All right. Good morning. So it's me, Dr. Jenny, physical therapist and doctor of physical therapist. It's my privilege and great opportunity to be your host for our Innovator Summit 2024. I believe this is our second Innovator Summit. We have outstanding Innovator Summit last year. And our goal is just to show you what are the different innovations we have now in rehab world, right? So I'm a physical therapist and I met and encounter in different CSM conventions and of course along the lines in different setting, you have amazing different gadgets, technologies, and you met amazing people that they have this kind of technology and this will be very helpful for our practice, right? So there are good for vestibular rehab, stroke, those robotics. AI now is very famous, and then what are the different EMRs that is very helpful for our practice as well, and so on and so forth. And some of those will be here tonight, all right? So, but tonight for you guys and today in our in our place right now. All right. So let me share. Let me see first. I will share first here. Okay, I can see already our speaker. Nice to see you, Alina. All right, see. Okay, let me share first what can you see? Can you see already my presentation?
Yes.
Okay, all right. And then I'll just show the basic that what we will have. All right, so this will be our program. So welcome. So in behalf of Fishgen PT and Wellness, it's me. I will be your host, and this will be for 2024. And for our first speaker, and you know me, some of you know me already. I'm a board specialist in geriatric physical therapy. I'm the previous vice chair of Global Health in Aging Adult. I'm the founder of Balance and Falls support group in aging adults. And if you have Facebook, try to look for us in Balance and Falls. That way you will know what are the different webinars and different topics that we have. Articles are amazing there, and we have different highlights, and the president of Fishgen PT and Wellness. All right. And I am a geriatric physical therapy and certified exercise expert in aging adults. So for today, we have the first morning and then later in the afternoon, we have Dr. Helena Esmond as the first speaker. She will talk more about the different diagnoses of vertigo and followed by Dr. Mike Studer. And then later on, we have amazing technologies from Ian Katz from Copa Healthcare and Ed Wilborn. And it will be ended up the half part this morning with Mark Evin. He's based in Canada and learning more about LudoFit. Okay. All right. And later in the afternoon, after lunch, we have a short break for lunch. We will have Todd Gilbertson from the balance shooter, and then Sheila will show us that the brain should be shaken and brain boost using vestibular training, and Stephen will give us some feedbacks of what are the AI or EMR right now. And we will be closed by amazing Dr. Mike Chua, learning more about what is an innovator and what is a mentor. All right, so let me give the floor to Dr. Helena. Dr. Helena specializes in treating patients with neurologic and balance and vestibular conditions. She earned a psychology degree from Northwestern University and graduated cum laude from Marquette University's doctoral physical therapy program in 2005. After 8 years in acute care, she developed a vestibular program. Dr. Helena transitioned to outpatient care in 2014, gaining access to infrared video goggles that enhance her ability to treat complex vestibular cases. She achieved vestibular competency at Emory University in 2015, certification in cervicogenic disease in 2016, and became a neurologic clinical specialist in 2018. So that's very famous and very outstanding for us, the specialist here in America. We are different in specialization. We have neurologic, orthopedic and geriatric and more. But Dr. Helena will be focused and she specialized in neurologic. And just a side note, the vestibular and video goggles that you will learn more today is from the amazing brain of her amazing spouse. And then Patrick, and he's one of the board with us with the APTA. And she presented in numerous conferences, including Penn Medicine, Mind for Your Brain Conference, and of course, lots of volunteers. All right. Okay, I give the floor to Dr. Helena. All right, let me see if I can highlight you. And here. Welcome, Dr. Helena.
Thank you. Hello, good morning and afternoon, and everyone, wherever you are. And thank you
Yeah.
for joining us. And thank you, Dr. Jenny, for hosting this. You're always doing a wonderful job sharing information amongst clinicians and patients. And I think that's just really valuable. So we appreciate you.
Thank you. My pleasure. I give the floor to you. And we are, guys, if you have anything to ask or later in the presentation, you have the QA portion there to chat and I can guide you to ask those questions. If you want to talk for short, maybe I can allow you to talk if it's really a long explanation. And we have the chat room. Go ahead, Dr. Helena. Thank you so much.
Perfect. Yes. So I have the oh so not easy topic of differential diagnosis of vertigo today, and I only have about 40 minutes. So understand that this is not completely comprehensive. This is not a vestibular course. I'm going to have resources for those who are clinicians that would want more. Absolutely happy to support you there. But I'm going to kind of use some case examples and just try to cover some of the concepts for everyone so that we can grow. So I've been introduced. I am co-founder of Vestibular First, and we are today going to discuss primarily benign paroxysmal positional vertigo. We'll be defining that because that is the most common type of vertigo. So that is the one that people tend to talk about the most. We will briefly cover how to do some assessment, including use of visual fixation remove testing, which is using infrared video goggles, and we'll go through some practice cases with eye movements as part of the assessment, which are really key so that we can identify the diagnosis and therefore choose the proper treatment. And if you've ever had vestibular rehab and you said, well, I didn't work, it may be that you didn't have the right treatment. And this is not to judge any clinician out there who tried to help you. Vertigo is not always a simple thing. I'll be honest. It can be complicated. So, the goal is to try to learn more all the time. They're always doing more research so we can do our best job to help deal with these challenges. So we're going to start just really briefly with the anatomy to get everyone on the same page. I feel that's very important with these discussions. So what is the vestibular system? We primarily mean our peripheral inner ear balance sensor. So you see that little pink guy with the three canals. Here he is made bigger for us to see better. We have several educational tools available through Vestibular First for this reason to try to understand this little apparatus. In real life, it is not this big. It is actually very tiny, about half the size of a dime, and it lives as a neighbor to hearing structures. So when we look at this little guy, it's really just these three little canals in the center area near it. But that kind of curly Q looking snail thing, that's actually a hearing structure. So you can see that the vestibular apparatus and the hearing structures are very close neighbors. Now, that means that some issues will have hearing symptoms and dizziness or imbalance when we have problems in this area, but other times, if only the little sensor is affected and not the hearing structures, we might only have dizziness and imbalance, but not hearing symptoms. So this is, again, where you can have different presentations depending on what structures are being affected. And so when we think about the different parts of the ear, the part that we all know and love is on the outside. That's our outer ear. Um, and that part is, really cool to look at, but it doesn't help us with hearing or balance at all. Well, it does bring in the sound a little bit. We should give it some credit. But the middle ear is where those little tiny bones for hearing live, and it's the inner ear that's embedded in the bone on the side of our head, the temporal bone, where we have this vestibular apparatus and some of these other hearing structures. So let's talk a little more about this little guy. So we have a few different sensors to help us sense up and down movement, lateral movement. Those are the otolith organs, or utricle and saccule, little collections of cells, have a really important job. And then our semicircular canals. So they're going to be really important to this discussion. So let's be familiar with them. Anterior goes up, like at the St. Louis Arch. Horizontal is roughly parallel with the ground when we're standing up, and the posterior canal kind of tilts back. And so we have this kind of apparatus designed this way. I believe that whoever designed it, or if it was just luck and evolution, but somehow it developed the ability to sense direction of different motions. Are we rotating? Am I leaned over? Where am I in space? And the brain really likes to know where we are in space to keep us safe so we don't fall and things like that. And when we talk about specifically problems with the inner ear, it's important to know some of these kind of more intricate structures within the canal. So you can see there's a membrane here called the cupula. Um, I call it like a trampoline. It's attached all the way around. And we have a cupula at the end of each of our three canals. And those cupula live inside this kind of lumpy area of the canal called the ampulla. And then we have what's called the long arm, this kind of big, long, curvy tube. Okay. And then we have what's called the short arm of the canal, which is just this little space in here, but it is its own space. Now there's openings in between this short arm and this kind of center area. This is where the utricle is, just as a reminder. But nothing can pass through the cupula unless there was significant damage to this structure. But otherwise, that cupula blocks things. And this is a good thing because it provides it with the ability to function, but it also can be a challenge when we're talking about certain conditions to try to treat. And then where the anterior canal and the posterior canal meet in kind of a common tube, that's called the common crus. Crus like cross, we all know that word, right? So you say, Helena, right out the gate, you're hitting me with anatomy. But if we don't understand the anatomy of the system, it'd be very difficult to treat it properly. So this is why I'm waking you up at, for those of us who it's early, for those of us who it's later, that's better for you. So what is BPPV? So this, again, the most common cause of vertigo in patients, especially adults. Um, the initials are as follows: B for benign. So even though it can feel terrible to have this condition, because when these crystals, go out of place, we're going to talk about that in a second. You can feel a lot of symptoms with this condition, but it's not a tumor. It's not something like a stroke. It's not going to significantly harm you unless you fall and get hurt. But it feels not good, right? It can feel like you're spinning, very off balance, things like that. But in a sense of seriousness to the body, it's considered benign. And then paroxysmal means that you can feel the symptoms suddenly. And sometimes these symptoms will recur, unfortunately. And you will feel these symptoms with a change in position typically. So a big report is I was turning over in bed and then the room started spinning, or I went to sit up and I started feeling off balance, and I went down to put on my sock and I started spinning again. So these are the kind of the most common reports of this condition. And then this vertigo word, this V in the BPPV, it typically means folks will feel a sense of self-movement, or again, the room might be spinning, something like that. But I will tell you that many patients who have BPPV do not feel BPPV this way, unfortunately. So it's a little bit of a misnomer in my mind, because people say vertigo and they think it's always spinning. But unfortunately, the descriptors of symptoms are not always clear cut. And we really have to look at our physical exam to figure out if this is what's going on to cause this patient to have some sort of symptom, or is there something else going on that we need to address. So the big kind of description of BPV that I like to give is the crystals are out of place. And you say, whoa, Helena, this sounds a little odd. What do you mean crystals? Well, in that anatomy, I'm going to go back to one of my earlier slides. You can see this little picture here. These are crystals out of place. Where are they supposed to be, you say? They're supposed to be in the middle in what's called the utricle here. So I mentioned the utricle briefly, and both the utricle and saccule actually have crystals that are embedded in a gel, and they help us sense gravity in a nutshell. So these crystals are supposed to be there, but they're supposed to stay in place. Sometimes they will break loose and they will float in the fluid that fills this whole system, and they will kind of sneak their way into one of these three canals, or sometimes more than one canal, unfortunately. So when that happens, the person might turn in bed or whatnot, they move, the crystals will shift in that canal where they don't belong. And that creates movement of the fluid in the system, stimulates that membrane, that cupula, and it makes the person feel like they're moving a lot more than they actually are. So it's a false sense of movement. They might even get nauseous with it, and they might throw up. So this is what we see with this condition sometimes. So the treatment is what attracts a lot of people to vestibular rehab as clinicians, because if you do it right and you put those crystals back where they belong, the person can feel better pretty quickly, and that's really cool. So I like to say it makes the clinicians feel like they're the magician, like, oh, magically I fixed you. And there's not a lot of things in rehabilitation that are a quicker fix. So this is a very attractive thing to want to fix if it's present. So what canals can be affected? The answer is any of them, but most common is the posterior canal. A close second is the horizontal canal, and a distant third is the anterior canal. And sometimes it's really a tough case to figure out. So in this study that we pulled this data from, which was on like 4,000 or 5,000 patients, there was some that it was just not able to be clearly defined. But the majority are going to be your posterior canal. And that is what I'm going to focus on today. I am not saying that the horizontal canal is unimportant, however, but I don't have time to cover both. So I picked one. And if you want to learn more, again, I'll have resources for you for how to assess and treat the horizontal canal properly. So when we talk about these crystals, sometimes they're floating and sometimes they get stuck. So we have different terms for that. They're big, long terms. So canalithiasis is the term we'll use for floating. Otoconia, they're kind of in a canal. And cupulolithiasis means they're stuck. Now, they might be stuck to that membrane itself, like rocks glued to a trampoline, or they might actually get stuck like a clogged pipe. So they might kind of jam the canal. And it's not always clear which is happening, but as long as we free them and get them back where they belong, it's fine either way. So we just got to figure out how to get them back. And that's the important part, wherever they're stuck. So I want to point out here that I mentioned that a lot of patients will feel like they're spinning, off balance, but some patients actually have very little symptoms except perhaps falls. And so if I have a patient come into my clinic and they tell me they've been falling and they don't really know why, I always screen for BPPV. They do not have to say they're dizzy. They do not have to say they feel like they're spinning. That is not necessary for BPPV to be present. And we should be checking for this because it doesn't take long to check for it. And if you catch it and you treat it, that decreases the risk of falls by 64%. That's a very powerful number for a very immediate improvement in balance. So recent literature led by Sue Whitney and her team of researchers have found that experts recommend that all older adults more than 60 years old with objective, meaning I can measure it with a balance test, or subjective, I feel off balance, problems, regardless of their symptom complaint. Doesn't matter if they say they're dizzy or have spinning. They should all be positionally tested to examine for BPPV. This is the recommendation. So I'm pretty passionate about this because it's a powerful thing. And what's tricky about this condition is it can come and go. So you could come into my clinic today, you're feeling off balance. I check you for BPPV. I find it. I put the crystals back where they belong with some head and body movements. And then 2 months later, you're feeling it again. Or a year later, you're feeling it again. You need to go back and go to see not necessarily me, but someone who's like me, who's trained, someone who knows how to check for BPPV, check it and treat it if it's present. Very, very important. So we don't get unnecessary falls that can lead to injury, broken hips, things like that that we worry about. And they've actually found that amongst community dwelling people over the age of 65, they just took a big group of them. None of them said they were dizzy, and about 9% were found to have BPPV. That's, 1 in 10 roughly. So that's a pretty big number of people that aren't even complaining of dizziness or vertigo. And then you've got your group that are, and lots of those folks have BPV as well. So we really want to be checking for this. All right. You guys are doing great. All right. So how do I know where the crystals are out of place, you say, Helena? Well, we have tests for that. And one thing that we're looking for is an eye movement, a special eye movement called nystagmus. So nystagmus is an eye movement that has a quick component and a slow component. So again, this is going to be, if you're brand new to this concept, don't feel like you have to learn all this now. I'm going to give you courses to attend. You're going to need more, I can tell you, but this is just giving you a sense of it. So the eyes will do certain eye movements, tell me that the crystals are out of place, and the direction of the eye movements tell me which canal, right? Because I don't just want to be treating every canal. That's silly. So we're going to test, let's say, the posterior canal, and I'll show you that test in a second here. And then you're going to look for a characteristic eye movement that says, yep, they're out of place on that right posterior canal or what have you, versus testing the horizontal canal. You're going to get different eye movement if there's crystals out of place there. And so here is kind of a summary. I'm big into summary charts on where could the crystals be out of place and what type of nystagmus I would be looking for. So posterior canal versus anterior canal versus horizontal canal. And remember, it can be floating or stuck, and that can affect how the nystagmus presents as well. So I'm not going to get all in the weeds here because, again, this is a vestibular course that we need to really learn this. Okay? What's that, Jenny? Dr. Jenny?
Sorry, I'm just putting my what is kind of torsion
Oh
and
yes, all the nystagmuses. I know,
yeah,
right?
I'm
There's
sure.
so many. There's so many. I'm going to show you some videos because videos are worth 1,000 pictures or me moving my finger to show the nystagmus. But you're totally right, Dr. Jenny. The eyes
Yeah.
do dance. Some people call it like a dance
I'm
that they
reviewing
can do.
myself, that's why. Sorry.
I love that. I love that. Everybody review like Dr. Jenny. All right. So the eyes move because we have muscles attached to our eyes and because there's a strong relationship between the eyes and the vestibular system. And this is called a vestibulo-ocular reflex. So it's a really cool neurologic reflex that allows us, when everything is normal, to keep my eyes on something, even though I'm moving my head all around. So really, my eyes and my inner ear have to work as a team not only for balance, but to stabilize my gaze. So this kind of important relationship that we rely upon because when there's something wrong with the vestibular system, we get these funny eye movements. And because the vestibular system lives deep in the inner ear, you can't just take a picture of it with an MRI and know that there's crystals out. It's not like that. And remember, the crystals are super tiny. They're like microscopic. So that makes it tough too, because you got to figure if the structure is only half the size of a dime, the crystals are like smaller than a thread of your hair. You wouldn't be able to see them without a microscope if you had them in front of you. So when we talk about looking at eye movements to help us diagnose BPPV or other vestibular issues, it's always in relation to I'm facing the patient. It's the patient's right or the patient's left or the patient's up or the patient's torsion to the right or left. So we have to kind of reverse it in our mind, and that takes practice. Once you get good at it, it's like automatic. But in the beginning, you might need to kind of label it for yourself. I have put post-it notes on my screen of my computer before. Goggles have them sometimes already labeled, so you know which one is the person's left or right eye. So you know it was a left bead and not a right bead or what have you. So here's an example of an eye movement we might see for nystagmus in a right posterior canal. So this is considered right up torsional. You can see there's kind of a rotational component, like a clockwise, counterclockwise type idea, as well as a little bit of upbeat, as well as kind of pulling a little bit to the right. And we can even use gaze to help us really clarify if there's an upbeat component and if there's a right pull a little bit. So that can help us with our diagnostics. So I have superimposed, well, I'll give Patrick, my husband, co-founder and technical guru, credit here. He has superimposed a crosshair just to help us see better that this is a real patient's eye that's having some right up torsion, which is a common presentation for someone with right posterior canal, BPPV, where those crystals are out of place in that right posterior canal. So how do we figure this out in detail? Well, Helena, wait a minute. There's all these other conditions that aren't BPPV. I know, but I don't have a day or 2 days. I only have 40 minutes. So I just want to give you kind of some common ones here listed. And know that asking questions can help. So for BPPV, just as an example, I can't read this whole chart out, but just for BPPV, if the person really feels symptoms turning in bed, That's a high likelihood, not a definite, but it's a high likelihood of BPPV. You can see this big orange chunk here. All right, and that proves out true again and again as you go further down um, and see again if they have dizziness turning in bed. High likelihood, not a guarantee, but high likelihood they have BPPV. So this is just a way to kind of look at how asking the right questions might help us figure out a diagnosis. Now, we still want to do our physical exam, but it's good to know the answers to some of these questions. So this is a nice study done by Strobel et al. That you guys can check out if you want to learn more. Now, I'm not going to read this chart out to you either, but I want to let you know that if you think a person might have damage to their vestibular nerve on one side or both, which would be a unilateral or bilateral vestibulopathy or hypofunction, there are some tests that you should learn, if you don't know them already, to help you identify that as a likely issue. Whereas someone, if it has Meniere's disease, which is intermittent swelling of the inner ear, they absolutely need a hearing test because in order to meet the diagnostic criteria, you must have low to mid frequency, a very specific kind of hearing loss in order to fit that criteria. And there are diagnostic criteria for many of these other conditions, as you can see. So again, this is not a 2-day course or a week-long course, but at least it gives you a sense of how might, as a patient or as a clinician, might I start to figure out what's the cause of my vertigo? This is what differential diagnosis means. What's the cause? And bad news is sometimes two of these conditions are present at the same time. So that makes it even a little bit stickier, right? So in fact, vestibular migraine is an example, which is a type of migraine that is less about headache and much more about dizziness. So the patient may have very little headache issue, actually. I know people sometimes think migraine just means headache, but actually can primarily mean dizziness. It's very common to get BPPV. It's a kind of a risk factor for BPPV to have vestibular migraine. So I might have someone coming in and it sounds like they have vestibular migraine based on the diagnostic criteria, but I'm still going to check them for BPPV because if that's there, I can treat that right away. And we still are going to do some ongoing medical management and vestibular rehab for the migraine component. So this is where our differential diagnosis, we need to think broadly, think about everything we're seeing and hearing and what makes sense. And it may not be that we figured out in the first session. So don't feel bad about that as a clinician. It can take time for some of these conditions to really show themselves over time with pattern. So we look for that. So let's go back to BPV because that's our easy fix. So it's easy to talk about compared to some of the others, but it can get tricky. So the clinical practice guidelines by Bhattacharya et al. In 2017 still stand strong. And they highly recommend checking both posterior and horizontal canals. I mean, you're going to check anterior canal as you're checking posterior canal. Just don't think we're neglecting anterior canal. But remember, that's really rare. So we're really focusing on these two as our primary likely culprits. And you can see here on our right, this is the common test for the horizontal canal is this supine roll test. We're turning the head gently to the right or left. And if you don't have neck range of motion, you can just roll the body. So there's always ways to accommodate this testing. There's very few reasons why we can't do it. And sometimes if someone's medically unstable, we would wait. But there's certainly lots of opportunity, even if there's limited neck range of motion, to test for these. Some of you, as clinicians or patients, may have heard of something called meclizine. It is the most common vestibular suppressant given. I compare it to pain medicine. I have a broken arm. Here's your pain medicine so it doesn't hurt so much. Does that heal my arm? No. So meclizine is not a bad thing, but it actually is not the best treatment for something like BPPV. They do not recommend that that be prescribed, that we really should be doing maneuvers and clearing these crystals. And actually, even if someone has something like damage to the inner ear, that vestibular neuritis, vestibulopathy, if we give meclizine for more than a couple days, it actually blocks the ability of the brain to help take over the job of the inner ear that was damaged. So meclizine is not a bad thing, but it's really not something that we should be taking long term. So if you're a patient on that, I'm not saying get off of it. I'm saying talk to your doctor and hopefully have a vestibular specialist that you're working with to see if we can kind of have other treatments that are appropriate to address your dizziness aside from the meclizine, which may or may not really be helping, to be honest. Also, it is important, according to the guidelines, for clinicians to feel comfortable differentiating positional vertigo, that BPPV, from general inner ear issues like a vestibulopathy or Meniere's disease, from brain problems like vestibular migraine being one example. So we really need to make sure that we're not just treating every vertigo and every positional vertigo. Oh, it's definitely BPV. No, we have to do our exam, do maneuvers. If the maneuvers are not changing the symptoms and the nystagmus that we're seeing, it's not BPPV. So that's one of the things we have to think about is this responding to treatment? Because there's unfortunately stories of patients who have had repositioning maneuvers once or twice a week for 6 months. That is not appropriate. There's something else going on if that's not resolving your symptoms, or the maneuvers are not the right ones for your BPV, I suppose. But you really need to be kind of taking a second look. So I'm just going to spend 1 or 2 slides on goggles. So this is really an essential tool because unfortunately, you lose about 2/3 of the abnormal eye movements in someone with vestibular pathology of any kind, including BPPV, if you're not blocking light. So what the goggles do is they're dark inside. So the clinician will put the goggles on. It's dark to the patient. There's infrared cameras inside so that the clinician can still see the eye. You can see there's kind of a display because the goggles are attached to a computer so that we can see, is the eye moving? What direction is it moving? And how is the eye moving in different ways depending on where I've put the head, where I've put the body, would I shake it and then stop? What happens? These are certain specific tests that we're looking at to help with the diagnostics. So the good news is these used to be very expensive, but Vestibular First, one of our missions is to make them affordable. So they're currently priced at $2,600. That's, in end of 2024. So we're really trying to keep that price as close to that as we can in the future, but we'll see what we need to do from a practical perspective. But ultimately, the other ones that are out there are $10,000 to $20,000. So we're really trying to keep them affordable. This is my mission because I believe that every person should be checked for BPPV. So we need lots of clinicians who know how to do it, but then all of those clinicians should have the right tools, or they can't do their best job. They're guessing, they're missing things, and then we're not able to help these patients properly, reducing the risk for falls, things like that. So this is what we want to be able to do. And there are experts in the field, it's not just me, that state this very clearly, particularly when you're looking for a peripheral nystagmus, so that would be BPV or a hypofunction. These types of nystagmus can suppress in room light. So they feel that, quote unquote, nystagmus goggles are essential for any clinician dealing with dizzy patients. So if you don't know who Dr. Michael Hamagi is, he's a fantastic ENT physician out in Australia, and he's been studying the vestibular system well longer than I've been alive, and I'm not super young. So yeah, he's been doing it a long time. Um, so what does BPV look like? You say like, okay, I feel dizzy when you turn in bed. Okay, that's fine. But there's more to that. We got to look at the nystagmus. So the nystagmus should be provocable with our positional tests. The nystagmus should occur and kind of crescendo and then decrescendo. Okay, so if it's just like a constant mild nystagmus, that might be the brain talking, or an old hypofunction or something like that. So we want to differentiate, are we getting that crescendo, decrescendo? And if we try treatment and then we retest after a rest and we've resolved the nystagmus after a few rounds, great. If they still feel a little off balance, they might need a little bit of vestibular rehab to desensitize to motion or some balance training. That's appropriate in the literature. If we don't change that nystagmus at all after 3 to 5 good rounds of treatment, and that's like a full session where I'll probably at least do 3 or 4 maneuvers if I have time, then I need to be referring back. We really need to be kind of making sure we're not mistaking a nystagmus as BPPV when really it's a tumor. I mean, that's rare, thank goodness, but we don't want to just jump that everything that we see during a positional test is not necessarily BPV, is what I'm saying. So we're just kind of reminding ourselves of that as we go. So how do we test for it? The most popular test, been around a long time, the Dix-Hallpike, fantastic. Turn the patient's head toward the side you want to test, about 45 degrees, lay them back. This can be modified with pillows and other things if the patient doesn't have a lot of neck range of motion, no problem. And we're just trying to get the head in this kind of little bit of extended or rotated type position. And we're watching for a nystagmus that comes and goes. Or it might just kind of get really strong and then kind of just stay there. If it's stuck, then you might kind of see a persistent little bit of nystagmus that can happen as well. And then we look for any symptoms that are associated, which, most of the time there will be, but sometimes remember that patient may not feel it at all. It's called vestibular agnosia. It's a fancy term. And it just means the patient will be like, I don't feel anything. And the eyes are doing this. And then they stop and you're like, well, that's acting like BPV. Let me try to treat that and see what happens when I do a proper maneuver. Do I clear that nystagmus or does it stay? So recently in the literature, for those who are clinicians, there is a way to increase the sensitivity. So increase the accuracy of your testing. In addition to using visual fixation removed or with the goggles, we can load the Dix-Hallpike. So this comes out of research with Jeff Walter, who's a fantastic vestibular educator and clinician and researcher in his group. And so you basically turn the head towards the affected side, just like the regular Dix-Hallpike, but you want to tuck that chin towards the chest about 30 degrees if they have the range. And you're going to leave them in that position for 30 seconds. And what that's doing is it's basically dropping any crystals that are out of place in the posterior canal or anterior canal kind of forward into a clump. So then when you go into this extension, you're going to drop that big clump and you're going to get a nice burst of nystagmus. So do not use this if the patient is coming in and I'm like, I'm so nauseous, I've already thrown up. You don't need to load those people. But anybody who's, maybe like, oh, it was really bad the other day, but now it seems like it's getting better. Maybe they only have a little bit of crystals left. Absolutely load those folks. All right, so a little tip for you, load the Dix-Hallpike for most of your patients. I found it to be very successful in my practice. All right, so how do you tell if it's floating or stuck in the canal? Because again, that's going to change your treatment choice. If it's floating, the nystagmus will last less than a minute, and the symptoms will probably be lasting about as long as you see the nystagmus is typical. So you're doing this Dix-Hallpike test, you look for that nystagmus, the lasting less than a minute, and it's like torsional and upbeat towards the affected side. So this chart is giving a left-sided example. We think it's left floating. If it looks like a downbeat with a little bit of torsion or a straight downbeat, but it still comes and goes, it could be either in the anterior canal, which remember is really rare, but it does exist. We know it does, 2% of cases, or it can be that short arm. Remember I said there's a little piece on the other side of the cupula of the posterior canal? Sometimes the nystagmus will be downbeat because it's in that little area, and that has to do with the way the cupula is getting pulled. But we don't have to get into that. Just trust me on this one. I've read the literature. So if you see a downbeat that's short in duration, it still could be PPPV. So we want to at least try to treat that. And then if we don't change it at all with maneuvers, we might think, oh, maybe this is brain talking and there's something else going on, like vestibular migraine can create a downbeat as well. All right. Now, if it's stuck, the nystagmus will last more than a minute, and it'll probably just keep kind of beating a little bit consistently. So you see my example here, very similar. Now, the answer for can it get stuck in the anterior canal? Nobody's proven that. They think it's either exceedingly rare or it might not exist. So if you see a downbeat that lasts and lasts and lasts, suspect the brain, because almost always there's something going on, whether it's a lesion in the cerebellum from an old stroke, or it's somebody who has vestibular migraine or some other brain issue that's causing that nystagmus. So just keep that in mind, that it's very rare to have it stuck in the anterior canal. So that persistent downbeat would be rare. All right, so here's our classic. I promised you videos. Here's a classic left posterior canal test. So we're doing the Dix-Hallpike. And credit to our people that made this video. So we're doing a turn to the left. We're going to bring this patient back with a little bit of neck extension. And inside the goggles, what's happening? On both eyes, it's doing this. So the patient's like, oh, I feel it. And you see that nice line on the iris. You can really see how there's this brisk left torsion. And you're like, left? Yes, it's the patient's left. Lest us not forget. So that would be a very classic presentation of someone with left posterior canal because it came and then it slowed down and then it stopped. Right, so those crystals shifted, we got that movement, and then they were done shifting, and so they settled. Now, the most popular treatment, been around the longest, is the epley. And so the epley, you're going to have the patient turn their head, lay back into the Dix-Hallpike, and then you turn their head 90 degrees away from the affected side. You have them roll over, nose down, and then you have them sit up, and you're going to do a minute or two in each of these positions. So again, this is something you can learn in a course, so we're not going to be able to physically practice it right now, but just understand that there are common treatments here, and there's always science happening. So they've actually found that if you modify the position on the third position with the nose down to more rotation than they used to do, you can get a better result. So this is the cool thing about science, is that even something as classic as the epley doing it a little bit differently can get a better result they're finding with science over time. So keep that in mind. And, don't get frustrated. If it's not responding to maneuvers, maybe you need to modify what you're doing. Don't just keep doing it the same way multiple rounds. That is not a good plan. If you do one round and you got it cleared, great. You do a round and you didn't get any change, try it differently or try a Samant, which is another treatment. There's something new out there called the Diaz. I mean, you got so many choices. All right, so let's look at this patient. They're in a Dix Hall and they're getting a downbeat. So you're saying to yourself, is this anterior canal? Is this the short arm posterior canal? Possibilities. Okay. So if it's in that short arm, again, we can get this downbeat. And that's what we suspect with this patient because they responded to a treatment called the Pascal. This is brand new. This actually is not even published yet. This came out of the Baronese Society meeting that they had in August. So I pulled it for you guys. I put this here. You don't have to memorize it right now. I'll make sure all these slides are available. But understand that there's a cool new maneuver. If you see that downbeat, you could try this maneuver to see if that'll clear these kind of more stubborn cases. When it's caught in that short arm, it can be really hard to get out. Dr. Jenny, you got something? Doing good?
Yes. Mm-hmm.
Good. All right. So here's another patient example. Now this patient is presenting, I'm treating her right, or I'm assessing her right side. So I've got her in the right sixth hall pike. She gets a nice brisk right torsional upbeat nystagmus, pretty classic right posterior canal presentation. But I did maneuver her. I tried the standard modified Epley, even with that little extra head turned down, like I just showed you, didn't clear it. I tried what's called the Samant, which I'm about to show you. And that didn't clear it either. So this is the Samant. You lay them. It's kind of like the Pascal, but a little bit differently because you reverse which one goes first. But anyway, I tried the Samant, which is a very classic maneuver also, in case they're stuck. This could be really helpful. Didn't clear it. So I'm like, all right, this is it's acting like regular posterior canal, but it's being stubborn. So if it's being stubborn, we've found that sometimes bringing them into full extension with the deep head hang can help free them where they're kind of getting caught or stuck on one of the edges of the canal somewhere. Even though it looks like they're just kind of floating, maybe they're a little bit stuck too. We might have to really get a lot of neck extension and really drop the crystals. So I think if you could take something home from this whole talk, it's don't just keep doing the Epley. Try the Epley. If it works, great. If it doesn't, go to plan B, C, D, and E. There are options. And if it's not clearing with any of those, think about the fact that it might not be BBB. This is what we need to do for our patients instead of kind of, oh, I went to this, clinician and they did 60 Epleys. Like, no, that ain't it. Something's not right if we're not clearing it with that. All right, so we can use this deep head hang, convert it. They think what's happening is sometimes it's caught in the short arm and it'll drop down and it'll convert into long arm. And then we can do a modified Epley right after the deep head hang and then we'll clear it. And actually that worked really well for that lady I just showed you that didn't clear with our classic maneuver pattern that I usually do. And there's another one out there that Ludwig and Schubert found. I mean, they didn't design the maneuver, but they found that it cleared this kind of stubborn case. It's called a demi-Samant. So we have so many choices. And if you ever see a nystagmus and you're like, this looks like maybe it's stuck in the short arm, right? This is our kind of our downbeat nystagmus here. Oh, that's so dark. I'm sorry. Anyway, there's a downbeat going on here. So I'm saying to myself, this isn't really acting like it's going to clear. Why do we have this downbeat? I tried a maneuver or two. I even tried something fancy like the demi-Samant, nothing. Let's make sure we're always going back to, does it reduce with fixation? So this is turning on the fixation lights in our goggles. Another really helpful piece of the goggles is that you have these little lights inside that you can turn on. So you just flip these switches on the top and the lights come on. And if it's a nystagmus that's coming from the brain, that nystagmus probably won't diminish in strength. If it's a nystagmus that's coming from something like BPPV, that nystagmus will diminish or go away. So in that patient I just showed you, when I put in those lights, that downbeat that I thought maybe was like a short arm posterior canal, it didn't change that nystagmus. And now I'm like, ooh, now I'm suspicious for brain issue. And actually, in that particular case, like 12% of patients who get nystagmus with a positional test, they had a brain issue. And actually, she fit the criteria for vestibular migraine. So I was able to sort out that even though I was getting a nystagmus that I thought maybe was BPPV, it was actually vestibular migraine talking, I like to say. So again, going back to this, if we do 1 to 3 sessions of well-applied maneuvers for a simple case where I think it's just floating or it's just one canal, and that should clear. And if it doesn't change, I should go back and think, are they fitting any other criteria? Is there anything else going on that might be think this is not BBV, this is something else going on? Um, and if it's a tough case, multiple canals, or it's stuck, maybe it'll take me 3 to 5 sessions maximum. But after that, I should always be going back and thinking about, is it fitting the vestibular migraine criteria, for example? And she did fit those well. And so I referred her properly to a neurologist to get medical workup to make sure that we weren't thinking that it was migraine, but it was actually a tumor. It turned out it was just vestibular migraine, but they had to check that out. And then also give her medical management for the migraine piece, which again wasn't about a lot of headache. It was more about dizziness. And then we can work on lifestyle education to help reduce the recurrence of vestibular migraines and vestibular rehab for balance, neck care, gentle habituation to visual motion or self motion. All of these things are beyond the scope of the talk. So I've got tons of resources for you. You're like, Helena, I need more practice watching eye movements and figuring out what I'm seeing. Here's your slide. You're like, Helena, I need goggles. Get a demo. I got you covered. I'll take care of you. If you're like, Helena, I need courses. Tons of stuff we have coming out of vestibular first, differential diagnosis and atypical BBV coming out this January. We're going to have a 5-part series releasing throughout next year, which will be a novice ready to treat. So that'll be great for y'all. We're going to be doing some in-person courses come 2026. But if you're like, I don't want to wait for all that, there's other people. They're doing awesome teaching too. These are some of my favorites, really depending on what level of learner you're at. If you're like, I just want to know how to do an epi myself at home, well, maybe you should get somebody to check out, make sure you have PPP. But here are handouts available on our website, and for clinicians to give to patients if it's appropriate for them to do a home maneuver. Tons of educational resources for you as a patient, or if you're a clinician, you want to share these with the patient. Wonderful ways to learn more than what I have been able to cover in this talk. How do I find a vestibular PT near me or an expert in vestibular care? Here are your resources to find somebody. And we're working on Dizzy Care Network. It should be out the next year through Vestibular First to help match clinicians with patients because this is needed. And if you're like, I have vestibular migraine, or I think I do, I want to learn more, here's your resources. I got you covered. And this is me. So if you just want to reach out to me directly with questions or watch our free journal clubs on our YouTube channel, everything's available to you. I'm happy to help. Whew.
That's a that's a nice headdress as well, and then that's a rough like closing. That's wonderful. Lots of resources there, Helena. That's wonderful. Thank you so much. And I believe you said we can grab that PowerPoint. That way they can follow. And then I will be able to maybe highlights as well some of those resources. But if it is available in PowerPoint, definitely maybe they can hyperlink that as well, or they can.
Absolutely.
Ah, okay, good, good.
Yeah.
So because that lots of hyperlink there. We have a couple of questions, but that's amazing. PowerPoint, very nice. I keep taking pictures because it's really nice, all those diagrams. And sorry, I keep moving my
No, I
head.
love it. I love it.
I
As long as it's
distract you
helpful,
with.
that's all I care about. I just want to, help everybody to feel empowered because again,
Mhm,
vertigo can be tricky. So, whether it's a clinician or a patient, the
mhm.
more you know, the more you can hopefully do the right next step. What's the right next step for me? And that's what you're all out there figuring out. And so I'm happy to help guide you and I'm happy to answer questions. And then we're going to let Mike, I don't want to interrupt Dr. Studer. He's awesome and I don't want to cut out a minute of his time. So let's answer
Yeah, we have
questions.
QA here. Do you have access in the QA?
Yeah, so I'm just
Okay.
going to read them out. Can we
Mm-hmm.
use the universal maneuver if the diagnosis is clear? So universal maneuver is awesome. It's for either horizontal or posterior canal, as long as you know the side. It's a newer maneuver. So I didn't really cover it because it has less research on it yet, but I think it's worth a try, especially if you're not getting a result from some of the other more kind of well-studied maneuvers. So absolutely try that universal maneuver if you feel like you have a clear diagnosis. And how many repetitions of treatment can be done per session? That is about patient tolerance. And how much time do you get? So I get my patients for an hour. Let's say it's a follow-up visit. So the first day, I'm just figuring out what's going on. I only usually have time for 1 or 2 maneuvers at the most. Second time, let's say it's not cleared yet. I'll do a maneuver. I absolutely need to rest them 10 to 15 minutes. not just to let their symptoms settle, but so that we don't get a retest that's a false normal, because that your brain will try to suppress the eye movements if you keep testing like right away. So I wait 10 to 15 minutes. I'll test again. Still, I have seen nystagmus, and I think I haven't cleared it yet. I'm going to do a second maneuver if the patient's tolerating it at okay. And so the most I've ever done in a session is probably like 4 or 5 in a session. But that's really for a stubborn case, of course, or multiple canal, maybe something like that. So that'd be the maximum I would do. Hopefully that answers your question there, Mr. Rahman. And then we got a question on the Acavino for short arm, posterior canal, and for anterior. Yes, so the Acavino is the deep head hang. They have two names, like a lot of things in vestibular, unfortunately. So it is an appropriate treatment for either short arm or anterior canal as well. So great question from Cohen. I don't know, you're
Mhm.
Mr. or Mrs. Doesn't matter. You're a person. You're awesome. All right. Deja, I know, so I could say her name. Would you refer vestibular migraine patients to an audiologist or a neurologist? So, if I think they might have signs of Meniere's and I'm not sure, I would love for them to see an audiologist to get that hearing test just to kind of have that information. Even if their hearing is normal, if they keep having episodes and they kind of notice some hearing changes, and then we do another hearing test like 6 months or a year later and we see that low to mid frequency hearing loss, what we thought was vestibular migraine might have been Meniere's, because they can definitely mimic each other. We actually have a whole course on that just because they're so complicated. They can really mimic each other. And some people have vestibular migraine and Meniere's, which isn't cool either. So definitely, if they're describing hearing symptoms, get at least one hearing test. Otherwise, if it's just more purely a headache, dizziness, I'm pointing right to. Usually, it's a neurologist. Some ENTs actually specialize in vestibular migraine as well. So it's not as much about discipline as like who's comfortable treating vestibular migraine, because not every neurologist is. So you got to kind of try to find the people in your area or refer to somebody like Shinbei who will see people doing a telehealth. That was on my list. All right, I think I hit all the questions.
Yeah. Yes, we have the webinar chat, so you can put it on the QA chat and the webinar chat as well. Thank you so much. That's lots of informations. Thank you for sharing the new evidence and articles that was outside nowadays. I took picture because the diagram really are very helpful in the position. So those
Yes.
positioning are very important and very sensitive for us to really rule out something and also to perform the test nicely and perfectly, right? Although it's not really perfect, but we just want to get those symptoms. And then those resources will help us a lot to build more confidence to learn more. Because as what I've said, I really always want to have vestibular rehab in all my summits, either geriatric rehab and innovator, because we have less clinicians more confident enough in vestibular rehab, but at the back of their mind I really want to. That's why I always want to invite our you guys vestibular rehab. Even we have lots of dizziness with our previous speakers as well, American Institute, and we always love to learn more from different clinicians. So thank you so much for this. Any closing remarks? You already said the resources, and then kindly put there, Helena, where they can find you, or at least an email,
Oh,
all
of
right?
course, of course. I'll put
Thank
my email
you.
into the webinar chat. Okay.
All
And
right,
thank you,
guys.
everyone. And right to Dr. Studer, because he's awesome. I don't want to take a minute of his time. You want to hear everything he has to say. He's brilliant. But thank you guys for having me.
My pleasure. Thank you, guys. All right. Thank you, Helena. So let me share our next. This is the share, right? That's only the first one. And then I learned a lot already. So that's Dr. Helena. So for our next speaker, we have Dr. Mike. So this will be is going to highlight the Marbles Brain Body Fitness. So Marbles Brain Body Fitness is a one-of-a-kind brain fit first fitness franchise that leverages innovative dual tasking technologies to deliver customized programming in a fun, supportive environment. So it helps to reduce Alzheimer's prevalence with evidence-based exercises and technologies accessible nationwide. So Dr. Mike will go in to discuss more about this and then the different innovations like the Smart Fit and other devices there later. Okay. And here, so for our Next speaker, Dr. Mike Studer is a doctor of physical therapist, master of health and science, and also clinical specialist in neurology. He's a certified exercise expert as well, and he is a fellow of the APTA. So he has lots of speaker events, and he's a physical therapist since 1991 and 1995 when he became the certified in neurologic physical therapy. He's a private practice owner since 2005, and Dr. Struder has been invited speaker covering 50 states, 10 countries, and 4 continents, speaking on topics ranging from cognition and psychology in rehab, aging, stroke, motor learning, motivation in rehab, balance and dizziness, neuropathy, and Parkinson's disease. Dr. Mike is the co-owner of Spark Rehab and Wellness, a multidisciplinary health, aging, and neurology rehab clinic, also in Bend. He is a consultant to Major League Baseball on the motor control of pitching and hitting. As a very fun and lighthearted note, Dr. Mike is a four-time and current world record holder for the fastest underwater treadmill marathon. A mark was set most recently in January 2022. So I remember when I interviewed Dr. Mike Suter, he is walking in his treadmill while doing the interview, and nobody does that usually. And then that's really just amazing. He can multitasking. That's why he's doing these things to us, dual tasking. All right. So he provided us a wonderful webinar today. He's speaking in another state, and then he saved this wonderful, almost like more than an hour video for us. And let's see. And here, welcome, Dr. Mike. Mhm.
Hello and welcome. My name is Mike Studer, and I'll be your host for today's presentation, The Neuroplasticity of Cognition. And that truly means how we learn, how we make connections to stimulate and improve our cognitive functions. So the why is clear. We all know that we want to have preserved cognitive abilities throughout life. The how has always been in question, but now I can tell you the how is here. All right, so again, just very briefly, my name is Mike Studer, physical therapist as a background and have been since 1991. I'm board certified as a neurologic clinical specialist. I've lectured as an invited speaker throughout the world, all 50 states, published author, clinician, but most importantly, I've got more than 25,000 patients that I've seen over my career and building. Still an author, clinician, academician, adjunct faculty, researcher, etc. I'm here today to give you the science and the applications. My contact information, if you need more from me after you've watched this live or viewed it in recording, please do not hesitate to contact me using the mechanisms below. I will tell you that I'm an authority on this topic, and you will also see that I am an author. Down below, you'll see my latest book, The Brain That Chooses Itself. Now, let's get started talking about what we will be covering today. The course description is here for you. We're going to really talk about how to improve cognition in a preventative and also rehabilitative manner in persons that are aging. That should be you and I. We're all getting older at 1 second at a time, 1 day at a time, but also persons recovering and rehabilitating from the conditions you see down at the bottom: stroke, multiple sclerosis, Parkinson's disease, mild cognitive impairment, concussion, and Alzheimer's disease. Those conditions will be covered specifically. We don't need to spend much time on the course objectives because you and I both know you have signed up for this. You've attended this with your own intent, and you also looked into the course information and peripherals to do that. We're going to really talk about what cognition is, how to improve it, and the applications therein. So a few disclosures. I am also a consultant for SmartFit, which you'll see today in the course, DVDOT, and also Blue Goji. But I'm also a consultant for Major League Baseball, and of course, our primary theme today, Marbles, the Brain Gym. Now, I am an author of the upcoming book, The Brain That Chooses Itself. If you want to look into that a little bit more, you can. That is also about lifespan and health span. The timeline, what are we going to cover today? Well, we've done our introductions. Next, we're going to debunk the myths that aging has associated with it. Well, after that, we'll talk about the mechanisms and physiology without really being highbrow and technical and sciencey about cognition. How does the brain improve cognition, rehabilitative and prehabilitative or preventative and wellness? Then after that, we're going to talk about patient engagement in cognition. How do you get someone that you want to help improve their cognition to be interested in that? And finally, we'll cover the action steps, cognitive health and wellness programming, and we'll address a few frequently asked questions along the way. In the main section, number 1, defining and debunking the myths of cognition with aging, we see that one of the main things that we need to debunk is there's nothing that can be done about it. That's not true and is no longer true. And this is our main repository for that. You'll see over here on the right-hand side, we are talking about actually having something that's known as the brain gym. Yes, this is the inside of a marbles facility. You'll see the wall very clearly marked, and also plenty of room with the latest equipment. Time to think and move, and that's our DVDOT. Time for gameplay with the blue goji, cyber cycles, and time to get warmed up. There's a lot of science that helps us understand we benefit best when we increase blood flow. The brain gym off to the right, you'll actually see a wall of smart fit over and around, and that's just a portion of what you're seeing there. So first things first, it's time to debunk that nothing can be done about cognitive decline with aging. The second main point is that there has to be an obligatory cognitive decline with every person as they get older. That's not necessarily the case any longer. We're going to talk about the physiology of reducing the expected trajectory of cognitive decline with aging. Now, one big point on that is be efficient with your time, be intense with your time, and be purposeful with your time. So that's a really big 3 statements said there. Be intentional and efficient with your time, which means we're going to go straight into dual tasking, because dual tasking is the concurrent performance of working your body and your mind with challenges that are of a dosage that's therapeutic at the same time. Dual task. Think about that as body and mind both engaged, not on the same task, but on separate tasks that have to be suspended in operation together. We'll find out why that's important. So you could do cognitive stimulation or fitness directly. Just work on features of problem solving, remembering, trivia, rehearsing old memories, and recalling. And you can also do physical intervention by themselves. All 3 of these are evidence-based and can help with cognitive decline. Dual task being the most efficient, effective, and by research, certainly the superior element. Now, let's say a few statements here about dual task loss by diagnosis, because it can be easily misconstrued that everyone that is losing cognitive faculties loses it by the same diagnosis or the same process. Now, aging will have some losses in terms of dual tasks specifically because we lose conduction speed in our nerves, we lose a little bit of executive function, our ability to regulate attention. So we lose speed of our physical, plus we also lose speed of our reaction mental cognitive. That's a little bit different with Alzheimer's disease and mild cognitive impairment, where we actually lose a greater portion of working memory, holding and suspending things in short-term memory, cognitive reserves of actually being able to problem solve and being aware of our own actions. Concussion and traumatic brain injury are entirely different again. These are very diffuse injuries across the brain that will have different losses, but always attention and most always cognitive fatigue. Parkinson's disease, totally different again. Primary loss in attention because dopamine is necessary in the attention centers of the brain. But also, persons with Parkinson's disease lose their automatic access to move without thinking. That causes them to have to think more about their movement, which also borrows against cognitive reserves. In addition, dual task losses can be expected for persons with stroke. Losing motor control means you may have to spend more cognitive resources on operating your body. Multiple sclerosis, very similar, but also a loss in conduction speed and attention. Neuropathy, loss of sensation, loss of automatic access, and loss of our ability to conduct reaction speeds and balance sensations quickly. And finally, very similar, vestibulopathy. Rather than neuropathy, losing it from your feet, vestibulopathy, losing that sense of body awareness in relationship to gravity by way of the inner ears. I know we're moving quickly with this, and you'll also have these handouts if you want them. Remember, you can go back and look at the recording, and you can always contact me as well. I value your time and want to give you a lot of information. Let's look more deeply now at aging. We do understand that aging includes a nearly obligatory, should almost always happen, loss of processing speed that we can't change. That is the ability to transmit nerves from the body to the brain and from the brain to the body. We lose sensation, and that could be hearing, vision, and also senses from our vestibular apparatus of balance. We also lose attention there. That part can be arguably mitigated or influenced by what we can do as well. But all of those, if you lose all three, lead to fall risk being elevated when you're trying to move and you don't react as fast and the world is busy and you need to also be attentive to what's going on. Now, the quote here obviously is relevant. In aging and disease states, declines in sensory motor and cognitive functions may lead to reduced postural reserve. It doesn't take that much more for you to fall. You are very much close to the edge of function. And you also have a smaller amount of cognitive reserve because of your losses that experienced in this person's aging. This combination, postural reserve and cognitive reserves declining, creates an overall greater demand for attention to the task. That quote can be found by a very formidable author and a very important seminal paper, Tara McIsaac, in 2016. Let's move to our second segment where we discover the neuroplasticity of cognition and how to build adaptability, redundancy, confidence, and function. All right, so the facts on falls will begin there. You might not think that's relevant to cognition, but if we go back just a few minutes ago and we think about dual tasking, the ability to move, one task, and analyze, assess, witness, and avoid things that are happening in our environment, we have a secondary task there. Falls are directly related to losses in cognition by way of dual tasking. What's important about this is that 1 out of every 4 people over 65 fall at least once a year. Falls are the leading cause of fatal injury and the most common cause of non-fatal trauma-related hospital admissions among older adults, again, those persons over 65. These collectively together result in more than 2.6 million injuries in the emergency department. And in 2021, this was over 40 billion. And it's now estimated that by 2024, we are at 50 billion and continuing to increase because of the aging nature of our society. The average cost of a fall, a low estimate here at $16,000 per fall. And in the United States, there is 1 fall every 13 to 14 seconds with 1 death from a fall every 20 minutes. Source for you down below there. Now, the definition of dual tasking, let's give you a very clear introduction there. Now we've hinted about it so far. Dual task is the concurrent performance of 2 tasks that can be done separately, but they are being combined together. They have distinct goals. I need to listen to my granddaughter and also walk is a very clear and frequent example of dual tasking. Dual tasking is not a complex single task. I'm carrying a glass of water, but in fact, if you were carrying certainly something that you had to interact with, maybe a purse that you're drawing something out of, a backpack that you're trying to sort through, a water bottle that you're trying to open the lid off of and drink while you're also walking, we're back to dual tasking. Now, without going too deep here, let's understand the dynamics of dual task. Here's our main attention center. Here is one of our main automatic movement centers. We call it a procedural memory center. Now, when the attention center is too overloaded from math or a shopping list or a conversation, a podcast, or a television show, then it no longer can truly pay attention to the person's movements. And it says, hey, I'm too busy to pay attention to your walking, your dressing, your balancing. I need you, center of automatic movement, to take over. I need some help here. And so these procedural memory centers, of which the primary is the basal ganglia, says, hey, I've been doing walking our whole lives. I can take over here. Problem being, if we have any insults here, Parkinson's disease, any insults here, aging, Alzheimer's disease, frontotemporal dementia, multiple sclerosis, stroke, or many others, we don't have the full fund of these resources to be going out into the world thinking and moving. So what is the physiology of dual tasking that we've been talking about? Well, you've gotten a great introduction to that already. This frontal network that I referred to in the last slide is known as the dorsolateral prefrontal cortex. For sake of simplification, that's our main attentional center that determines what's important right now in the world. Prioritization, where should my attention go? The procedural memory centers that I also highlighted in that slide, and I actually gave you the top one, is the basal ganglia, but also cerebellum, supplementary motor area, and the premotor cortex that have bilateral, both sides of the brain, representation. Now, when you hear the word attention, I don't want you to think that it always means dual task. Dual task lives down here at the bottom. That's divided attention, okay? Now, attention, when you think about someone who has attention deficit disorders, ADD, or attention deficit hyperactivity disorder, primarily we're talking about all of the functions of attention, but here is a main one that's seen, the inability to stay on a task, focused attention, and sustained attention. Different from that is selective attention. I can keep myself on this task, and even when other distractors arise, I can ignore or extinguish those, and I can stay attentive to a main task that is prioritized because of my job function or my safety or my driving, and meaning other people's safety as well. Selective attention is the ability to pay attention to the road when the children in the back seat or the radio is distracting you. Sustained attention for a long period of drive. Divided attention is I need to give some attention to the children in the back seat, but I also need to pay attention to the brake lights in front of me. Finally, we're at alternating attention, where I'm not paying attention to one and I shift over to another, and that can happen back and forth. You'll find out the world is primarily filled with alternating and divided attention, simultaneously paying attention, but also shifting back and forth. Typing, email, but also I just got a text, shift over to my cell phone, come back up to my project. All right, so let's take just a moment to talk about dual versus multitasking. The basis is in dual tasking, people can still learn and improve motor and improve cognitive. We've established that. In multitasking, the main difference is there's too many different tasks you are alternating between, and you're never giving enough mindfulness to any one of them. No learning occurs in multitasking. That's quite agreed upon uniformly throughout the industry. Dual tasking, Steph Curry attempting to dribble 2 basketballs to get better at dribbling 1 in a game. Multitasking, obviously a very hyperbolic image here with this individual that has, some 8 arms, and she's managing something different with each of those. Obviously, this never happens, but it's not that far from the truth in potentially today's high-powered reception positions. You cannot learn when you are constantly task shifting. And so the science of what we do in marbles leverages dual tasking, leverages the science of efficiency, of engagement, of cognitive stimulation to promote neuroplasticity. But before we start thinking that dual task is only constructed to prevent falls or to reduce fall risk, we have to understand that falls, yes, are a main consequence of dual task, but dual task is also necessary when a person is engaging in conversation and trying to get dressed efficiently without losing their balance off the side of the bed. So ADLs, activities of daily living, such as dressing and such as light hygiene, keeping myself clean, those are obviously always requiring dual task resources as well in a person's everyday process. Hygiene is right there with it, and that could be including applying makeup, brushing teeth, and toileting, as well as keeping yourself clean therein. Instrumental ADLs, meal preparation, financial management, driving. Well, I don't have to elaborate on that. You know where divided attention in a busy world engages there. If I don't have the ability to be able to divide attention to the kids that are telling me about their day and my financial management of the checkbook, one of the two is going to fail, likely both. And then we also understand that dual tasking is necessary as we communicate from one human being to another, and also with our pets. Our ability to, in human-to-human interactions, listen to what someone else has to say, formulate our response while we're still politely listening to theirs, waiting for a break, and then engaging. That always requires the management of impulse control, thoughts, plus also listening at the same time. And then finally, let's also understand that many people have an aspiration pneumonia, have swallowed inaccurately, getting fluid or food particles down into their lungs because they're unable to talk and chew, to converse, listen, and swallow. And that happens as a primary indicator of dual task impairment. We see individuals have a higher likelihood of aspiration pneumonia. Now, we've already alluded to this in the last slide, but here again, we know that in every single work operation, we know people have the ability to divide tasks and learn, but hopefully they're not challenged to multitask too much. But success in the vocational settings, doesn't matter whether it's a road crew, reception, or otherwise, we're going to see some dual tasking come up there. And also, as I pointed out in Steph Curry's example, knowing where my teammates are that are open, knowing what the score is, knowing what my coach is yelling into me for advice. We've got the negotiation of multiple stimuli there as well. So cognition, let's not think that it's only about attention. Divided attention and dual task is certainly part of it, but we're going to be looking next at these next few slides into cognitive function, cognitive flexibility, confidence, reserve and redundancy that I've made some forays about and some references to already, impulse control, which I've also referred to, and oh, by the way, you can get some benefits too, because dual task can be superior to help with all of these, as well as some fitness benefits as you're engaging the body at the same time. Let's take each one of those one at a time. Very briefly, dual task can help to stimulate cognitive function, such as the ability to carry out daily responsibilities, getting your schedule straight, making your breakfast, getting yourself dressed, ADLs, scanning the world to determine where is and is not safe to move and what to avoid. All of those require cognitive function. For us to be functional, we need to be consistent, independent, reliable, and capable. If you are inconsistent, unreliable, or not independent, you need help. You're not functional. You need to hire caregivers or have care provided by family members, which may mean they're missing work. Cognitive function is extremely important to preserve or to recapture, if for no other reason than the resources spent in the gross domestic product based on wages lost or even resources spent because you're not functional and have to have help. Cognitive adaptability and flexibility already assumes you have cognitive function, but can you function in more than just one environment? So flexibility means that you've got a range of skills that are necessary for higher level functions, but also different settings. And that will require that you have the ability to hold on to information and suspend it for later use. You can call that working memory and short-term memory. Here, for purposes of simplistics and to feel very intuitive, we're going to just actually call that function hold. Next, we have recall, and that's very clear to all of us, and that's the ability to extract information that's been in your brain for a long period of time, grab it out of long-term memory, phone number, her name, what kind of car do they drive, where do they live, and how do I get there? That's all in recall. That's not hold, suspend it for a short period of time. What did you want to order at the drive-through? That's hold. Recall is, where is that drive-through? Process is a totally different form of cognition, and that is deductive reasoning. The ability to say, I'm locked out of my house, and what are the different ways that I could get back in? Process also means calculations and sequences and making something in the kitchen as well. And finally, we have generate. And in generate, we have inductive logic, the ability to say, okay, well, what are all the different uses that I might have for a paperclip? Or I don't actually have the tool that I need. What are some other things that I could use to help me with the task when I don't have that tool at hand? So we're talking about inhibition as well as creativity, as well as that inductive logic. Now, moving forward from there, remember, dual task programming also helps with cognitive reserve and redundancy, creating an extra level of executive control or cognitive abilities. So if you do end up losing some from aging or from a disease process, you've created redundancy. It's like being so strong that you can afford to take a couple of days off, or having such a great VO2 endurance capacity that you can take a week off and still be elite. We want to create at Marbles people that have cognitive redundancy, right? And so we want to have more interconnectedness in those 83 billion neurons you've got in your brain that can make upwards of 100,000 connections from one neuron to any other neuron. Each one can make anywhere between 5,000 and 100,000 connections. What happens with dual task and cognitive stimulation? You make more connections. The brain becomes neuroplastic, and it becomes a redundant network of, okay, I-5 is closed. I still have Highway 99 and 217 to get there. No problem. All right? So again, let's come back here and let's see. How do we create that redundancy? We actually get people to think and move. We get people to interact quickly. We get people to keep pedaling while they're also problem solving. And we do that at the very start by priming the brain with blood flow. And that's just a small part of the brain gym that you're seeing there. We also have to respect that if someone doesn't feel that they have cognitive functions and is constantly, let's just say, talking down to themselves, negative self-talk, or denigration of themselves. They're thinking pessimistically, many different ways that you can say that cognitive confidence will indicate cognitive function. If I can bring you to a bright, shiny room that is also surrounded with people that are having fun and excited about the fact that they're working on improving their cognitive reserves, you are more likely to feel confident that this is plausible and can get done. So you need to be in what's known as an enriched environment. You're familiar with research studies. Rats put in a darkened environment without food, without access to exercise, an impoverished environment, they die quickly. Okay, and that is even if they're getting enough food to sustain them, they begin to die from within, is the easiest way of saying this. If someone's in an enriched environment, they have good social support, they have possibilities, they see themselves as gaining, and they know they're in the right places for their optimized health, they have the best opportunity for cognitive confidence, okay? Impulse control, which I referred to, is something that's very important to be safe with driving, to be appropriate in conversation, to resist temptations toward actions that might be illegal or socially inappropriate. So we see that for safety, appropriateness, we can help to reformulate and reinforce impulse control. We train that by playing games that cause an individual to resist their first response and actually learn how to quell that initial cognitive set. I want to say red when I see red. But if you see the word red written in the color or the font of blue, in this game, you're actually supposed to step on or signify or say or touch blue. So again, there's a lot to be said there. You'll benefit from an opportunity engaging with the DV-Dot or certainly SmartFit to be able to see what the Stroop color word feels like. Both of those devices and corporations actually have that represented in their gaming. In addition, you may be familiar with the hailing sentence inhibition, which is also a measure of impulse control, which we use at Marbles in some of our land-based low-tech programming for dual tasking. Now, cognitive stimulation comes down to basically a demand that incites or creates a neuroplastic stimulus. It is more than just maintenance therapy, but we can actually keep people cognitively healthy by providing a stimulus so that the natural course of aging, I've retired from work, I don't manage my own finances, I don't drive anymore, I don't grocery shop anymore. Imagine that's like stopping your weightlifting, stopping your exercises, and not expecting to lose fitness. No, if you lose all of those stimuli with aging because of what's being taken away or provided to you, maybe you chose to have those functions all provided for you. You are losing stimulus opportunities. We're replacing that in your life with the very formidable, let's just say side effects supplement that is known as Marbles, right? So we provide the cognitive stimulation. We keep people from that expected degradation in aging, and we keep people from the actual physiologic process known as use it or lose it. The brain prunes what you have not been exercising in a cognitive function recently. Now let's give you a functional bonus here, right? The benefits of improving dual task tolerance, we've already talked about cognitive fitness and function and confidence, etc., but let's even go a step further. If you can expose yourself on a regular basis at Marbles to dual task demands, you get to continue to be tolerant of distractions and being able to extinguish them or participate in them without losing your walking capacity. You gain a greater amount of awareness. Oh, I'm really challenged when I'm distracted, so I will act accordingly. If you don't know that, you actually continue to try to participate in the granddaughter's talk and your walk because you have not been exposed to what it's like to spread and divide your attention, and you fall right in front of your granddaughter as a function of that or as a result. So with this stimulus on a regular basis, the use it or lose it is used and improved, you actually continue working and building your abilities in problem solving, in memory, in functioning with your walking and your balance on a very automatic basis. We call that the movement is in the background. You don't have to have it cognitively as a main thought or tenet that you're processing. And we actually rebuild motor automaticity, and procedural memory. If you are recovering from stroke, concussion, brain injury, multiple sclerosis, Parkinson's disease, etc., we're talking about rebuilding. And if you are aging and wanting to maximize your function in aging, we're talking about actually reversing those expected obligatory tendencies with aging as according to our society's definitions. Now, you also get the bonus of ADL, independence and efficiency. Doesn't take you as long to get dressed, to shave, to apply your makeup, because your distractibility is no longer drawing away from your timeliness or efficiency. You get out the door for that, that long day with many errands. You get out the door more efficiently if you have the ability to divide attention and not degrade function. So we see these main things are a function of your independence. Remember, if you lose independence, you need to hire caregivers, or you need to have caregivers that could have been doing other things. If you can continue to stimulate, you can continue to hold on to those functions, maintain cognitive function, like we said in slide 1 of this segment. Hygiene completion is also predicted by dual task tolerance. You have the ability to do this and think about that. Your abilities will be preserved in hygiene completion, because what's necessary in hygiene? Well, I've got to have attention to detail. Did I get my teeth brushed everywhere? Did I wash everywhere? Did I apply makeup symmetrically? And if you're inefficient, you have to check and recheck. And if you don't have the ability to shift off of a task and come back to it, that makes you inefficient as well. So it's attention to detail, the ability to appreciate full visual fields, and finally, be aware of your actions so that you are aware of when you're making an error and somebody doesn't have to point it out to you because you have elevated awareness. So let's keep in mind that, as we said earlier, we want movement to be in the background. We want it to be proceduralized. We want it to be automatic. So when you're doing your activities of daily living, many of them are listed for you here, you don't have to borrow away cognitive resources because those tasks are remaining automatic for you. So now I'm going to actually add another abbreviation to you, activities of daily dual tasking. And what are things that you are routinely doing that are requiring your dual task participation? Well, you might be walking and cleaning your glasses, walking and having a phone call or listening to a podcast, walking and applying makeup, or standing balance and applying your makeup, walking and texting, walking and getting yourself dressed, walking and brushing your teeth. These are just a few things that would be activities of daily dual tasking to give you a deeper flavor of that. But let's not forget, we already said that functional communication requires a dual task capacity, and I've already listed to you, this is just a reiteration of that. Suspend my opinion, wait for its time to talk, listen to you well. We've got some bi-directional dual tasking as well. Now, for those of you in rehabilitation professions, physical therapy, occupational therapy, speech language pathology, remember, dual tasking is relevant for all of the bullet point functions that you see here. And it's not just relevant for one of those disciplines. It's not necessary any longer to say that balance and gait belongs to physical therapy. Not true. Happens in ADLs. And if we don't have the ability to be able to read or to deductively or inductively problem solve while we're also trying to keep our balance or walk, now we see that all three of those disciplines are involved in every one of the bullet points. So as a person that's aging, as a medical practitioner, if that's your role, as a person who's interested in learning more about marbles because you want to help your community get better at these things, as another part of medical health, being an ancillary provider, perhaps physician, nurse, or otherwise, you see the importance of all of these. And perhaps most importantly, as a caregiver of people that you love, that you know you want to be able to keep safe and keep independent, we know that dual task testing, measuring the abilities for people in each one of these functions, is something that can be professionally done. We can handle that at Marbles. We actually have the technology to do that in a reproducible, finally, let's just say scientific environment where the testing has high fidelity and reproducibility, so we can give you your score, give you your treatment, and then prove to you by the same exact test that you've gotten better. Maybe that's the most important reason why we test. If we don't test, we don't know that we've gotten you better. You never manage what you don't measure. All right. And again, let's keep in mind, all of these functions require dual tasking. We have the ability to capture the tests and results in that, but that also is necessary for safe return in concussion. All right, so now let's measure and improve your dual task capacities. If you're going to expect someone to improve, they're going to, number one, need to know exactly what type of dual tasking they are challenged with. We do that with the SmartFit. We do that with the Blue Goji. We do that with the DVDOT. We also do that with land-based assessments of dual tasking that are proprietary to the Marbles brand. We also can use tests and measures of function, impairment, and participation with a distraction overlay, such as a timed walk with subtraction, a timed walk with naming WNBA basketball teams, right? So we can do that in a personalized fashion that feels engaging to an individual and create a baseline for them so that they feel we know them, we have that score, and we are going to hold ourselves accountable to show you that we can get you better from that. So we want to measure, we want to intervene, then we want to remeasure and then adjust our interventions, the games you're playing in Marbles, accordingly. Now, remember, several slides ago, we talked about actually going beyond gait. Dual task can be measured outside of just walk and. And this is just one table that I encourage you to come back to, because now you see 5 different activities that are necessary for life that can be coupled with distractors. So on the top line, you see a meal prep, reading aloud, dressing, upper body and lower body, self-feeding, or wheelchair propulsion. But on the left hand, in the rows, you see cognitive distractions that could be combined, auditory, visual, or manual distractions. This is a very important and very formative slide to help us see really this expansive importance of dual tasking and how we can overlay systematically so that we can measure one with each one of the modalities of distraction. For example, can you read aloud proficiently while the television is on? Can you feed yourself when there's dining hall clamor? Can you balance yourself while you're attempting to get dressed? All right, let's move into patient engagement, because none of this works if it's not fun, if it's not person specific, if it's not practical, if we can't demonstrate you're improving. The people inside Marbles have all of these. They see the measurements. They know that they're in a place of healing and health. They know that we are doing scientific testing and we're delivering the latest in evidence. So let's talk about patient engagement and the recipe of how that is done. So let's start off very first, and let's put the brain right there in a very fun, engaging manner, because it is very common for persons of multiple generations to associate cognitive function with the word marbles. We don't want people to lose their marbles. We want to help them regain more marbles and get excited about collecting up marbles. So this is our brain and body fitness. You see right here, the brain gym. Imagine right there to know that there's a place in a repository to get this done. There is nothing else like that. So the principles of neuroplasticity actually play out beyond just evolving motor control after stroke. My brain's getting reconnected. Now I can feel my leg again. Neuroplasticity of sensation. Let's think beyond that and understand that these same principles are viable for us in preserving, gaining, rebuilding, and recovering cognition. What have I already told you? Let's reiterate. If you don't use it, you will lose it. Where better than marbles to ensure that you are getting your supplement, your dosage, to keep you from losing it? Use it and improve it. Hey, you want to go next level and create redundancy and actually improve your dual task tolerance, your speed of thinking, your impulse control, right there. Demand and supply. We give you the demands in the highest level of evidence deliverable in our interventions. Intensity matters. Sometimes we can work very hard, and that is a necessary element to induce the brain saying, we need to get better at this. Let's actually see if we can make some new connections. And now let's go back and try it again. That was fun. Remember, intensity doesn't mean you're dripping wet. It doesn't mean you're disappointed. You can work hard, and if it's fun, you may not even notice how hard you're working. We call that flow. Now, in addition, we talk about saliency matters. Now, if you don't like to do subtraction, you don't have to at marbles. If you don't like to do ABC or A, C, E, and skip letters, you don't have to. We have such a large cornucopia and palette, a buffet, if you will, of different games and programming. You really will not get bored, and you will find yourself. When you find your flow in your game, you're allowed to actually process right into that as well. You're going to get your warm-up. We know you. You're going to RFID badge into many of these machines and games, and it will recognize you and your scores. And finally, specificity matters, and that's where the science comes that I help with our team at Marbles. If we're not delivering something that recognizes all the different attributes of cognitive function, then we're missing out. And that's why hold and recall and process and generate are important. Because if you're only working dual tasking and having people look at how many fingers you have up or add up the numbers on flashcards, you're actually not going to have the full fund of neuroplasticity available to you. I want you to think about dual tasking, especially in the marbles formulation, as constraint-induced automaticity. Now, I'm going to take just a moment and help you realize the analogies here. When a person's recovering from stroke, many times some of the most powerful research says, well, let's put your good arm in a sling, your intact arm in a sling, and let's actually force the brain, no other option but to choose the more impaired arm to reach for that door handle, to finish folding that belt over, to pull open that refrigerator. And by forced use, which again is known as constraint-induced movement therapy, that forces the brain to think about the affected arm. Dual tasking is the same thing. I am constraining, occupying your, not your left arm now, I'm occupying your attention. And that leaves you with no other choice than to put your movement on autopilot, get better at walking reliably, balancing reliably, sitting to dress yourself reliably. And when your movements are in the background and they're automatic, you're at dramatically lower levels of risk for falling or faltering or failing, right? And so that's exactly what happens here by this quote by Ford in 2006. The presence of a demanding secondary task, a distractor, in learning modulates the degree to which subjects solve a problem using either declarative memory, thinking about it and concentrating on it, or habit learning. We want movements to be habits. So dual tasking actually improves learning by forcing that learning to be happening and occurring without cognitive resources, because the constraint, the distraction, borrows away all of those cognitive resources. It forces you to use your procedural memory centers, your motor memory centers, okay? Now, that also gives us an improved dorsolateral prefrontal cortex because it's been challenged, and it actually begins to create more synapses and more connections from that area projecting outward. So we create redundancy. So if you were to have a stroke in your main attention center, but you've built up your resources, you are losing from a higher point and not faltering as far to become non-functional and dependent on others. And finally, you get a compensatory reprioritization because an individual becomes aware. Honey, I'm going to listen to your story after we get over here and seated down. And they become developed in knowing what is and what is not safe for them while they're looking to improve them. So how do we negotiate a dosage of activities at the brain gym? How do we know you need to do 3 sets of 15 with a 15-pound weight coming in twice a week? Dosage in cognitive neuroplasticity is very clear. There's a lot of research that studies this, and still more to be learned. But what we know right now is that it's daily is best. Use it and improve it. Person specific, these are the types of stimuli and distractions that are relevant and fun for me. And task specific, we're working on hold, process, and also recall and generate. It's dynamic, it's interactive, it's not passive. We're not doing to you, we're working with you. You're working on those machines. You're working harder to improve your score. It has to also include some stimulus, some demand, some challenge. Otherwise, neuroplasticity doesn't happen. Remember, demand and supply. Okay? So only if we have a stimulus with some errors, what we call a near miss effect. Oh, I almost got a best score that time. Can I try this one more time? That is the behavioral economics principle that's known as the near miss effect. If you don't have a demand and you get a new high score every single time, where's the supply? Where does the brain need to develop something new? It doesn't. Okay? So we think about and consider the person at Marbles, creating task and person-specific cognitive stimuli. So when you come in, you have the ability to see what our low-tech dual task of the day is, and you can choose, and we have several different options for you. So you can engage in a low-tech dual task that says, oh yeah, I want to see if I can come up with the facts of the day and hold on to those. I want to see if I can name as many Major League Baseball teams or recall the uniform numbers of the New York Yankees, or see if I can name as many different pets that I have owned throughout my life in recall as well. We want to make it engaging. We want to make it gamified. You're looking at a score and trying to beat it. Purposeful, I'm working on trying to improve my cognitive fitness. And I'm also trying to shoot these monsters on the Blue Goji bike. Whatever works well for you, you will find yourself, because we have such a variety available for you. It may be musical, it could be fun, it could be recreational, it could be vocationally specific, and it's always going to include divided attention. So we want people to have a demand that's sufficient enough to create a supply. We would not want to overwhelm someone and cause them 90% errors, although some people are still willing to thrive when they get 9 times in a row wrong and 1 time successful. We want to actually shape that closer toward your personality. So in fact, we also use a scaling system so you can tell us how hard you prefer to work. That's another secret and recipe for dosage. It's called autonomy. You rate how difficult that task was. Now you tell us if you want to stay at that level, make it harder or easier. The games themselves, DV-Dot, Blue Goji, SmartFit, have the ability to actually make those artificially intelligent assessments. So you will see while you're on the games, they are smart enough to see you just got 4 in a row, correct? I'm going to speed the pace of those balls coming onto the screen. You just missed 3 out of the last 5. I'm going to slow it down. Doesn't show you it's penalizing you. It adjusts according to your abilities. We want to have a dosage. Doesn't mean overwhelming. It means whelming, if you will. Cognitive neuroplasticity. Now, let's keep in mind a few things as we start to enter that Marbles facility and that Marbles franchise. There are expected improvements that come within these diagnoses, especially the earlier and middle stages of these, right? So mild cognitive impairment, I gave you earlier, is the abbreviation MCI. Not all of those people will automatically convert to individuals that have Alzheimer's disease. Early Alzheimer's disease has viability, and you see that list here. I'm not going to read it to you. We do not expect viability for improving people with these conditions. Does that mean we should give up on them? Does that mean that those individuals should not attend Marbles? No. What that actually means is let's not expect they're going to improve, but let's keep these people where they are for as long as we can to give them the capacity to be able to remain as functional as they are. If you take a person who has gotten weak and say, you've gotten so weak we can't strengthen you, that would be ridiculous. You'd at least want to keep them at that level and provide a stimulus. That's exactly what we're saying in the more severely impaired persons. Now, cognitive neuroplasticity is viable when we age. There's no limits to an age that says after 80 years old, you cannot make new connections in the brain. Absolutely false. And we do know that many of the losses that are experienced with aging, this should not be news to you anymore because of where we are nearly an hour into our presentation, that if you don't use, you will prune. And you will prune not only facts and memories, but you will begin to lose processing speed. You may develop fear according to your cognitive functions. Expect yourself to lose faculties, and you're going to be watchful of errors that you make and say, this is starting to add up. This is the 3rd time today that I've come into a room and forgotten what I'm looking for. When that fear happens, that becomes a distractor psychologically that you ruminate on in your mind. So we want to give you positive. We want to give you hope. We want to reverse these tendencies toward what society informs us that age has to be. Okay? So let's not forget that dual task improves procedural memory. If that wasn't the case, Steph wouldn't be doing it, and he wouldn't be the highest paid basketball player. We can retrain procedural memories, and the science is showing us how to do that, engaging and programming both at the same time. Now, you may actually appreciate, as I fly these up on the screen, try to name as many procedural activities as you can. And they're everyday life. I've populated a couple. I'm going to give you a couple more, basically like a family feud. See if you can have named some that end up appearing here. Top 10 answers on the board, if you will, right? So these are 5 top, in no specific order, procedural memories. You need to have these memories existing in your brain without requiring cognitive attention. Riding a bicycle, buttoning a shirt, zipping a jacket or pants, entering a code or a phone number, and there we are driving a route to work. And a lot of times we'll make it to work and like, whoa, how did I get here? Because it's so automatic, and we want automaticity for you. Now, I want you to, as we begin to wrap up, identify one thing that you would normally do while doing each of those activities on that slide. So you're going to find here, now is a brand new list of 10 things, and you say, gosh, while I walk, brush my teeth, put on a shirt, zip up a jacket, I am frequently watching the television, listening to a podcast, identifying grocery items, reviewing driving route. So let's finally move into the action steps. You can see how important this is. You can see how practical it is. You know the science that it can be done, for whom it can be done for, and let's look at the action steps. A couple of quick videos here. Okay, here's a nice low-tech option that can be graded according to someone's physical or cognitive capabilities. as you see up here on the top row, off of the carpet, I've got a green 1, red 2, blue 3, yellow 4, and a wild card in black. Now, all of those are listed 1, 2, 3, 4. In the easiest cognitive and physical request or task, I could say, go step on a color in the order that those are listed left to right. So we would find a green one, a red one, then a blue one, and then over to a yellow one. And then I could say, okay, now ignore the colors, go step on the numbers in order. Now you'll notice here, we'll go find a 1, and then obviously we'll go over and look for a 2. Now notice that I put this one upside down. It takes a little bit more cognition to kind of invert that in your mind. We go find a 3, and then the 4 is slightly turned. As I want you to do that, you can see how we can challenge individuals a little bit. Imagine even in a low-tech option. In addition, we can measure individuals with their abilities during something that's, for example, a cognitive step test, and we can add practical person-specific information to that. And we just did our first round of the 4-square step test, and how long did it? We're going to skip up to right here so you can see this. Now watch what happens. While you do the test one more time, we're going to do something regarding surfing. I'm not going to tell you what it is. He chose the topic of surfing. All right, good. Then you now let's watch him in action. Oh, yeah, and then any other boat you can come up with. He's stepping over small pipes here as part of the formalized test, the 4-square step test. You got it. What do you do when you're done? You completed both tasks, still didn't require any physical assistance from me. I know you're about ready for a rest break. I'm going to ask you one question before I hand the walker to you. How much time do you think that took you? Yeah, you're exactly right. 32.16 seconds, less than a full second difference. Now imagine how healthy and brilliant that feels when you can see you challenge yourself and you're thriving. Here's another low-tech example. So she's walking on a mat and going from the number 1 to the first month, January, to the number 2 to the second month, February. So we're having people try to complete this as quickly as they can. This measure is something they can gamify against, is low-tech, is safe to do, feels intuitive, it's not mathematics. That's another option. How about the Stroop that I mentioned? Okay, attempting to actually read a color that's written in a font that's not that color. Let's skip up to here and see her. See how she actually has to say green when she steps on the word purple written in green? Red, green, red, purple, red. Yeah, and that can be challenging, and we can time your abilities on that. We look at and leverage many technological advances, and we also continue to stay adept and abreast with future advances at Marbles. So we can do gait analysis, fall prevention. We can deliver dual task, high intensity interval training. We can actually also begin to incorporate information from medical professionals in the community and collaborate as the brain gym with people that can give us information about activity monitors and body worn sensors and stability, etc. So we can provide some things that aren't hosted elsewhere, and we can also collaborate with technological advances and information that might be done by local professionals. Marbles is not here to replace any professional and will not and cannot. But Marbles is that bonus. Marbles is the preventive. Marbles is the next level. So it is so many things that support the medical community during a rehabilitative, before any problems occur. and then well after for maintenance and redundancy. Another perspective here of the marbles, the brain gym here, open area for some of that low-tech dual tasking. You see the blue goji over here, and we see a light, bright environment that's ready to help people. Our very proud relationships with these unique technology partners include the blue goji bike here. You see these cyber cycles, the DV.Dot Senso, as well as many attributes of the Smart Fit. We will have these boards as well as some other features that you've seen in the photos as well. All right, so the technological advances can include engaging time. You'll watch in here.
Fun. Like, we bring the fun factor back into fitness. When you're doing these cognitive games, you're engaged and you're challenged and you're making mistakes and you're laughing, but you're also moving at the same time. So the time just flies by.
Now, here's the key. These technologies can be used for preventative measures. We all know that physical exercises are good for the brain and mental exercises are good for the brain, but when you combine them at the same time, that is the holy grail to keeping your marbles. That's dual tasking. Now, that is the ingredient that marbles offers to be able to promote neuroplasticity at the highest level. All that really means is helping your brain be as powerful, as adaptable, as variable,
that concentration
and as
required
as possible. So the big inspiration is to make these technologies available, accessible, affordable to the public to help prevent the onset of cognitive decline and dementia.
So we need people to engage in activities that we know are evidence-based and are going to actually be effective. And that's what Marbles brings to the community.
That's why I'm here as a medical director for Marbles to design the programs, to identify the equipment, and to help you achieve your optimum in brain health.
So unlike a lot of workouts where you go in, you exert yourself, and you leave feeling worse than when you walked in because you kind of beat yourself up. Here, you're going to leave invigorated, right? You're going to leave with energy. You're going to leave with clearer thinking because you stimulated your body and your brain appropriately without beating yourself up.
Franchising is the fastest way to get it to the public.
There are many reasons why this is such a
I'll tell you, there may not be any more important conversation than, in fact, the cognitive health of our society, and that's what we're doing something about right there. In the remainder of the handout that you will have, and if you don't, please ask me and I can get that to you. I just wanted to provide a few things that I'm not going to cover today for you. I've given you a greater explanation for each one of these cognitive functions: recall, hold, process, and generate. So you see examples that we're handing to you for this, and then some very frequently asked questions here that I think you'll be able to respond to already. Can cognition be improved? Yes, and how? Through neuroplasticity, demand, and supply. Is there a role for cognitive stimulation in persons with dementia? Yes, to stop the loss, to decelerate the loss, or at certain stages to prevent the loss. What's the science regarding cognitive prehabilitation and wellness? The science is that dual task is the superior mode over cognitive stimulation, over dramatic differences, statistically significant, between dual tasking when compared to crossword puzzle and Sudoku, etc. And does cognitive skills respond to neuroplasticity? You know that is absolutely true now. We'll wrap up here, and I'll extend to you exactly what I told you. My contact information right here. Your time is valuable. I want to thank you for your interest in this utmost of important topics throughout our nation and the world. My name is Mike Studer, and I'll sign off for you right now.
All right. So thank you so much. All right, guys. Can you hear me? Everybody's good? Let me see. That's amazing. Okay. Oh, I'm just removing some of the spins that we have. Pin. Okay, I'm here. All right. Lots of nuggets there with Dr. Mike Studer. What to expect, right? Dr. Mike Studer. If you have any questions, please, you can email him, and then he told us that we can definitely connect with him And then, yes, thank you so much for everybody making some comments there. Let's take a 5 minutes break or 10 minutes break, and then we will connect with our next speaker soon, okay? All right. Thank you so much, guys. Feel free to write down your questions, and I can definitely send it through Dr. Mike's email as well. But on the PowerPoint that he provided with us, he has all the informations and emails and how you can connect with him. All right. So if you have any other resources, Dr. Helena just send me the informations, and then we will also going to send it through all your emails. So we will have a recorded version for this. All the attendees will receive the recordings. And if you find value at the end, kindly donate for our future foundations. And then we will give you more information about that. Thank you, Sonia. Yes. Oh, wow. She's from Argentina. Thank you for joining us. Yes, thank you, Shalu. All right, appreciate you guys. Okay, let me see. Go ahead and take a break and we will resume. Hi, Todd. Good morning. All right. And I'll see you
Good
soon.
morning.
5 minutes. Good morning, Todd. Yeah. And you can resume, guys. Just go ahead, like a short minute break, and then we can connect with the next speaker. Hi, Dr. Mike Chua. He's here as well. Good morning.
Very important area. I'd like to talk about very important areas as the population ages in the reduction of falling and also the protection of the hip. And then my colleague Ed Wilborn, who will follow on from this presentation, will discuss more about posture alignment and spine related challenges that are occurring as we get older and our musculoskeletal condition changes. So Copa Healthcare is a distribution company for the United States. We're working with technologies that are primarily aimed at population from like 50 to 100 years of age in the area of musculoskeletal health. So our ultimate objective is to help reduce the rate of compression fractures in the spine and then hip and associated fractures that are occurring because people fall over. So we want to help patients enjoy an active and satisfying daily life. And our sort of condition focus is things like sarcopenia, the falling itself, osteoporosis and underlying bone health, as well as helping to prevent fractures. So what I'll do today is introduce you to the Marodyne low intensity vibration device with particular emphasis on fall reduction and bone health. It's a broadly used device that can be utilized in children as young as 4 with bone suppressing conditions like cerebral palsy or things that the child is born with. And then also as they go through earlier life, onset of things like anorexia nervosa, maybe Crohn's disease and things like that that can have some impact on bone. So our area of interest today is going to be the sort of 60 to 100-year-old population. And then I'd also like to introduce you to a range of hip protection products from a company called DeLoc, which is based in New Zealand. So why are things changing? The boomer population, of which I am one, is now one of the biggest ever groups of mankind to be going through the system. So in the US, every day, 10,000 people become 65 years of age. And this is going to carry on until we get to a peak around 2034, so in about 10 years' time. And then we've got this steady aging population over the next few decades. So this is a really big issue because something like 71 million Americans over 50 have osteoporosis or low bone mass. So it's a condition we can't ignore. So when we look at health challenges in this 50 to 100 year population, at 50, you've got issues like cardiovascular disease, and that carries on obviously all the way through to the rest of life. But there's cancer and osteoporosis beginning to pose a problem. But falling isn't really an issue. It starts to change as we get to 65 and then becomes a real problem when we're around 75 and above, where you've got this tsunami of dementia and or Alzheimer's or neurocognitive decline, underlying bone loss, plus muscular change, which is increasing falling, balance-related problems. So this is a real challenge. And as we've just been saying, there are going to be a lot more people going into this category as we progress over the years to come. So Maradyne, low-intensity vibration, is one of the solutions that can be utilized. And we'll discuss this now as we go forward. So the Maradyne device, which is that big white one in the middle, that was designed around 2013. Now, predecessor devices were the Juvent dynamic motion therapy device that was designed about 20 years ago. And I've been involved in all of these since 1998. And then there was a Exogen research device that was used in clinical trials in the 1990s. So the use of low-intensity vibration in human use is getting towards about 30 years of real experience, either in clinical trials or commercial availability. And commercial devices have been available for around 20 years, from when the Juvent came out and then in 2013 when the Maradyne emerged. So the indications for these types of device are balance, sarcopenia, rehabilitation, and that could be after hip fracture repair or other conditions, and underlying bone health. Most people that buy them are looking for solutions for bone health because there's a big push against bone medication generally, and solutions on the exercise side, which can be complemented by the Maradyne, are highly regarded and of great interest to particularly women as they go through the sort of menopause and beyond. So a Maradyne type device is used every day, ideally at 20 minutes of use, and that's broken into a couple of sessions of 10 minutes each. In this country, the device itself is a class 1 exercise device. That's the current sort of status that the FDA applies to it. Now, if you go to Europe, Canada, Australia, New Zealand, other geographies, low-intensity vibration devices, Juvent years ago, the Maradyne in the recent years, are class 2 medical devices approved for the treatment of osteoporosis. So there's around about 30 years of scientific information in humans, which we'll be talking about in a bit more detail as we progress through this talk. And the Maradyne device itself is manufactured in Germany. So just bear with me while I move to the next slide. So a Maradyne device, you stand on it. It weighs, and they're designed for portability and ease of use. So in the home, they're an easy to move around device. They're about 14 by 18 inches in area, 3 inches high. They can be applied, they can be utilized in United States and other geographies with electrical supply from 100 to 240 volt. And basically what's happening is the person stands on it, and there's a microprocessor that's controlling the sound actuation, which is creating the motion, the upward motion of the plate. So if you sort of look to the picture on the left, the individual stands on the device using G, force, which is acceleration against gravity of the whole body of the human. 0.4 G is being put into the feet. And that's constant because the device uses a closed loop feedback to maintain monitoring of the dynamic load on the plate. So the first thing it does is match the user who's on it. And then secondly, it matches the user's behavior as they're standing on the plate through a session of use. Because we're not concrete blocks, we are mass that can move. So the 0.4 G goes in, and then there are effects of attenuation as you go up the body. So through the legs, around 0.1 G is lost. So into the hips and the lower spine, 0.3 G is reaching that area, and then it further attenuates to 0.1 G getting into the head. So this is really important from a safety perspective, and we'll discuss that in a little bit more detail in a minute. So what does this do? Well, if you think about the bone marrow as the manufacturing site for bone building cells, osteoblasts in particular, then these small movements are stimulating increases in mesenchymal stem cells and biasing of those mesenchymal stem cell populations towards osteoblast genesis and away from adiposity. And I'll talk a little bit more about that later on as we go through the talk. So what does it mean? Well, it means the Maridine, to some extent, is a surrogate for fast-firing muscle fiber because it's working around 30 cycles a second, which is similar to some of the firing and contraction rates of the faster-firing muscle fiber type 2A, type 2B categories. So I want to just touch on safety first. Vibration is a pathogen. So there are international standards for human exposure to whole body vibration, and the ISO 2631 sets certain limits for how much exposure you should have in a 24-hour period. So a whole body vibration plate, like a power plate, the exposure is sort of less than a minute in 24 hours based on the force magnitudes in acceleration. A low intensity vibration plate, like a Juvent or a Maridine, they're safe for 4 hours in a 24-hour period. And we're talking about utilization of those at around 20 minutes in that period. So it is, in the vast majority of the population, a very safe device. So this is actually shown quite well in this video. So if you look at the bowl on the left, that's a 30 hertz sine wave going through the water, which would be similar to what a low intensity vibration plate is putting out. This is what a power plate device is putting out at low setting, and this is what it's putting out at high setting. So you can see there is a significant difference in force magnitude from acceleration between low intensity and whole body vibration at higher magnitudes. And we treat higher magnitude acceleration as anything above 1 G force. So these things can get up to about 15 G. For reference, acrobatics in a jet, you're pulling about 7 Gs when those guys are doing maneuvers. So some of the vibration plates can be doubling that acceleration. So this is like seriously intensive, and it poses risks. So that's the reason we're very focused on the low intensity category. So low and high intensity vibration plates, where do they fit in? If you're a child, under say 4 or 5, then these really have no role. But in kids who may have bone accrual challenges, low intensity vibration has been studied for the last 30 years. And also some of the higher intensity vibration devices like Galileos, for example, which can be controlled at different frequencies and magnitudes, have also been studied for conditions. And they're a very useful tool in children because they're not medication. Now, as we get into the adult population, then high intensity vibration is perfectly reasonable if someone's fit, active, strong, going about life in a normal way. As you get older, 60 to 100, then obviously they start to become more of a challenge as frailty and other challenges affect the human. So we're particularly interested in this category. Why? We want to stop you falling over. So if you look at a sort of leg format in a 25-year-old compared to a 63-year-old, you can see on the left, you've got a very vibrant musculature made up of type 2A, type 2B, and type 1 fibers, and not a lot of fat. When you get to the 63-year-old, there's an enormous increase in fat. And that's our challenge, because our body is increasingly getting fatty as we age. And also the fiber type percentages change. So the group under Lee looked at type 2B fiber content as a representation of age, and you can see there's a very, very steady decline as you get older in the type 2B fast-firing muscle fibers. So these are important, for maintenance of tissue integrity and also key things like balance. Now, when the low-intensity vibration was being looked at initially, NASA were a funder of quite a lot of the research. So it was presumed to be quite a useful technology to consider for long-term space travel because of zero gravity and the effect that zero gravity has on both bone and also muscle condition and the capability of the person as those tissues decline. So NASA ran a bed rest trial. And this was in adult volunteers, men and women. They laid in bed, 5 degree head down for a 90-day period. Some of them were exposed to the low intensity vibration. We were calling it LMMS at those times, but it's the same as a LIV force. And there was a control group that didn't have the exposure to the LIV. And you can see from the benefit of the low level vibration that in all categories for strength in the legs and the back, they're significantly better. So what was happening was the baseline was being maintained pretty closely with the group getting the LMMS. However, the control group were declining. Now, if we think about mechanical force, bone and fat, Pagnotti and colleagues did a nice review paper in 2019 and looked at sedentary lifestyle versus exercise. And there are a number of things to think about as we look at the two circumstances. So if we're in an active, exercise-oriented lifestyle, we tend to have better bone and cartilage and muscle. Part of this is because we're creating more mesenchymal stem cells and they're aligning with the osteoblastic pathway. The sedentary lifestyle is having an opposite effect. So adiposity is increasing, so the bone marrow is getting increasingly fat, and osteoclast resorption is increasing. So the bone that's there is being resorbed at a faster rate, and the muscle is also declining. So if we think about that musculature, if it's not the same as it was earlier on, it's having a different dialogue with the bone. So both the bone and the muscle are sort of systematically declining as we get older. So what can we do? The way to look at low intensity vibration is it is a type of exercise. So it's not a single magic bullet approach to musculoskeletal challenges. It's a sort of quite specific type of exercise. And the research, and I haven't put too much of it on here because there are stacks of papers that show low intensity vibration stimulates mesenchymal stem cell populations, proliferates those, and increases osteoblast output. It also contributes to stronger, better musculature, which we're going to talk about in a moment. So for frailer older people, it's a very safe exercise alternative if they can't do regular exercise for various reasons. It may also be a priming response to help other exercises have more effect. So it's definitely a technology that you have to look at and seriously consider if you're involved in care, management of the older population. So CDC in 2023 recommends low intensity vibration as a fall intervention for elderly adults. So that was published in the Study Compendium in that year. And I'll talk to you now about the clinical science behind that guidance, which was work done by the Chinese University of Hong Kong under Professor Kaz Leung and also latterly under Professor Louis Cheung. So the original study, and this was women 60 to 70 years using a vibration plate, and that was 20 minutes a day, 35 hertz, 0.3 G device versus just ordinary exercise. And we know the Asian population in that part of the world are probably more active than possibly people in the States. You know, there are various circumstances why, but people do a lot of regular exercise and it's more normal with things like Tai Chi and Qigong and other things that people do. So the regular group were just doing what they usually do. It wasn't a systemized set exercise routine. But the LIV was 5 days, 20 minutes a day. So when they looked at the summary of the data at 18 months, they found the fall rate, and this is slightly obscured actually, so I apologize for that, but the fall rate in the vibration group was 46% less than in the control group. So you had something like 62 out of the 300 in the vibration group falling over one or more times versus over 90 in the control group. And also the fracture rate was less. So it wasn't correlated to hip fractures or anything. It was just fractures that had occurred in that group. And there were 50% less fractures in the vibration group. Now on bone health, using DEXA, the bone mineral density in the spine and the hip in the group with high compliance, so that's basically 80% of 100 minutes a week or more, they showed positive improvements in their BMD. And we've seen that in other studies. So definitely with low intensity vibration, if a person of say postmenopausal age group is using these around 20 minutes a day, every day of the year, then they're more likely to get positive BMD changes measured by DEXA in both the spine and the hip. But we're very, very interested in the falling and the muscle related benefits of this. So the balance was better, the postural stability was better, the quality of life scores were better in the vibration group compared to the control group. Now, Louis Cheung in 2016 did a follow-up study of 50 or so of that group at 30 months. So 12 months after they'd stopped using the LIV. So what they found was in the group that had the LIV compared to the group that were just the control is the maintenance of leg strength and other control in the balancing and reaction times were better even at 30 months, 12 months after they had stopped using the LIV compared to the control group. And these were significantly better than the baseline scores. So really LMHF, which is the same as LIV, it's that type of low-level vibratory force, is a very good tool for balancing ability, muscle strength, and reducing fall rate. So this ought to be considered in every approach to the older population, particularly those living in sort of retirement communities and under sort of nursing home type environments. Now there's some other stuff coming through on the muscle and rehabilitation side with LIV. Leung, around 14 years ago, reported on hip fracture rehabilitation using LIV plates. So again, 6 months, 5 days a week, 20 minutes a session, low intensity vibration used 5 days post-operative after patients with trochanteric fractures in their hip fixed with a plate and screw or a dynamic, like a gamma nail type implant. And they had better balance, muscle strength. There were some bone related benefits, because in the animal studies that Ruben has done, bone integration around implants is extremely good with LIV. We don't claim anything to do with that in this country because it's a class 3 medical device indication for use. But there are very, very good musculoskeletal benefits using LIV post-op. The challenge in the US is everybody is dispersed, and there are loads of different stakeholders that interact with the patient when they've had their surgery. So it's hard to deploy LIV consistently compared with what you can do in other geographies like Hong Kong, which is an integrated health system. But we shouldn't be ignorant to the fact that these devices are very useful for post-op rehab. And we're seeing now new data coming out in things like symptom relief in chemotherapy-induced neuropathy, muscular reconditioning and balance and gait for women that have had breast cancer surgery and had chemo as a result of that. So Kerry Winter's group in Oregon are doing work. They published a pilot study last year at ASBMR. They're doing a bigger study now as we go forward. So I think the use of LIV for patients that have had cancer to get bone recovery and musculoskeletal recovery is going to be an interesting area as we go forward. And then we've got, obviously, the data that shows it's useful for reducing falls. So I'd now like to just talk about the lock hip protection. So you can stop people falling over, but if they do fall over, you want to stop them breaking the hip. The challenge with hip protectors, as you know, is people don't want to wear them for various reasons. Indifference, the stigma, the fact they look like very broad-hipped individuals. But there is, clear evidence that shows if you wear the hip protector, you fall over, you do better than if you don't have the hip protector. So DeLoc have done quite a lot of work, which I want to show you, because they're an interesting company and they offer some options for the older active population. So I'm just going to show you a video of their product range.
Ian, does this supposed to have sounds or just video like without sounds? Because we don't hear any sound. We don't have sounds on our end, but we just see the video.
Yeah, sorry about that. I didn't realize you weren't getting the sound on the video. Apologize for that.
It is really good. There's like wordings on the bottom. Yeah, that's fine.
Yeah. Okay. So DeLoc, which was formed around 2009, 2010, they looked at hip protectors on the market and they did a lot of biomechanical testing So this was work that was also done in Cardiff through Keenan and Evans at the University of Cardiff and their biomechanical testing lab. And they created a sort of model to look at the force and the force attenuation through various hip protector pads. So and that was published, their findings were published in 2019 in Osteoporosis International. And the DeLoc items had 5 of the top 8. So we're marketing now the Flexi, which is the blue pad. And we also have the Osteoactive pad, which is going to be evaluated this year. But, basically, there's a very solid foundation to the work that DeLoc have done on force management and force protection with their hip protectors. So if you look at their range, they have standard briefs in male and female, but you can change the inserts. So the blue pad would really be for an older, higher risk person, maybe in a residential community, who's fallen or falling. And these can be worn all day. They can also be worn in bed. So they can be removed. So they can have a number of pairs of briefs and one pad, just so it keeps it more pleasant for the individual. Now, for the active younger person who wants a good lifestyle but protection and doesn't want the sort of thickness of this pad, this is where the SAS pads come in. And these are motorcycle grade, as we've seen. They're thermoforming, so they mold to the body temperature. And these are extremely good. So that combination for somebody that's playing pickleball, walking, riding a bicycle, skiing, doing other activity, riding a horse or whatever, gives you peace of mind and some increased safety. So I think this is a really sort of useful approach to hip protection compared with classical approaches. And then for people that have got a sort of neurocognitive challenge, then there are closed pocket briefs. They have the white pads in them. So these are closed, stitched in, and you've got no worry about the person taking the pads out and maybe not putting them back in again. So this is good for sort of that memory care area where we need to consider people differently. So really, that's it. Our whole approach is aimed at keeping you tall and don't fall. And you can get further information from me at my email address at copahealth.us or product information at maradine.us and copahealth.us websites. So thank you very much.
You are welcome. So guys, if you have any questions with Ian, definitely join us. There's a question portion there. So Ian, that's really nice innovations and technology, especially that's very simple for the fall preventions for the hip protectors. And that's really good for we have lots of assisted living facility here, modern maturity aging, and definitely we can share this, that it is available and very portable, discreet, as you've said. I have a question. There's like the soft one, the blue Deloc, and there is like the osteo something with the different texture. What's the benefits of that one? What's the difference of that one?
Well, the black one is motorcycle grade. So it's used and it's tested to the European standard for motorcycle grade protection. So this is what you would buy in, apparel, like trousers and jackets to protect your hips, knees, elbows, etc. if you're on a motorcycle. So we've taken that pad and put it into hip protectors for people that are just normally ambulant, or they may be riding a horse, bicycle, e-bikes. If you think about those, are very popular.
Yes,
they go quite quickly. So you protect your head with a helmet, but what are you doing with your hips? So that's really for the active person. The blue one would be better if you're in a place and you've got a full risk and you just need protection. But because it's removable pad, you can change the briefs. So somebody can have a number of pairs of briefs and so those can be laundered and it keeps it cleaner and more pleasant, for the person rather than the hip protectors that are all integrated.
Gotcha. So the briefs, they can buy the briefs alone, or and then the pads is also separately.
Yeah, the pads will last forever pretty much. So
Yeah.
you're only going to need to replace briefs.
Yes, yes. Because that's a different kinds of briefs that there's an insert. So
Yeah, so
those
it's
looks
like a
like the
open
normal one.
pocket, we call it. And
Yeah,
there's
it
men
is.
and women's versions of those. And then we have the closed pocket in men and women where the pad is stitched in. So that's really for your sort of memory care market.
Regarding the LIV, can you tell me, can you share how much it costs? Because we have listeners that definitely, guys, this is really nice if you have an outpatient clinic that can easily, can you just give us a little bit of how can it benefits with the influx of patients, because that will be a good, like, difference and high ends that my clinic has the LIV. Now that we know the different innovations, evidence based that is, so I have a clinic A in this city and I am the clinic B in the city, but I have the LIV. You can sell that, right? And especially that's another income for your clinic. But how much it costs and how can we build that with the Medicare things that we have?
Right. So the low intensity vibration plates, you could have one in your clinic. We have a stand that goes with that. So that's around $4,000 for those two items together. The Maradyne on its own is $3,200 list price. So going back to what you can use it for, there's a mix. So have one in the clinic so people can get to know it, can maybe spend some time on it, become knowledgeable of it. Then there are rental opportunities for people to have them for a period of time. So when I was talking about rehabilitation after, say, a total hip or a hip fracture procedure, then you only really need it for about 6 months. So you can rent one. Now,
Yeah.
the areas that we're seeing in things like chemotherapy induced neuropathic symptom management and muscle recovery in the women after breast cancer and chemo, they're only being used for 90 days. So having access to the low level vibration plate for various time periods is something that needs to be done when the person's in their own home, right? So you'd have one in the clinic, and then there is a opportunity to get them for rental, or they can buy their own one.
Mhm.
And if they buy their own one, then we give you like a referral fee, and we also discount the price to the purchaser if they've been referred by you.
Yeah,
So,
because we can use it personally for us. Yeah.
well, really for long term use, if you think about it, for full reduction, you want to use it forever. You need to have it either in a facility where somebody can go and get access to it and use it each day with other people using the same device because it matches to individuals, or they have it in their own home or their own apartment because you want them to use it twice a day, but every
Yeah.
day of the week.
Thank you. And we are global, Ian. So we have lots of course, US based here as well. But I see that I have my doctor in Azerbaijan, and we have from I forgot where is she, but where is it available? And if ever they're interested, is it available outside internationally?
Yeah, well, the easiest thing would be for people to drop me an email. I can then put them in contact. If they're outside the United States, I know a
Yeah.
lot of distributors that are working with it in Australia, New Zealand, in Europe, because we worked together for many years. But also, we can refer people through the manufacturer who are
Okay.
BTT Health GmbH, and they're based in Germany. So the easiest way, Jenny, would be somebody just drop me an email and I'll be happy to send that on either to the distributor I know in the country, or I'll send it to the manufacturer for them to pick it up and take
Thank
care of it.
you. Yes, yes, definitely. I know you showed already your information on the last slide. Just kindly put Ian on the chat, your email, and I'm sure they are very interested to learn more. In the Geriatric Rehab Summit, we have so many questions about that too, and we have a nice presentation as well with Doctor. All right, thank you. All
Thank
right.
you.
You are welcome. Good job, guys. So we are now done with Ian. And definitely we will be now on our next. Let me see. All right. So that's from
Hello and welcome. My name is Mike Studer, and I'll be your host for today's presentation,
I
the
think I will put that.
neuroplasticity of cognition. And that truly means briefly, my name is Mike Studer, physical therapist as a background and have been since 1991.
There we go.
Okay, sorry about that. All right. And you can hear me, guys. Just thumbs
Sure.
up and the screen is good. Hi, Ed. Thank you. All right.
Dr. Jenny.
Okay, for our next speaker, and definitely we have also, so Ed and Ian are working together in a great company as well. But Ed will going to tell us more about another great innovation related with osteoporosis as well and spine management. But Ed is a results-driven senior executive with 32 plus years of experience in healthcare. He's specializing in sales, business development, and medical device innovation. Expertise in building and leading high-performance sales teams to penetrate large market territories and drive consistent year-over-year growth. Proven success in launching and positioning cutting-edge orthopedic products, including osteoarthritis and post-op rehab solutions within new and existing accounts. So he's a co-holder of U.S. patent. That's is it like 8,700,000 or 8,764,000? I don't know. I think that's 8,764 and 692. Oh, that's a lot. For the design of a groundbreaking osteoarthritis offloading knee brace. All right. Extensive experience in the rapidly growing baby boomer market, focusing on non-invasive, non-pharmaceutical solutions for osteoporosis care. He's skilled in market analysis, reimbursement strategies, and training programs for clinicians and sales team, offering strategic guidance and operational support to foster innovation and drive growth in the osteoporosis and orthopedic markets. So I would love to give the floor to you, Ed. That's amazing. That's lots of things there. So we need to ask you some question on strategy,
Sure.
things like that. So welcome for the Innovator Summit 2024, Ed.
Thank you so much, Dr. Jenny. Okay,
Yeah,
let
sure.
me, are you seeing my show yet?
I see your video, but no presentations yet.
Okay, got it. Let me bring my screen share up. Okay. You should be seeing it now.
Yes, and still you can put it on full view. I'm
Yep.
seeing the presenter slide view.
Okay. Let's see. How about now?
Yes, better. Thank you.
Awesome. Perfect. Thank you so much. And thanks for that introduction, Dr. Jenny. I appreciate that. Thanks everyone for attending today. I really appreciate this exciting event. Been looking forward to this. And as always, I enjoyed listening to my colleague Ian's presentation on the Meradigm system for sure. We work together targeting the osteoporosis community, but really the geriatric community and some of the issues that they face. I will be specifically talking about osteoporosis and vertebral compression fractures. Within that 32 years of experience, just a little background, I have spent a bit over 2 decades focusing specifically on osteoporosis and vertebral compression fractures and spinal utilization or spinal orthosis utilization to help correct postural issues and reduce pressure on vertebrae and try to just to help the patients improve quality of life with vertebral that are suffering from vertebral compression fractures related to osteoporosis. So let's move on. So we're going to follow this agenda today, and I would appreciate if you have questions. I'm going to allot some time toward the end for a Q&A, since there's a lot to get through pretty quickly. And so I think it's important really to set a foundation here with regard to osteoporosis in the geriatric community. And it's a significant problem in the United States as well as around the world, according to the WHO. But we're going to focus on the US for this conversation. And in the United States right now, 10,000 people turn 65 every day. That's that big baby boom generation moving its way throughout our society that has changed so much as it's moved along, right? Increasing the lifespan, and with increasing the lifespan, also the amount of challenges that we have as we enter the older years. So with that 10,000 people turning 65 every day, 1 in 2 women and 1 in 5 men will develop osteoporosis. So it's a significant problem, and it really doesn't peak for another decade. So pretty big issue we're heading into. So after the peak in 2034, though, the U.S. population focused on, with challenges like osteoporosis, vertebral compression fractures, falls, that's going to continue to grow, just not at the same rate over the next couple of decades after that. So we're going to focus on vertebrae, but of course, hip fractures, it's a big one. I'm sure, as Ian touched on in the last conversation, it's a big talking point today because of how it hits our society. And it certainly, postural alignment has a lot to do with that. So just talking about the impact on our society from a financial point of view. And the most important number, I think, that we can focus on this particular slide is the 95 billion by 2040. That's an enormous number just related to osteoporosis and the cost of dealing with the result of misdiagnosis or underdiagnosis and the impact that it has on our society. Hip fractures, that's a big one. But there's a long-term issue with vertebral compression fractures that really start to equal the impact of hip fractures as you move through. Future challenges. With the aging population that we're dealing with, it's a significant issue when you're looking at how many people are turning 65, but really that can be brought down all the way down to 50. But when you look at how many fractures go undiagnosed in the United States, I mean, it's 45%. And that's according to IOF. And, in South America, 46%. In Europe, you look at 29% of underdiagnosed or just not diagnosed vertebral compression fractures. And you see that present in your PT clinics, right? When a patient comes in with back pain and it's discovered through an X-ray later that there was a underlying vertebral compression fracture that just wasn't identified. And now what do you do with this patient? And so I think it's important to set the tone for why the SpinaMed exists. And so, I'm going to hit a little bit of anatomy and problem foundation here. So bear with me, because everything that we're talking about here has to do with why the SpinaMed exists and what it brings to the market. So when you're looking at bone density osteoporosis, a 10% reduction in bone density is a 2 times increase in the risk of a vertebral compression fracture from osteoporosis. And so a long time ago, the vertebral fracture cascade was established and some work done all the way back in 91. And what we see here is, an increase of 5 times the risk after the first. But when we look really as it moves along, and when you think about how many patients that you've seen that have had multiple vertebral compression fractures, when you start seeing people that have very low bone density, the risk of a vertebral compression fracture goes up significantly, 75 times when you're dealing with somebody that's had 2 or more and they're in the 33rd percentile. So pretty big issue. And so I'll hit on the clinical signs of osteoporosis because they will relate directly to the science that we're going to be talking about when it comes to the SpinaMed. So clinical signs: increasing kyphosis with accompanying loss of body height, limited quality of life due to pain and restrictions on daily living, impaired function of the lungs, reduced muscle strength of the trunk, and an increased risk of falls. So hyperkyphosis, again, we're going to touch on this because it directly relates to how the SpinaMed fits into the picture. And the most important number or bullet point from this particular slide is the average angle. So angle is greater than 50 degrees from vertical is where you get into the clinical diagnosis of hyperkyphosis. It's going to be important when we start looking at the science and how the SpinaMed helps correct some of these issues. So I'm going to lead me into the SpinaMed 5th edition. Why does the SpinaMed exist in the first place? Prior to the SpinaMed, so going all the way back to the turn of this century, really the solutions to bracing a patient, whether it's a vertebral compression fracture or some other issue that needs to have core stabilization so healing can occur, the options were pretty limited as far as any type of dynamic orthoses. And really what you saw were cast-style braces, Jewett-style TLSOs, and also custom and prefabricated corset-style TLSOs. All of these products exist today, and they're proper in their right place, right? And that's an important thought to really kind of grasp here, because the right place isn't in weakening the core of a person that already has some issues with sarcopenia and reduced stability. We need to be finding ways to strengthen the core, not weaken it. And when you put them in an immobilizing corset or a rigid 3-point orthoses, that's what's going to happen. Unfortunately, 25 years after introducing the SpinaMed, a large percentage of the osteoporosis healthcare community still believes that these are the options when we start talking about bracing and osteoporosis patients. And while we've fought hard to try to bring and change that image, it's still out there for sure. And so problems with existing orthoses and supports. We talked a little bit about it, but high on the list is poor compliance. When you speak with a doctor about bracing a patient that is somebody that needs some type of stability enhancement in their osteoporotic, they believe that compliance is going to be really low. And that's because they're thinking about the old style orthoses. Also passive body posture, which means the risk of muscle atrophy goes up dramatically. Pressure on the body structure, especially the sternum and the pubis. And when you look at things like the cash style brace, while they're appropriate for certain people, if you're going to be in it all day long and you're immobilizing the core and you're putting pressure on those areas, you see a lot of patients with just skin that's been rubbed raw or blisters created and just uncomfortable. In some of the corset style TLSOs, you have a reduction in the lower portion of the lungs, so diaphragmatic breathing is an issue. And so if you have comorbidities, the risk of not getting full oxygen intake is a real problem. And of course, in the states anyway, in the areas that have a higher heat and humidity, that's a big problem when you're putting a corset on a patient. So pulled this from a great study that SpinaMed was part of, but I thought it was really a great quote from a patient that was in the study and a follow-up. A well-adapted spine orthosis could develop into a long-lasting friendship that provides support and help in daily life. And the reason I thought that was interesting is because that's really the way a lot of patients look at the SpinaMed. Once they get to use it and understand how it works, they really like how it helps them become more mobile and regaining some of what they lost. So, SpinaMed at 25. Evidence-based peer-reviewed studies drive the message for us. And along the lines, after the initial one, we're going to touch on in a minute, many other studies have come along that have validated those original findings. In the United States, we launched in 2003, so we've got 22 years on the US market and tens of thousands of units on the US market alone. And since 2006, it's enjoyed Medicare reimbursement under L0456. Another great thing about SpinaMed is that it does require professional fitting. It's not an off-the-shelf brace. It's a custom fit brace. It's not custom made. And what's important about that is that you make sure that it's tailored perfectly to the patient. So the patient gets the best quality care out of the product, and also the healthcare provider has the ability to really ensure that the patient is getting the best treatment. And with the SpinaMed, you have multiple product champions in the U.S. market. People like Sarah Meeks have been pushing this idea since 2003, and she really has become one of the strongest voices in the world of osteoporosis care and postural alignment. So a little bit of the evolution of the product before we get into the science. As mentioned, it's been on the market for 25 years. And along the way, we've made multiple changes. Some people still think of the earlier model with the exposed piece that kind of looks like a spine. Now it's contained in a pocket, and it's become much easier to use over the years, and it fits much more closely to the body, and patients just seem to like it more and more. So a little bit about the study. Pfeiffer and Minna published this study through American Journal of Physical Medicine Rehabilitation back in 2004. And it's proven its efficacy, and it has very high patient compliance, and increases core muscle strength, reduction of pain and body sway, and an improvement of posture. Those are the key things to know about it. We're going to get a little bit into the numbers now and into the science. But before we get into the results, I think it's important to talk about the type of patients that were included in the study. So these are your real patients from your clinics. And you're looking at 62 postmenopausal women, and the average age of the woman in the study was 73 years old. And to be included, you had to have at least one radiographically proven compression fracture, and the average was 2.1 per patient. Minimal angle in the study is 60 degrees of kyphosis. And leading to high compliance, the instructions that the patients were given in the study, they were restricted to using the SpinaMed 2 hours a day, an hour in the morning and an hour in the evening while they're up and around. So it's not all day. They're not in this all day. And the goal really was back extensor strength and a reduction in angle of kyphosis. Those were the two endpoints that they were really focused on, but there were multiple points that we measured. And very important to know about this study was physical therapy was not included during the course of the study. It was just the SpinaMed along with their prescriptions as well as nutritional guidance. So the numbers. I'm not going to focus on every one of them here, but just the ones that make the most sense to talk about. And the big one is back extensor strength and abdominal flexor strength. So when you think about orthoses, most people naturally and correctly think of wearing an orthosis, you run the risk of atrophy of the muscles in the area that you're protecting. But with the SpinaMed, the exact opposite happens. You see an increase in core muscle strength, 73% in the back extensor strength alone. You also see increase in vital capacity. What we were measuring there was expiratory volume. And so making sure that the patient is getting good oxygen intake. And also you see a 38% reduction in average daily pain. Of course, that can be translated into less medication and for body pain, and then a decrease in angle of kyphosis of 11%. And along the lines, also a decrease in body sway. So core strength, reduction in angle of kyphosis, equaling a reduction in body sway of 25%. And of course, we can naturally carry that over to reducing the risk of falls. That, however, hasn't been studied at this time, but that's a natural adjunct to think about there. A couple studies that have come along after this one. There are many, many studies that I haven't included here, and we can send you a summary of each one if you'd like. But a couple that I did feel like were important to include here. The first one was done by a Greek doctor, and it was a fairly small study, but he was looking similar parameters to get into the study, and he was really looking for compliance and pain reduction and muscle strength. And so he saw 90% compliance rate, back muscle strength increased by 25%, and abdominal muscle strength increased by 50, and a reduction of pain of 37%. So very similar to what we were seeing with the original study. The second one was a little bit different. So this one was focused on people with chronic back pain. They had osteoporosis, but we really didn't look at whether or not they had a vertebral compression fracture or not. They had chronic back pain. That was the target. And what we wanted to find out was back pain reduction as well as back extensor strength and stability. They're really, with this chronic group of people, you didn't see a tremendous reduction in back pain, not statistically significant, but we did see a 26.9% increase in back extensor strength. Additionally, next, can't really talk about vertebral compression fractures without talking about vertebral augmentation. That hit the market sometime around 2006, 2007 or so. And very, very soon after, the kyphoplasty really blew things up. Prior to that was the vertebroplasty. It's been around for a while. Kyphoplasty kind of took it to the next level. And initially it was thought, okay, well, makes a lot of sense. Reestablishing vertebral body height. What are you doing about the posture, right? So we started talking to doctors immediately about how do we take that pressure off the anterior edge of the vertebrae when you're going in and doing a kyphoplasty or a vertebroplasty or some of the other newer ones. And so there was about back and forth a bit on that. And now this one was published in 2020. And it really, if you look at this slide, the most important takeaways are number one, at 6 months, the conservative SpineMed solution and the kyphoplasty, more aggressive, they were equal in the pain reduction for the patient. So that was pretty interesting. But the final bottom line was that the vertebral augmentation in conjunction with the SpineMed produced the best possible outcome. Because you maximized spine straightening, so taking the pressure off the anterior edge of the vertebrae for adjacent vertebrae helps stabilize the spine a bit more. And of course, we can look at that and think, okay, does that mean we're going to reduce the potential risk for future fractures? That's yet to be determined, but that's the thought behind utilizing both solutions to help with pain and stability for this particular patient population. And so the goal of the SpineMed, return the patient to a better quality of life. That's the bottom line. Stability, strength enhancement, all of the above, but better quality of life is really what it's all about with the SpineMed. And so how does it work? That's the big question most therapists and most doctors will ask, because we start talking about strengthening the core while bracing the core. And it doesn't really jive with what most people think. And so it does it through biofeedback. So there's three mechanisms that are happening here to provide that biofeedback when a patient is properly fit with the SpineMed. So you get the full spine panel, you get an abdominal binder, and you've got shoulder straps. The key is the SpineMed moves with you. So there's a turnbuckle that is in the center. When the shoulder loop goes over when the shoulder strap goes over and comes back around, it hits a turnbuckle that moves it back toward the front. And as the patient's moving around, it's constantly cueing them. So properly fit Spinamed is going to be constantly reminding the patient to return to their best possible posture, because that's how the product was fit. And so that's how we increase the strength, because it's always cueing the patient to move in that position. It's not pulling them back there. It's not holding them there. It's constantly providing that feedback to move there. And so we saw in the study, again, I'm going to drive 3 points home. 30% reduction in average daily pain. Of course, that means a lot to the patient. Reduction in pain meds, a much better mental space, right? You're not dealing with pain all day long. That really wears you down. And so that improves the long-term outcomes. And core muscle strength. A stronger core means better stability, means a higher quality of life for the patient, means a willingness to engage in your daily activities a little easier. And of course, that's the objective with all PTs, to get a patient a higher quality of life and better stability, especially with this patient population. And of course, reduction in ankle kyphosis, straighter, more upright position, less risk of falls. This is a great real life picture provided from Betsy Newcomb. And she's a longtime user of the Spinamed for her patients. And she sent us this one quite a while ago, but she was so thrilled with it. She felt like it was something that you need to share. And so this was over the course of 3 months, and pretty significant changes in this older gentleman, as evidenced by the pictures. Okay, so indications for the Spinamed. So vertebral compression fractures related to osteoporosis in thoracic and lumbar spine. Hyperkyphosis with back pain, and juvenile Charlotte's disease. In the US, we don't see the Spinamed used a lot in that particular segment, but it's there. It's a very similar application for sure. Where does it not belong? In unstable fractures of the spine. So if you're looking at a traumatic fracture from an accident, falling off Jenny, are you talking to me? Okay. I saw you move and say, okay. Where does it, unstable fractures. So if you fall off of a horse or automobile or a bicycle and burst fracture or something like that, Spinamed doesn't belong there. But in a stable environment, chronic back pain, things like that, that's a good fit for it. Okay, so the features and benefits of Spinamed. So open abdominal breathing. So just an abdominal binder. We're not going up high with a corset. We're not locking the patient in. So you're allowing the oxygen intake to go deep into the lungs. So the Spinamed, the 5th generation, has a new feature, and this pivot joint, along with elastic attachments in every portion that connect to the anterior binder, they all move, and it allows, as you're walking, the product is actually moving with your hips. So it's staying planted and locked in. So that, again, provides better feedback. So the patient is constantly staying in the right position. The product itself, still from the early days, it carries on the aluminum alloy insert that goes into the back panel. That is shaped. And what's important to know about this particular picture and what we're talking about here, when we get a little bit later, I'm going to have one slide that briefly talks about fitting. But what we're doing here is shaping the panel to be in the patient's most upright position. So we're not pushing the patient back there. We're encouraging the patient to move there under their own strength to get into that position. And that's how we're fitting it on the first day. We're going to adjust the straps so that it's cueing them to be in that position. Anytime they move out of that position while they're up and around, it's constantly reminding you. But after 4 or 5 weeks, the patient's going to come back in, and you're going to see that they're upright more, and they can even get further. And you're going to readjust it, and we're going to continue to guide them back into that better position. And that's really how we have achieved the success over the years with the Spinamed, and that's what was reported in the studies, and that's how the patients were treated. So a couple other features that help the older population, remote shoulder straps. So those loops are permanent, and so it allows much easier application, especially for the older population that has dexterity issues in their shoulders. And these small grips on either side of the abdominal binder allow them to use their thumbs and just slide them in there and not just grip. So they get a much better fit. As far as fitting and sizing, the SpinaMed comes in 6 sizes, and you measure from S1 to C7 C7 topographically. Again, with the patient in their most upright position, soft tape measure following the curves. That's going to give you a spinal length. And then the proper fit is going to, when we're applying the SpinaMed, the sacrum to 3 to 5 centimeters below C7 is where the actual product's going to fit. So moving on. When you're first teaching the patient how to wear it, do it several times in the clinic, but you need to make sure that they're looking into a full length mirror, because the anchor point, the lower pelvic strap, is really designed to hook around the iliac crest. So ASIS is really where you're trying to anchor the lower strap. And to do that properly, until you really know the feel for it, you want to have the patient looking at themselves in the mirror as they're applying it. When guiding the patient through how to use it, so 2 hours a day is what we recommend based on the science, right? That's what we studied. And our objective, of course, was getting high compliance. So 2 hours a day, an hour in the morning and an hour in the evening are what we're shooting for, but an older patient population may not be able to pull that off. And you may have to back it down 10 minutes, 15 minutes at a time, maybe even less, just to get them started. And then over time, you'll start moving it up. It's not a product that will work very effectively if the patient is sitting. You really need to be up and around. So yeah, we've had patients in a walker using it, not a problem. But refrain from sitting. If you're going to be sitting for periods of time, just take it off and reapply. But an hour in the morning and an hour in the evening. Now, those are guidelines based on the science. Each care provider and their patient are going to have to decide what is appropriate for them. So, it may be longer periods of time, and there are plenty of studies out there that show longer periods of time. But that's how we go with the recommendations. Okay, so I'm sure there are practitioners or clinicians watching that may be interested in actually doing it through their clinic and not just referring it out. And so I've thrown together some ICD-10s as well as the L code that is utilized. And this is just a starting point for the ICD-10s. There's a lot of them that can be applied to the SpinaMed, but this will give you an idea. L0456 is the proper billing code, and there are a few CPT codes that PTs can use for the initial fitting as well as the follow-up and training. So some collateral that we have that will help the patient. So wow, we are already at 30 minutes. Okay, so videos, clinical patients brochures, and study, as well as a script pad. It's already been done. So if you need to provide something to your doctors, there's a lot to like about the SpinaMed. High compliance, number one. It's got lots of evidence, peer-reviewed, published studies. The outcomes are out there. I mean, tens of thousands of patients are successfully treated in it. So that speaks volumes, not just in the US, but worldwide. And proven reduction in pain meds and higher quality of life. Copa Healthcare, you already heard from Ian. He talked about the other product within the fall risk reduction. I talk about the other ones that are in our line for postural alignment. And the SpinaMed is our flagship for sure. And it's the prescription-driven solution for the challenging, even moderately challenging patients. Medium duty is more the TG posture garment, and the daily use product will be out in the first portion of 2025, and that is designed to be utilized in combination with the other products or by itself. It's all-day use. It's got a band that's underneath that bow that you see on the back there. There's indicators. There's a band underneath there that's constantly cueing that person that's wearing it so that it moves them back into that position. So it's a great adjunct to the SpiderMed. So our contact information, and that's it. So thank you so much. I really appreciate the opportunity to present the SpiderMed. And any questions?
Thank you so much, Ed. Yes, definitely. It's really lighter and more easy to use. So that's very important for us as a clinicians as well. We have lots of cases nowadays. I'm working in acute rehab. We have lots of falls, post surgeries, post-op laminectomies, and they're wearing those very heavy braces. So some of them that really adds on the compliance, but definitely these are really great innovations. And also the lightweight, and then just like a normal teachers for postural correction. Even for us, I always see that the taller you are, the more you're hunchback, they're very conscious on their height. Yeah.
Oh, yeah.
So that's definitely will be helpful in their physique. And I always advise them. I like when you emphasize the importance of improving our core because that's why they are weak. And I always educate them. The better posture you have, the better breathing, and then you can prevent further vertebral compression fracture, as we age. So these are very important. So guys, if you have any questions, please put on the chat. But definitely Ed is here, and Ed, kindly put your information on the chat. I know you showed it already on the slides. Thank you so much, Ed. Appreciate you guys. Thank you,
Thanks,
Ian.
Dr. Jenny.
My pleasure. Let me see. All right. Okay. And all right, we have that. Thank you for the hearts, for the love. Okay. And we have here, let me see. All right, so we have Ludo Feed. So our next speaker will be Mark Evan. He just came from Canada. Yeah, because we're all over. So he's just home. And we have Ludo Feed is a unique exercise experience that is personalized for you. Ludo Feed's innovative technology customizes the exercise difficulty for each person, making it suitable for individuals with a range of conditions, ages, and health goals. Feel confident to exercise safely at the level that's right for you. They have different exercise to thrill of personalized challenges and celebrate your progress in individual health journey. All right. For our next speaker, we have Mark Evan. He's the co-founder and CEO at Ludica Health. And Mark is Ludica Health is a company that develops interactive exercise programs for rehab and healthy aging. Their flagship product is Gentronics, is currently being used in over 300 rehab facilities in North America. Mark led the company through Gentronics' initial design, IP clinical research, regulatory approval process, and market development. Ludica Health's newest program is LudoFit. It is an easy-to-use therapy software for laptop or iPad that enables therapists to assess, train, and track progress for strength, balance, endurance, coordination, and cognitive skills. This is really fun. We presented this in Geriatric Rehab Summit. This is very colorful, fun way, and entertaining for our patients, especially when they're bored using our TheraBands or do your exercises. They're just sitting in quads. So this is really nice to know that you just bring your iPod, you just bring your computer. All right, Mr. Smith, this is what we're going to do, and they will be very excited. Let's show it now with Mark. All right, I give the floor to you, Mark.
Thank you, Dr. Jenny. Very excited to be here. I'm going to go ahead and share my screen.
Thank
So
you.
give me a quick second here.
Mark, are
Okay.
you in Canada right now?
I am in
Yeah.
Canada. Yeah, yeah. Just a second here.
I
Coming in
was there in
here from,
November and also
sorry?
last week. I was in
The,
Vancouver in November and in Victoria last week. So I know the place now. It's my second time in Canada.
oh, wow. Yeah, it's that's a bit on the other side of the country. But yeah, I haven't been over there in quite a long time. But I just shared my screen. Want to make sure
Yeah.
you guys are able to see it. Okay.
Yes. Yes. Very clear.
Okay, perfect. Perfect. All right. Well, I'm very excited to be here. Good morning, everyone, or almost good afternoon. So are we ready to get started?
Yes. Excited.
Awesome, awesome. Okay, so I'm Mark Evan. Thank you for the introduction. The CEO and co-founder of Ludica Health, a company that makes LudoFit, Gentronics, a whole range of programs for interactive programs for rehabilitation and healthy aging. And I'll get right into it. Today, we're going to be talking about from rehab to home, talking about sort of the challenges and solutions in the clinician session space, and then how this can be extended for home. So just a quick little intro about us. We've been around since 2012 doing a therapeutic exercise. We have a suite of products. This is what you see here is our Gentronics program. It's in like Jenny said, over 350 rehabilitation facilities, mostly skilled nursing facilities, and our newest program, LudoFit, is for individuals, and LudoFit Pro is for clinicians to be using. So today I'm going to be talking a lot about LudoFit Pro and how LudoFit fits, the LudoFit Home part sort of fits with regards to that. I should also mention that the exercise is what we've done. We have a lot of clinical evidence that has been studied, or a lot of clinical studies that have been done on the Gentronics program, and already a number of studies that are underway and towards the later stages for the LudoFit program. It's something that we take very, very seriously. And we have some great research partners that have been showing some amazing results. And you can go and check us out. I'm going to actually just on the chat, I just put in the web page, the LudoFit Pro web page. So if you're going and if you're in the conversation, you feel like you want to go check in there and sign up for a trial, you can always do that. That's free trial, no problem. And we're happy to get you started. So I put the web page in the chat. So today we're going to cover how technology can help during therapy sessions. And bridging clinic to home, extending the care visits, and then I'm going to give you guys a live demo of the program so you can see it in action. You can see what it's all about. We'll have some fun, and let's do it. So let's start by talking about in session. So when we think about, let's talk about some of the challenges that we sort of really focused on and really took care to think about deeply with our clinical team and with our team of clients to see, well, what can we do here to help. So patient engagement, keeping patients motivated and engaged during their therapy sessions. You have 45 minutes, 60 minutes to fill with something that you really need, and that engagement has a really important factor towards the outcome. Time constraints, high caseload with documentation. So finding a way to balance those elements is really critical. Complex cases and managing cases with comorbidities, cognitive impairments when you're working on a physical challenge and there's a cognitive impairment as well, and you need to match those key pieces together. Proving value, showing measurable progress to justify continued therapy. Burnout, the toll in regards to managing demanding schedule, hands-on care, and high patient expectations. So let's take a look at these one by one and see, well, what can we do? What can innovation do? What role can it play in really helping a therapist's life, a patient's life, and really improving the experience? So let's start by talking about patient engagement. So first thing that a technology like ours does is it's about gamifying therapy. It's about turning traditional exercises, evidence-based exercises, into something fun, an interactive video game, something that patients look forward to. And when you're having fun, your stress levels are lower. You're able to take on a bigger challenge, and that has a significant impact in having the time pass while you're doing something super beneficial. Then there's personalizing the exercises, so customizing the exercises based on the patient's abilities and goals, finding ways to get the just right challenge for the patient, something that feels relevant, feels achievable, getting immediate feedback. That's a really important element for patient engagement, to see what you're doing. Is it right? Am I succeeding? How well am I doing? So reinforcing that progress. There's a lot underneath the patient engagement part that really could play an important role to ultimately leading to that better outcome through a patient leaning in and feeling really engaged and focused and motivated with what they're doing. Looking at time constraints. Using technology and specifically a program like LudoFit Pro to offer ready-made evidence-based exercises. So you can basically get the program up and running. I'm going to show you how it works in a few minutes, but you plan the sessions. You with a couple of clicks, you've got a ready-made whole scenario all set up with the challenges, with the elements required there to keep the patient focused and engaged. Documentation tools. So this program is automatically tracking patient progress as you go. So every movement, every success that they make, number of arm movements, number of squats, number of weight shifts, postural control, range of motion. These are elements that are being tracked on the fly as the patient engages in the program. Portability, the ability to set it up anywhere with no extra equipment. Basically, up till now, these virtual reality systems or these motion sensing systems have usually been in larger rehab centers like that we work with, or SNF settings, and they require a screen, a sensor. And imagine, if you're working in the home health space or if you're working in an outpatient clinic space, you could just pull out that kiosk right out of your bag, open up your laptop, and you're giving the patient the full experience that you're used to getting, but with needing high-end equipment. But now you're able to just pull it out of your bag and give the patient the same experience. So that's a huge plus, and that really opens the door to a lot of clinics who want to offer something special, or clinicians who want to offer something special that wasn't previously within grasp. Complex cases. So every activity that we have on our program, you can customize it in really significant ways: standing, sitting, right arm, left arm, range of motion, challenge level, time of play, to really meet patient needs, reaction time, inclusive design, and also we have dual tasking as well. So some of the activities include memory challenges, short-term challenges, and pairing that with the physical challenge, which is a really important piece, evidence-based piece for fall prevention exercise. So that's an important element. Proving value. So I talked a little bit about this before, but imagine just engaging the patients and having that training period and that documentation period happening at the same time. That's something that's new, and that's something that you can do with the aid of technology, with the right technology that can save a lot of time, and you can get that objective data, and you can use that data in a whole bunch of different ways to obviously engage the patient's family, but also for proving value, for justifying the need for more rehab, and for also informing the next steps of the intervention. So, and then burnout, obviously, this is about making therapy fun, not just for the patient, but also for the therapist too. You can find ways to really strengthen your bond with the patient and engage with them, take turns, reducing the physical strain. So you can focus on guiding the patients, cueing them, rather than physically intensive interventions on your part. Streamlining the workflows, so the automated tracking, like I mentioned, that time-saving element, and then the autonomy piece. So and I didn't actually talk as much yet about the home part, but this is a platform. The LudoFit platform is something that connects the clinic or the clinical session with the patients at home and have it all centralized. So you can the program is centralized, the automated tracking is centralized, and so there's elements that maybe you would have to do in the clinic that now you can ask the patient or be confident that the patient's going to be doing on their own. So that continuity of care piece. So let's talk a little bit more about the clinic and the home, and then I'm going to go into the program itself, and we're going to spend the rest of the time looking at the technology, clicking around, seeing what's there, and if anyone has any, through the chat, if they have anything they want to see or any questions, let's do it. I'm more than happy to talk a little bit about. So obviously there's different options for home programming that you could do. But the first most important thing is finding a way to give the patient a home program that they are going to do, that they are going to want to do, that they're going to want to stick with over a long period of time. There's a lot of really good evidence-based exercise protocols out there, like the Otago fall prevention protocol, Tai Chi, moving for better balance, and they often work very well in a pilot setting. But when it comes time to rolling this out at scale, the biggest challenge that has been found is, well, yes, they work, but they only work when you're doing the program. So what we've done with the LudoFit program is we've created a whole range of exercises that have been directly derived from these evidence-based programs. So, but we've taken them and we've gamified them. We've implemented motion sensing, and we've turned them into something that people are excited to get involved in. And then there's the continuity of care piece. So you've got the clinic, you've got the patient's home, but the data, the exercise data, the program data are all centralized in a way that element could be shared. So you're knowing exactly what's happening on the patient side when the patient is at home, and then you can pick up right where they left off without any question marks as much. So that's a really important piece to what this program LudoFit Pro and LudoFit Home is all about. So I'm going to go ahead and do a little demo, and we're going to go into it from there. And feel free, if any questions or anything like that, to. So before I go into the demo, I'll tell you that this is a program that runs on most laptops or iPads. So it runs on Windows computers, Mac computers, and iPads. It uses the web camera for all the motion sensing, so you don't need any special sensors. Literally, if you went to our website now and filled in the form, this afternoon we'll send you an invitation. You can click through the invitation and you'll be playing the games and trying it out and experiencing it yourself. You don't have to pay anything to try it. So I encourage you guys to do that. But before, let's take a look. So I'm going to go ahead and sign in with my clinician account. So I just put in my password, and then I've got my patients here. So these are all sort of test patients. This is our test account here. So I'll go ahead and click on one patient over here. And what do I see? So right now I'm looking at this is the patient's. Oh, actually, no, I'm not even.
Yeah.
Yeah.
Not
Sorry
seeing
about
it.
that. For some
You're
reason,
good.
it's not. Let me just go ahead and stop the share for a second
Okay.
and then reshare my screen. Sorry about that. That must have not made sense. Okay. Okay. I'm going to go back
Good.
and log off. So basically what you're seeing here is I'm logging. So this is the profile screen. Okay. And I'm going to go ahead and log in with my clinician account. So this is the login screen. And now I've got my list of patients. These are all, as I mentioned, these are all test patients. So no PHI being divulged here. And I'll go ahead and click on a patient account. And then what do I see here? This is basically the patient's profile screen. So obviously this patient didn't do much this month, but you could see on a monthly basis what they've done. And it's really taking the exercise experience and gamifying it and adding that layer of fun, badges, challenges. We have mountains to climb and things like that to really help encourage people to continue for the long term. You can view their performance data. You can invite them to the home program. But this is basically the starting screen when a therapist clicks on a patient's name or if a patient logs in on their own. They've got a program here that's sort of based on what they've done so far. You could browse the exercises. So you've got a whole list of exercises here that you can go from. You can choose global options. So basically, this is, let's say this patient is going to be mostly in seated position or mostly in standing. You can always change the parameters before you go into the games, but you could choose which side of the body. Let's say this side, this person is going to be focused on the right side of the body. Let's say they're hemiplegic, or they've got a challenge on one side that you want to focus on. That you can do. I'll go ahead and confirm. You've got the list. So for example, I'll start with, and each game is a thematic experience. So it's not just a kiddie little party game. It's something that's designed to be an adventure. We take our games seriously over here at Ludica Health. We think real carefully about what we're doing on that side. So you choose stance, seated, or standing. You can actually see the most recent results. So last time they played at the lowest level, and they played it for one, they rated it a bit easy. I'm just going to put it for say 1 minute now. I'll leave it at challenge level 6. We're going to be doing this in standing position, and then let's do it. Let's go. So you're going to watch me play the game a bit, and don't judge, but I'll do my best. So this is a skiing the Italian Alps. It is a true to life Italian Alp ski resort. So this is the real thing. Well, it's not the real thing, it's virtual, but we try to replicate the real thing in this space, in the virtual world. And you can see here, what you see on the screen, by the way, on the screen share, there's dots and lines on my body. So this is computer vision in action. Basically, I'm just standing in front of my web camera, and it's tracking all my joints on my body. So I'm just standing about 3-4 feet away from the program, from my computer, and here I am. I'm ready to go. So I'm basically weight shifting, and here I am. So I'm going to be now, okay, the first thing I had, so there's different challenges along the way. So I've got these trees I got to navigate. So I'm doing reasonably quick weight shifts around these trees. So that's how it starts. And then I've got a little slalom course. I got to get those stars. So now I'm shifting my way to the left. By the way, you guys are watching this over Zoom, and my little disclaimer is that it might look a little choppy if you're watching it, because this is over Zoom, but I can assure you that when you're playing this, and you go squat, so maybe you'll be playing it tomorrow or Monday, and you're going to see how smooth it is. But here I am, I'm squatting, and there's a sort of a squat indicator, so let's see how I'm doing. And I'm shifting around these rocks. So I'm only playing this. Oh, I got a new personal best. Fantastic. And nice job. I finished. So that was a 1 minute. 1 minute went pretty fast, huh? So that was good. Tells me how I did it. Keep it up. I got a personal best too. So a lot of fanfare, you could see over there. Tells me some of my things. Number of weight shifts, number of squats. So this is for the patient and the therapist. All of this, obviously this data is there, but this is sort of the patient's experience. Okay, their badge progress. This is how far they're getting to their next badge. Now you rate your level of exertion. So this is a modified version. This is our version of the Borg RPE scale, which goes from 0 to 10. We're rating it from 1 to 5. And why we do that is the therapist could obviously always see how a patient is performing subjectively, but it's also to help the program adjust in difficulty. Let's say I rated it a bit easy. Okay, rated a bit easy. It'll say, would you like to increase the challenge level? So I'm at challenge level 6. Okay, and then you can see I just unlocked challenge 7, new challenge level unlocked. So you have to play your way to better progress, and there's a few steps. So in order for an higher level to be unlocked, you have to do okay on this level. You have to show that you're good, you're decent at this level, and then you have to subjectively rate it as reasonably easy, and then it'll ask you if you want to upgrade it. So these are all the elements to really make sure that you have something that is both autonomous, so the patient's in control of what they're doing and they can feel some ownership as to where they're going, but also but it's done in a way that really covers all their bases. Are they performing it correctly? How is their subjective feeling, and do they even want a higher level of challenge? And obviously that depends on certain other elements too. Just a second. Okay. All right. So let's show, for example, I'm going to show another game. For example, let's show this Tour de France. Okay. So who here has done the Peloton or something like that? Okay, this is our version of that. Obviously, where this is one of many experiences, but this is a marching in place. So you're not actually bicycling, but you're marching in place, and the program's actually watching your knees being raised and navigating you through this cycling course. So you can go here. You can do it in standing or seated. Let's try seated for fun, because I already showed you a standing. So let's do seated position. You could choose arms, left arms, right arms. We're going to do again, duration 1 minute. And I'll go ahead and click start. And this is Tour de France. It takes you through beautiful areas. It takes you through Paris, Montpellier, through the beaches, tunnels. You might see a video now. So all the games have the tutorial videos, tells you what you're doing, what it's all about. You can skip the videos if you want, but it tells you what to do. So you can see here, you're basically raising your knees, you're reaching to the right, you're reaching to the left. And let's go in there. So it says move back and sit down. So here I am. So I'm going to be moving back.
Make sure we can see your knees.
And it sees me over here.
Great. Stay
Okay,
seated.
so it says great, stay seated. So I'm ready to go. Okay, so here I am. Okay, the game has started, but we're not moving. Well, we can only start moving if I start raising my knees. So here we go, raising my knees. Cyclist is going. I gotta reach to the left here to get those stars. And I gotta navigate around the other cyclists. It's really important not to hit the cyclists because it gets pretty, ouch! Whoa, that's bad. You have to really watch not to hit the cyclists. You need points for that. And I got a personal best. I continue along my way. A lot of our patients and users are really excited about reaching those personal bests and seeing those fireworks. And the program is taking you to different places. So, now we're in the sort of a woody area, but then you can go to a mountainous area. You can go to cities, towns, beaches, tunnels, all kinds of things. So here we're kind of going up a mountain, but I think we're almost finished anyway, because I only did this for a minute. So that's the end of that. Again, finishes the program. Thank you. So here it says the game score, tells you how you're doing. And then let's see what kind of data it's showing here. So it tells you how many times, number of lateral arm extensions, and 112 knee raises. That's pretty good for that short period of time. Again, see how I'm doing towards my badge progress. And we're actually adding more layers of fun. And you're basically earning badge progress on certain elements, on arms and legs in this particular game. I'll rate this one as just right. So then it's like, okay, just right, we're good. We don't have to. The goal is for the challenge level to be just right, not too hard and not too easy. So we're not going to recommend or ask you to do another higher, lower challenge level if you rated it just right. I'll show some more stuff, but before I show, I'm going to go ahead and click on the performance data just so you could see. All right, this is basically a little chart. So basically every day that the patient performs, in this particular case, you just click on the performance data in there, and then you end up here. And then the Tour de France, you see I did for one minute exactly, time of play. I did it at level 8. I got 16 points. Rate of exertion was 3. So this is something that a therapist can go and check actually, on the portal website. So they can go from the app itself, and they can click on the patient's name, see how they're doing. Even if they engaged from home, you can actually see the data, or you can go through a website and do that. And then you could see what else did we do. Okay, here, the ski game, Ski the Alps. Again, we did it for 1 minute, level of play, and you can see all the data that's listed here. So percentage of successful weight shifts, number of stars, percentage of successful squats, rate of exertion, I rated it at 2. So remember, a bit easy. Weight shifts and squats. So you can see all that's there. And yeah, that's basically the element here. And I'm gonna show a couple more, or until we're out of time. We may have a bit of time for questions, or is however long you'd like to go. But there's really one more really important piece of this that ties it all together. So you've got your patient here. You've pulled out your high-end interactive motion sensing rehab system right out of your bag. Let's say you're doing it at home or at the clinic, and a patient says, "This is cool. Can I use this on my own computer?" We always get those questions, and that's actually one of the reasons why, from our skilled nursing product, we get patients and their loved ones emailing us and saying, we used your program in such and such health and rehab center. Do you have anything for home, or can we get it for home? So you can have this button here that says invite client to LudoFit Home. Just click on that button, and the email here, well, this is just temp email, but you can basically put in the patient's email address. You can fill out a couple things. So you could fill out, will the patient be performed standing or seated? Which arms will be used? And this can always be upgraded by the patient themselves if if they've reached a certain level. Is initial assessment required? Something I didn't actually talk about, but this program actually administers the 30-second sit to stand assessment. That's designed to, it's designed for a therapist to track remotely how a patient is doing with an assessment that has normative data tied to it. And it's also to help the program understand what type of challenge level is appropriate for this patient. You can set how often that assessment could be performed. So let's say I'm discharging my patient, but I want to see them, let's say I'm not discharging them, but I'm reducing my number of visits to, say, once per month. Let's say we want to kind of kick it into a lower gear for many different reasons, but let's say that's how you want to do it. You can say, all right, I want them to do this assessment once every 2 weeks. And that way, when they engage in the program, it'll be like, it's time for you to do your 30-second sit to stand assessment. And then the patient would do it, and the therapist could now have something that they could monitor remotely. So you can go ahead, click invite, and then the patient would get an email. So okay, so basically, someone asked, I'm a mobile vestibular PT. Do I need the pro version, or could I just set them up on the home version if I'm treating them in their home? Okay, that's a great question, and it's very clarifying to explain how this could be worked. So what I would suggest for you, the short answer is yes and yes. So yes to both questions, but this is how I would recommend you would approach it if you're going into patient's home, and if you have patients that I would recommend that you might want to install the pro version on your laptop that you use for documentation, your PC, or if you have an iPad, you can have the pro version on your laptop, and you can pull it out of your bag and use it for 15 minutes, 10, 15 minutes during your session. That's a great way to warm the patient up, to get them understanding, oh, this is cool, this is interesting. And then you can invite them, right from the patient's home. Together with the patient, you can, set their profile up, do a couple of games, get them comfortable, get them excited, and then you can go ahead and invite them. So then they get the email to start their own account. But you don't have to do that. You can just say, and you can get it actually on our website through the LudoFit Pro page that I shared. You can just go to that website and order cards, and we send them to you for free. There's no charge for that. You could just put in your address, and we can send you 10, 15, 20 cards, or 30 or 40. Little promo cards about that big. It's an informational card. So if you have a patient that you would like to have on this program, you can just give them the card and say, here's something, try it, see if you like it. It's free. Patients get a 30-day free trial, and after that, it's $12 a month. That's the discounted rate for patients. So that's something that you guys could do too. So you can do either or. But we built LudoFit Pro for clinicians as a really nice way for therapists to engage with it. And we know it works. And I should also mention that it is billable. Your LudoFit Pro time with this patient is billable under a number of CPT codes: neuromuscular reeducation, therapeutic activities, therapeutic exercises, cognitive training, gait training. There's some gait exercises in here, and we do have a documentation guide as well. So you don't lose anything by using the program, and it's a great way to transition for patients in the home. Yeah, so that's the key, some of the key answers there. Feel okay. So I'm going to continue here. I'll show a couple of other things if you're interested, but I'm not sure we have until 12:15, so I'll do it for a few more minutes, and maybe you guys will get a bit of a longer lunch break. So that's my gift to you. So let me show you something else. I'll show you, for example, I did a seated position, I did a standing position. Let me show a standing activity that's focused on gait. So I talked a little bit about gait. So let's do that. So I'll go ahead and click on this. Is a Thai rock climb. Okay, so we're in Thailand now, and you may notice that all these games are based on world travel. So exercise your way around the world. That's one of our taglines. This game is only performed in standing position, but you can choose which side. Again, I'm going to just do this for 1 minute, and I'll leave the challenge level. Let's say challenge level 5. Do you have something put together if we want to introduce? Okay, so this is absolutely. So someone asked, do you have something put together if we want to introduce this to our employer to start a conversation about this? Absolutely. You should get in touch with us through the website, and I'm going to just, while we're on this conversation, health.com, I'm going to just put my name and email in the chat. Email me directly. We will do, you can reach out to us through the website or email me directly. I can do a demo. I can put together a package, and we got lots of success stories and lots of there. So yes, there is a subscription for the clinician, although the subscription significantly reduces once you have a bundle of clinicians. So for one clinician right now, you guys get a 2-month free trial, and then it's $60 a month for the clinician, and you can use this with as many patients as you like. Now, if you have a bundle of clinicians, if you have a clinic, that price can go down quite significantly with yes, the PT can monitor 2 to 3 patients. You can monitor not just 2 to 3, you can monitor 20 to 30 patients at once. Through this program, there's no limit to how many patients that you guys have on this program. So that's basically around that. I'll go ahead and show you the sidestepping game, and feel free to hit me with your questions as we go. I've got the chat here, so I see those questions as they come up. But in the meantime, we're going to this is again the tutorial video. This program is filled with tutorial videos that are context-based, so it's not like you have to go to another website to see a bunch of videos. All the tutorial videos are they appear exactly what you need to see when you need to see it. So this is a game. This is a tutorial video specifically on the rock climbing game. What you'd be doing, how it works. I'm going to go ahead and stand up and move back. Here I am. It sees me over here. I'm going to stand up here. So here we go. So this is great. Stand up and hold still. I'm in the right position. And this is a sidestepping and reaching. So here I am. So I'm sidestepping to the right and sidestepping to the left, and I'm keeping my way through it.
Collect as many stars as you can.
Now I'm reaching up with my arms. So this is a full body experience. I could be doing this with an assistive device as well, but what am I doing? I'm basically sidestepping. And now I have an experience. I got to climb up these ladders. How do I climb them up? With my arms. So as I reach with my arms, I'm climbing up these ladders, and I continue along my way. And I go up here, get the stars, and I continue. Personal best. Continue along my way. Here we go. Okay, so that is. I'm going to pause on that because I actually want to to give you guys. So here we go. Rate your level of effort. There's a lot more to show before I sign off here. Before you guys go to lunch, I just want to give you a little tour of what's there, so you know, and you guys could try it out yourself. And like I said, it costs you nothing to try it out. Just fill out the form. We'll send you the link. You guys can try it out for 2 full months. You can have as many patients as you want on this program, and there's no commitment, no credit card or anything. Just it's an informal trial, basically. We give you full access to the program, and then we engage with you and talk about, well, what are your needs? What types of patients do you have? How can we work with you? How can we help you? And then if you feel like this is something that is good for you, you could take a month-to-month subscription. So there's no, if ever it's not working out for you, there's no problem at all. So, ski the Alps, we talked about the rock climb, talked about Tour de France. We have a trunk flexion game. This is focusing on postural control. We've got a game focused on that takes you to the rivers of Chile. You're reaching with your arms, bilateral movement to the right, to the left. So you're doing functional lateral reaching. We have a dual tasking game. Dr. Jenny tried this game. I remember when we had our first session there. So you're basically doing sidestepping, squatting, you're going around obstacles and things like that, but you're also remembering things. So it's really practicing short-term memory recall overlaid with physical tasks. So this is a super important piece for fall prevention. The newest game is a pickleball game. So I don't know, Jenny, if you've seen that, but that's one of our latest ones. We're always adding new stuff into this platform, and the pickleball game is obviously reaction time and upper body. You could do backhand, you can do forehand. If you look closely at the environment, this is our first game that takes place in the US of A. This is Bainbridge Island in Washington State, which is the birthplace of pickleball. So we take you to the birthplace of pickleball. That's where it all started. The fanfare of pickleball all began right there, and we decided to honor that place by making our pickleball game. So you could see those. You can't really see it in the back, but there's some mountains back there, and this is exactly from a scene in that area. And feel free to try it out, enjoy, and go for it. So I'm gonna sign off and let you guys go. But thank you so much for your interest and for learning. And I really would love to see you guys try this program, get your feedback, your ideas. We're constantly evolving this program. Our team is super dynamic. We're adding a lot, and we're adding game after game after game, and we would love to partner with you.
Thank you so much, Mark. So that's really interesting. And we really love anything fun, like games. And then even the patients, they love colorful characters. Just like they just said that diverse characters, love to see it. So definitely connect with Mark. And then this is really very nice. It's very portable, especially for our home health therapists. We have nice gadgets in our new building right now in acute rehab. They have these big bikes, and then you can watch these things too. But the portability is a little bit challenge in that. So there are patients in the rooms who don't want to go to the gym, right? So now you just bring your tablet, your computer, so at least you can play and go to your account, and this is really nice. Great brains there, Mark. Thank you so much for innovating this for us. Definitely, it benefits us clinicians. It makes us a good clinicians, giving them a great innovations in the rehab. And then also for our patients, that this is really fun and this will be very interesting for them. Maybe they will be interested to look forward to see us. My exercise lady. Some of them, they call you like that, exercise lady. All right. Thank you so much, guys. If you have a question, feel free, okay? But we will begin your lunch break. And good point. And Mark already put there the account, how you will connect with him, even his email, because definitely this will be recorded, and we have lots of registrants or attendees so they can receive all their this recording as well. So everything that we discussed today will definitely will be, because it's Saturday right now. We are global, different time frame, and definitely I understand the time. But you got these messages, guys. All right. Thank you, and I'll see you in 1 o'clock. All right. Thanks, Mark. Appreciate
Thank
you.
you. Thanks.
Okay, guys, and feel free. We'll put on a break, and we have Todd Gilbertson from Balance Tutor later. Oh, Todd, I thought you're having a lunch. Yeah, so we will have Todd and even Chris for our 1 o'clock discussion later. All right, so feel free to have your break, and we'll see you again later. And lunchtime. Just want to, while some of you are still here and taking a break with others, so just want to pinpoint, we remember Mark discussed about the sit to stand, right? So that's really good. So sit to stand, 30 seconds sit to stand is a rather nice evidence-based functional outcome measure. It's really good to, it's very short, imagine, and this measures your leg strength and overall. So it's really nice if the patient can able to do like 19, so you're exceptional and you have a very nice like outcome. And then if they're able to do like what do you call that? Only 9 reps in 30 seconds sit to stand, it's a red flag. They are very low functioning, so they need to take care of that. And maybe they can only do like low intensity exercise. And then the medium exercise tolerance between 10 to 18. So that's an average tolerance that they can do. So that's a good test. And then you can assess what kind of activity they can use in the LudoFit activities. All right. So we have a mean numbers for our patients between male and female. If they are on the female on the 90s, they should be able to do more than 7, but the mean number is around 7.9. If they are around on the 60 plus, they should be able to do more. But for the men, the mean number or average number, if they are on their 60s, should be around 14 and above. And then so on and so forth. All right. So at least you have a goal. Okay. Good luck, guys. See you later. Thank you.
Complete assessments to monitor your cognitive well-being. Brain games. Keep your mind sharp and have fun with our brain games designed to challenge and improve cognitive function. Journal. Capture memories and express yourself with our journaling feature. Weather. Stay informed about the weather with our built-in weather forecast. Pill management. Never miss a dose again. Manage your medications easily with our pill management system. Social matters. AgeWiser combats loneliness by providing a vibrant social network where you can connect with friends and family. Create posts and share updates. Chat with loved ones. View your friend list and manage friend requests. Jen. Introducing Jen, your AI companion. Chat with a friendly avatar or create your own using a voice clone of a loved one. More about AgeWiser. AgeWiser is more than just an app, it's a comprehensive care solution that it helps prevent falls with AI-powered anomaly detection, offers custom-crafted exercise videos to improve mobility, provides brain games to enhance cognitive function, manages medications and detects conflicts, combats loneliness through social interaction and AI companions. AgeWiser, the future of geriatric wellness, is here. Join the revolution for a safer, more independent, and fulfilling senior living experience. Download AgeWiser today.
All right. So thank you, Swati. So that is from our amazing one of our colleagues. Swati Balantrapu is the founder and innovator for that. That's amazing. All right. So here. So we're done with our break, and we're now on the second set of our session for the Innovator Summit 2024. So right now we're going to talk more about balanced tutor perturbation with Todd Gilbertson. He is one of the leader here that we're going to present an expert. And what is balanced tutor perturbation treadmill? It is the world's first clinical perturbation treadmill that safely and accurately enables a clinician operator to give an unexpected perturbation. So you will see when Todd presents to us how it works. And definitely he has also another speaker, Chris, will be going to discuss more about it. And then it's really just nice that this perturbation can be given in a different like medial lateral, anterior posterior planes. And yes, it is actually moves up to 11 inches medial lateral planes, right? With an instrumented force plate as a treadmill deck, a harness for safety, and a computer-driven system, an operator or clinician has the ability to elicit an unexpected event, which is the perturbation itself. So whether teaching crossover stepping to a stroke patient, step initiation to a Parkinson's patient, or retraining the motor sensory integration for a concussion patient, the balance tutor is an extremely functional and intuitive tool for all types of balanced patients and individuals that would like to improve their balance. All right. So that's really exciting, and that's really a great innovation. I saw that in the CSM last time with the wonderful leaders with Todd, which we have today. And I met Jeff as well. Kevin as well was there. So really wonderful guys. So let's learn more about it with Todd here. Thank you, Todd. Thanks for having us for your Saturday weekend.
Thank you, Dr. Jenny. I appreciate the invitation, and I'm looking forward to sharing the balance tutor with you. I'm going to go ahead and share my screen and get started in the presentation real quick so we utilize all the time efficiently. Can everybody see that?
Yes, it's still not on the speaker presentation. Yes, getting better.
Ooh, hold on a sec.
But there's a black on the side that's blocking the video. I don't know what are
Hang
those.
on a
That's
sec. Black on the side. Let's try this one more time. Any better?
Just make it, so make it slider view. Yeah, go ahead. Make it now slide presentation. It's coming up. I don't know what's that side, but it will block some of your video.
Oh, I don't want that to happen. Can you see this? Well, let's see if I can, that is new to me.
It is part of our, like, when we have the Zoom, there's something like on the corner. That's the one on your end, but we just see it like black, It happens to me as well. So
should I go ahead and get started so we don't?
yeah, just show this one. Okay. That's fine. This will be fine, and make it like big. Yes, that's okay.
Okay. So what we're going to be talking today about is the balance tutor, and Dr. Jenny, again, thank you for the invitation. I'm looking forward to sharing this information with you, and we'll go quickly through it, and I'll be introducing Chris at the end of this for question and answers, clinician to clinician, if you have some. Basically, the balance tutor got started about 10 years ago in Israel. And they won an award at the national project by the Israel Ministry of Health in a fall prevention in the elderly competition. And that kind of spurred a worldwide interest in the balance tutor. And in the previous slide, which I skipped, we're now sold all over the world. Balance tutor came to the US in 2020. We introduced it at the APTA CSM show in Denver. Everybody knows what happened right around February in 2020. and things didn't kick off well with COVID right away in that first year. Tough to show a product, this type of product, over the internet. So what we did was we built a mobile showroom, and we've been traveling the country now for about 2.5 years, showing clinicians the Balance Tutor and the 3D Tutor Station, and really letting people experience four directional perturbation training. And what is perturbation-based training? It is basically a task-specific intervention aiming to improve reactive balance control after the loss of balance and in a safe and controlled environment. And that's what the Balance Tutor does. We give lateral, medial lateral perturbations and forward and backward perturbations at 30 different levels of intensity. So very customizable. What you see in this video is the Balance Tutor moving, and we put a safety tape around the Balance Tutor because it will knock you off your feet. It always moves at a reactive speed of roughly 280 to 300 milliseconds, no matter how far of distance or amplitude it moves. It always moves at that speed. Obviously, when you move further and have a high amplitude, it's an extreme perturbation. The belt goes at 4.3 miles per hour, and there is an instrumented deck underneath the running belt. We have a safety harness, and you can see Alan Waterman, who is a physical therapist that works at MediTouch, putting it on. Very simple, less than a minute to apply. We have over 8 different size harnesses to meet virtually all sizes. The Balance Tutor can take up to a 300-pound patient in the harness. Very simple. And again, there's how it moves. So basically, as I traveled around, and I'll share some experiences as I go through this presentation, as I traveled around the country over the last 2.5 years, what I do know is everybody is aware that perturbation training works. And there's plenty. If you do a PubMed research, it's over 300 results. We have 11 actual research articles done on the Balance Tutor in the US at this point, on various different types of patients, Parkinson's, stroke, and more coming out in the orthopedic area. Some very, what I think, game-changing publications will be coming out by Dustin Grooms at Ohio University. Very exciting stuff in orthopedics. But therapists, by and large, all are doing perturbation training. They're doing it in very different ways, maybe pulling sheets, pushing the patient, etc. But here again, I'm showing just some of the articles that are out now using the Balance Tutor. But therapists are doing perturbation training now and proactive training now. By proactive, what I mean by that is the patient's able to make a compensatory adjustment prior to the event. So if I'm reaching for something or if I'm moving, I know what to expect. I can plan for that. What is lacking in therapy, and what I mentioned and therapists are trying to do, is that reactive response, that slipping on the ice where I either take a compensatory step or I go down. It is strictly reactive, no time to plan. But how do we do that in a clinic safely? Well, you can do that now with a Balance Tutor. So what the Balance Tutor, as I mentioned, brings to a clinic, and right now, there's really doing this type of 4-directional perturbation treadmill, you're looking in the $800,000 to $1.4 million range. So that's why you don't see this type of training in a clinic like we do. So what we bring to the table, and we're nowhere near that, by the way, we bring safety to the patient and the therapist. I've actually had therapists tell me they've been given black eyes by patients when they pull a sheet. Patient hits them. So, kind of dangerous for both. We can elicit a effective perturbation at 30 different levels of intensity. So whatever level of intensity we need to use with the patient to get the desired challenging result, we can use. So basically, if they can stand on the treadmill, we can do in-stance perturbation training with them at very, very low levels, hardly noticeable. We can customize the treatment during in-stance or during gait. The treadmill, as I mentioned, goes 4.3 miles per hour. It's reproducible. All perturbations are reproducible and stored in a computer. So we know what's going on and we can reproduce it and monitor it from treatment to treatment. And as I mentioned, there's multi-directional perturbation, anterior, posterior, and medial lateral. We also have a gate phase trigger, so we can customize it because we have a force plate underneath the deck. We can customize whether the patient's in stance or during swing phase. Very important, especially with a stroke patient where you may have a hemiplegic right side and you want to work on hitting them with perturbations when they're on their involved side, or you may want to do, for instance, crossover stepping when they're in swing phase. You can program the system to do that repetitively. Very difficult, if not impossible, to do in a clinic today. And we have objective documentation from normalized reports such as a gait analysis report to a modified CAT SIB. We also do another report that would compare the patient against themselves. We call that standing stability. So you can virtually run a report in 30 to 45 seconds every treatment to see how they do in stance in all four directions at different intensity levels, showing progress on how they handle the perturbation. So when we talk about the perturbation, we talk about reactive versus proactive. You can see on the left when I hit the video, he's going to be hit with a reactive response. And you can see the speed of that response. He's got to take a step or he's going to fall. On the other side is the proactive response, which we are asking the patient to take a step backwards. Now, this could be he could be watching a game or whatever he could be doing and just make a step backwards. But he has time to plan for that. The one on the left, the reactive strategy, we're working fast twitch muscle fibers. On the right, we're working slow twitch muscle fibers. Here's the videos. You can see he's got a step or fall. On the right, this is what we're talking about. Obviously, he could step faster, but he's planning that. The reactive happens much faster. So on the left, pause this on the right. On the left, this kind of shows the proactive response and the reactive response in day-to-day life. On the left, what we're seeing is a caricature of a person that's coming up on a corner and going to make a turn. As they're approaching the wall, they slow their gait, they may drop their hips, they turn their hips, and they make the corner. It's all planned. They're looking at what's coming ahead and making that visual plan and movement strategy. On the right is the reactive response. You'll see a gentleman trip over the extension cord and he has to take a step or he will fall. Left, proactive. She's planned it. Right? So how do we train these things in a clinic? Well, first of all, what we typically do now is we have sensory inputs, and we have several ways to train these sensory inputs, this eyes, ears, and feet, if you will. Posturography has been used, and I sold that system for multiple 18 years. And Lou Nash, the inventor, is actually who brought me to this product, believing it was the next step. What Balance Tutor does that all these other things do not do, and all of them are outstanding and needed devices, proactive testing tools, etc. But what they don't do is integrate sensory and motor at the same time. And what that brings to the table is when you're doing sensory, vision, proprioception, vestibular, and you're hitting it with a motor reaction at the same time, you are stressing more of the senses, thus challenging the balance system more. What that does is it speeds up the learning process. And I've seen that as I've sold this product over the years, and you'll probably hear that from Chris. So who is Chris? And you'll meet him, and I want to make sure I'm on track here, and I'm going to bounce real quick off this slide through several more because I want to give Chris some time. But we have just started a new video series called Balance, and it's on your chat, called Balance Tutor Masterclass. There's 15 short videos of Chris using the Balance Tutor as he would in a clinic. Here's a sample of one of them.
Specialist in neurologic physical therapy. I went to Midwestern University and graduated, went to Northern Arizona University for my neurologic residency with Honor Health. I've worked in all settings in acute care, inpatient rehab, and now in the last 7 to 8 years of my practice have been in outpatient neurologic therapy. So I've had
Everybody hear the video?
To work with the Balance Tutor. The unique part is that nearly my entire caseload consists of those with neurologic injuries. I've also presented a case report at CSM that highlights the abilities to improve one's balance utilizing the unique features of the Balance Tutor. The primary goal for everyone who suffered a stroke is to be able to walk again, with the ultimate goal of walking independently. The Balance Tutor allows just that. We all lose our balance, but the ability to catch oneself when a loss of balance occurs is the difference maker. The unique component of this treadmill is that it offers a 4-way reactive perturbation component to it. So the Balance Tutor utilizes key components of motor learning, which are use-dependent or task-specific training and sensory-motor adaptation. So now we're talking about using the motor cortex, the spinal cord, and utilizing the use of the cerebellum to correct predictive responses, matching them afterward with a perturbation, and then the correct response, which will then help improve stepping reactions, improve confidence, and reduce the risk for falls. The natural progression of a balance reaction begins at the ankles. What happens is, with a small perturbation, there's a use of the flexors, either the dorsiflexors in the front of the leg or the plantar flexors behind the leg. As the perturbation becomes larger, there's now a use of the hip strategy and then the trunk strategy. And that's the sequential progression there. So it's ankles, hips, and the trunk. And beyond that, if the perturbation is large enough, we're going to utilize a stepping strategy to help catch ourselves.
So what we do, coming back to that, that's Chris, and you'll hear more from him in a minute. What Chris does when he's customizing the treatment, he works on the operator screen. And as you see at the top, you'll see in kilometers, it would be miles per hour in this country. But we have from 0 to roughly 4.3 miles per hour that we can go from in stance, 0, to ambulation at a pretty good clip. Trust me, you'll never go to 4.3 miles per hour. We also have 30 levels of intensity. Here's the direction. So as the patient's standing on it, perturbation to the left, to the right, forward, backward. We can adjust these however we need to challenge the patient. I mentioned earlier we can challenge a stroke patient during right swing or left swing. So if it was a hemiplegic right swing and I wanted the perturbation to happen when they were on their right leg, I would choose left swing. If I wanted it to happen at a 5-second interval, in other words, every 5 seconds they're going to be hit with a perturbation, I can choose the direction, random, timing, very, very customizable. We also have proactive gaming. For those of you that are familiar with limits of stability testing or training, we can set up limits of stability outside of this based on the patient's abilities, and we can set parameters and let them shift their weight out to hold it, come back to center. Go out, hold it, back to center. We handle all kinds of gait abnormalities. And one thing that I have you can't do in a clinic, and I've yet to have a therapist in 2.5 years tell me how they would do what the balance tutor can do in a clinic, specifically vestibular gait. We can do VOR and VSR training at the same time safely. Very, 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 very cool. Here's a challenge. You can see a gentleman just working on step initiation. I'm going to go through these videos very quickly. Now he's working on that crossover step during ambulation, and the therapist is working on the monitor, which I just showed you. This is a TBI patient working on just step initiation, great for Parkinson's patients. Whoops, hold on, let me go back to that. I can make him step forward or backward. Here's a sample of the gait analysis report, very important to take a look at. We have normative data on left leg, right leg, coefficient of variance, very nice report. Like I mentioned, we also have a modified CAT SIB. I want to show you one quick video of this is, I don't want to say typical, and Chris could probably address this better than I, but we usually hear from therapists 10 to 12 visits. We start seeing some nice, very nice results. So here's a MS patient. She was diagnosed at 20. She's now in her mid 30s. She has 2 young children. And this is when she came in. I just want to give you an idea of the progression. Whoops, my bad. Always at this point with a walker. As an assistive device. As we talked about, starting off with instance training, you can see him working on the keyboard on the operator screen, which I mentioned. She's very unstable, but she's starting to figure this out. What I hear the therapist telling me is that patients come back to them fairly early in rehab. Now she's worked to gait, fairly early in rehab, saying they feel more confident at home doing other things. They want to get on it because it challenges them. And Chris can probably address some of that as well. And treatments. Now walking without a walker. And her results. I'm going to skip through these videos because I want to bring Chris on. I do want to point out you can bring assistive devices onto the treadmill. You can use it for concussions. You can use it in sports medicine. I mentioned some great ACL research that's coming out. Pediatrics, more pediatrics, orthopedics. Great stuff going on with prosthetics. Patients that have had strokes 6, 7 years ago can benefit from the treatment. I want to just show you this because I'm not going to have time to show another video. This is a vestibular patient. Bounce this up a little bit. And she's playing a game. Let me see if I can get to where she's doing it with her head. Oh, not going to show it. So we have another system that works with the balance tutor called the 3D tutor system. Basically, the patient would be on the balance tutor, turns and faces the TV, which can be moved further apart, and they can do all kinds of visual training while being pertubated, such as saccades, pursuit, visual flow, optokinetic training, over 31 games to choose from with head movement. Really exciting stuff. As I mentioned, VSR, VOR training at the same time. And this system, the 3D tutor station, can be used away from the balance tutor as well as an independent tool. You could start off with foam pads, wobble boards, etc., and use that just for visual training and balance. This is what it looks like. I'm going to skip this video. I just want to point out that virtually anybody that has that wants to walk or ambulates can benefit from this type of training. And I think it's a whole new area that is just in its infancy of what we know and where it's heading. There's a reason why we call the brain the motor. It drives everything, and we're really tapping into that. So I would like to end my share there and stop talking, see if somebody else has questions, and if Chris is there. There he is.
Hey, good morning, everyone.
Thank you for joining, Chris.
Of course, of course.
So I wanted to let everybody know, first of all, that Chris just did a video series, as I mentioned earlier, 15 videos, outstanding things that he does with the balance tutor. Very creative guy, and I think you'll enjoy him. I think you'll find that in the chat. And Chris, could you share a little bit, if you would, about some of your experiences with the balance tutor and what you think?
Yeah, no, I think I alluded to it a little bit in the video. Actually, everybody can hear me, right? Before I start talking. Okay, perfect. Jenny, thumbs up. So I've been using it now for probably five years or so, I think. Just
real close.
About four, just about five. And I think that I've put everybody under the sun on there. We were just talking about different neurologic conditions, right? We were talking MS with latency in terms of muscle recruitment and motor response because of the demyelination of the nervous system. We talked about Parkinson's and reactive postural control. We talked about TBI, or even, I guess, more so, I've put more concussion, those with concussion on there recently. There's some new research that's coming out with latency and neuromuscular control in the lower leg after a concussion that I actually haven't even talked to you about this yet, Todd, but some new research that's coming out that's showing that they're more at risk for injury with orthopedic conditions such as ACL, MCL, medial meniscus stuff, that unhappy triad. And they're finding that latency after concussion. So using the balance tutor then in that way to regain that neuromuscular control in that stance phase and working on that quick twitch reactive fibers, so those type 2 fibers, right? So let's see, I've used it with, obviously, I think I've used it probably with stroke as my main diagnoses I've used it with, working on, as Todd alluded to, the right and left swing phases. The balance tutor can really break it down to where oftentimes early on in rehab, you get this abnormal focus. I shouldn't say abnormal, but there's a more attentive and focus on the hemiparetic side, right? So the weaker side. And as you step through on the weaker side, you kind of take a short, quick step with your strong leg or your good leg. And so you get this abnormal gait pattern where it's actually a larger step length on the hemiparetic side, and then it's less stance time and less of a step length on your good leg. And so what you can do is then you can isolate that on the balance tutor, and you can work on this step length symmetry, time and stance phase, the symmetry between those, and really get a lot of blocked practice in, building confidence in the harness. And you also have those handrails you probably saw briefly in the video, but they kind of come down and extend down. So I love using those to help with grasp and weight bearing through the paretic upper limb too, trying to get full body response through the arm and through the leg. So that is probably all of the diagnoses that I've used it with. I mean, and then vestibular. I use it with people with 3PD, vestibular migraine. Sorry about that. I've used it with those just rehabbing from a neuritis or a labyrinthitis, and working on just simple gaze stabilization progressions. They have optokinetics on there. They have a couple of cool games they called Helix Jump, obviously working on VOR. And then you can set the parameters. So I like to try and get only about 20 to 30 degrees, right? Because you don't really need too much more than that to really stimulate things. And then, working on speed and accuracy while perturbating them, which I think is key. And a key feature of the balance tutor is that you can perturbate them and cause and create a loss of balance that they might replicate over ground if they go to turn their head, right? So you're looking then at that stepping response, that stepping reaction, and trying to work on the entire system and the transference of that now to some kind of situation in real life where they're in the community and they're walking, they go to turn their head, you're talking to a friend, looking at cars, whatever it is. And then it's like, whoa, I lost my balance. And you also, so not only are you working on the vestibular system, but then you have to have a stepping reaction too. So you have to have the reaction postural control. So it's just tying everything in there. So that is the quick summary of just a couple of things that I've done with people. But I was actually just reading an article, and I think Mike Studer was, he had an excerpt on there about reactive postural control or reactive balance training, right? And that's what the balance tutor features. And they were in the study, they looked at the carryover, the timeline, the transference, and they were saying that it really only carried over for 2 months maybe of gains, and then they have to they wean off, and then they need to go practice in the community or do whatever. But I feel like the uniqueness, where the balance tutor comes in is like you can continue to bring those people back to feature them on the balance tutor to really go through a 6 to 10 session progression where then you just hone in and you work on those stepping reactions, and then you bring them back periodically throughout the year. Maybe it's quarterly. It depends a lot on insurance, right? Where you're at, the medical model, but working on those things to sustain that. What I found in one of my case studies at CSM, I presented, I think in 2021 or 2020, one of the two. I had this gal on there, chronic stroke. She had, I think, a total of, I don't know at the time, but I know she had a total of 14 kind of microhemorrhages and ischemic strokes in the cerebellum, basal ganglia, just in the cortex. And we put her on the balance tutor. And before this, I should preface this, before this, I was pulling her around with the bungee, right? In the clinic. That's how you work on reactive postural control is, you get her on the bungee. Well, we got the balance tutor in. I put her on that in that harness, and it allowed me to objectively quantify the level of the perturbation and then control the timing of it in the harness. And then I don't give her any sensory feedback by being on the band or being close to her. So it's really all her. And then she really that's when the motor learning really kicks in. And her FGA score went from like a 12, I think it was, to a 21. Don't quote me on that. Todd can send out the study, but it was a big jump. It was obviously way more than the MDC. I think the MDC for her age group was about 4.2 or about 4 to 5 points. So, and that had been the biggest jump that I had seen throughout. I had seen her for multiple episodes of care with recurring strokes. And so I think that was probably my 4th or 5th episode. And I was like, holy cow, like this really works. I had her on there 10 sessions, maybe 12. And I was like, whoa, like we just saw a big jump in her stepping reactions, her confidence. Todd touched on that a little bit with confidence. So that was a lot, and I brought a lot of energy, but anybody have any questions or have any questions for me or want to talk to me?
Chris, thanks for joining. I put all your information out there and updated your email and he's always posting really cool stuff on Instagram. I encourage you to follow him. Very creative guy.
Yeah, thank you.
Thanks, Chris.
It's the neuro guy and then underscore DPT for the Instagram
Thank
site or
you.
whatever
Yeah.
it is. So
It's
all right,
my
you
first
guys.
time to meet Chris, so I haven't met you. So nice to meet you, Chris. We
Yeah,
will
nice to
follow
meet you
you
too.
definitely. I'm Dr. Jenny. I'm based in Delaware. So thank you so much for joining us. Definitely, if you can put your other like email. Yeah, the email is here already.
Yep,
And then
yep,
other
perfect.
things in social media because Todd just said that you're posting great things and I definitely will email you. I think I emailed you already about your link. And that's really great point about that. And thank you so much, Todd, as well for bringing Chris. We're
Thanks
always
again.
Yeah,
Mhm.
thank you guys. There's my Instagram there, and
Uh-huh.
I appreciate your time and letting me speak. And I'll turn it over to you.
Thank you. Guys, if you
Thank
have
you.
any questions, we have the QA and then definitely Todd can still put some comments there on the chat. So thank you guys. And we have as well Sheila. Let me share something here first so we can introduce Sheila properly. All right. Wonderful, wonderful topics here, guys. All right. So here. All right, so we just want to say thanks as well with Urban Polling. They're one of our sponsors when we have the Geriatric Rehab Summit, okay? And then we have these wonderful things about them. And let's hear a little bit of ads and reminders from our friends from Urban Polling.
Hello, my name's Joy Cochran. I'm a doctor of physical therapy and the clinical evidence specialist for Urban Polling. Activator polls were introduced to me in 2018 and have been pivotal in elevating my clinical practice. Initially using them only for my patients with Parkinson's, I soon realized their relevance for so many of my patients, which I specialize in treating people with neurologic conditions and older adults. Realize the possibility of the activator pulls is to put the pulls in your hands and the hands of your patients or clients. Their versatility is endless, from sitting exercises in an acute care setting to using them as an alternative to standard assistive devices to an urban polling community class. The activator pulls can elevate your impact on the people that you serve. Thank you.
Yes, thank you, Urban Polling. If you attended the last GRS or Geriatric Rehab Summit, they were with us, and then Julie from Australia was one of our speaker. Okay, and now for our next speaker, and we have Sheila Tellen. She's the president of Vestibular Training Services and master rated figure skating coach. Sheila presents an engaging session on the role of spinning in enhancing vestibular function, balance, and cognitive processes. Drawing from her expertise in figure skating and athletic training, she highlights how rotational movement stimulates the vestibular system for improved stability and mental acuity. Sheila also introduces innovative, patent pending, but I know it's already patented, athletic training tools designed for both elite athletes and general population, making advanced vestibular training accessible to all. This presentation offers practical insights for anyone looking to improve physical performance and overall functional health. All right, so I would love to give the floor to Sheila, and I will going to share this here. Definitely. All right, you're not on mute, right? You're
Oh
good?
no, I'm all set.
Okay.
Hi.
Hello, everyone. We have Sheila. All right, I'll give you the floor, Sheila. Thank you.
Oh goodness, thank you so much for having me. I'm always honored to do these projects, and it's just a huge opportunity. So thank you.
My pleasure.
We talk about sports and we talk about sports training, really taking world-class sports training and bringing it down to the general public. And it's been a huge, exciting project for our company. We're actually an old company. We're a 28-year-old company. We've been doing harnesses and spinners. I have one in the background just sitting in the middle of my dining room because everyone has one in their dining room. That we really have an old company. So with that, about 10 years ago, I was meeting with other world and Olympic coaches, and we were standing in Colorado. And I'll be honest, we were at the bar having some adult beverages, networking as coaches do. And at that meeting 10 years ago, one of the coaches standing next to me says, "Oh, I have dizzy athletes." And I was like, "Oh, I don't." I don't ever have dizzy athletes. My figure skaters can spin like crazy and they just take right off, even the young ones. So that kind of started a little dinging in my head, like, "Oh, that's weird." And then the next coach talked about he had some kind of dumb athletes. And I was like, "Oh no, not figure skaters. That group is brilliant to the point I have many athletes in college classes, even in eighth grade." I mean, I really have brilliant children that I work with. So then I thought, "Oh, well, that's weird." And as we went around the circle of all the other coaches' problems, none of them were mine. And I just thought that was really like my head was just going nuts, like ding, 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 ding. And the fact that what are we doing different in figure skating than all the other sports? And the answer is spinning. So I spent the next 5 years really researching everything I could learn about spinning and brains and neurology and, of course, the vestibular system. So we expanded our company in 2020. So it was nice hearing other people talk about expansions in 2020, which was a horrible time to expand your company, and we did. So in 2020, we brought the product of spinning and very figure skating harnesses to the general public. And of course, we slowed it down. So I'll show a couple of my videos here in a little bit because some of them are shocking. But we keep using this word vestibular. And I kind of call it the orange car theory because nobody buys an orange car. Nobody. I'd never bought one. No one I know would buy one. Like nobody owns an orange car until you go out driving today and you notice there's 12 orange cars out on the road today because now you're looking for them. Something you never noticed before, but they're out there. So just like the word vestibular, you've never heard it before, but now after today, you're going to see the word everywhere. So your vestibular system, they always refer to it as these three semicircular canals. And this is actually from Vestibular First. They have these great, look at how great these are. I love Vestibular First. They have some of the best little mock-ups of everything. They're just a wonderful company. So I want to thank them. I actually got this at a conference in the UK. I took everyone's on the table. Just that's me. Anyway, so with that, the vestibular system is, so if here's my eardrum leading into the vestibular system, and the vestibular leads out into the cochlea, which is that nice kind of curvy section that's kind of right. You see a lot of children with like cochlea implants that are deaf. So that's a little bit more the hearing section. But the vestibular system, these three semicircular canals, have like a gooey gel in them. So it's like a gooey gel that moves through there. And it's not watery, it's very jelly-like. And then on the inside is like a silica hair. And on the outer canal is what they call crystals. They don't really look like crystals, but they're these little lumpy figures that belong in the outer canal, but sometimes will fall into the inner canal. And I always think of those people as people with concussions or people that ride in Humvees or rodeo, joggers, like the people with a lot of head movement, and a vibration that those can fall out of there. And they end up in the canal. And the best way to describe that when the crystals fall, it's kind of like trying to drive on the freeway with a whole bunch of parked cars in your way. So the data is not moving through smoothly. And those people are really suffering. But when I think of people with crystal problems, they're really suffering in their lives and having a hard time communicating why they're suffering. To the point, I hear people say they've been to 10, 12, 15 doctors before they end up in it with an audiologist that can help even just diagnose that. So as we talk about the vestibular system, what I'm really doing is I am spinning you gently. And I keep going back to the word gently because, of course, I have crazy videos out there of kids going insane on the gear, which, of course, I have to show just because I love those videos. I think they're really, really fun to watch. Yet, when you see the reality of how people really move through the world, those are some slow videos. So we do have a patent on our fly system, which I'm going to show, and a patent pending on our new rail system that's only been out a year. So I'm very excited about that, So let me just quick screen share because I have some stunning videos and some lovely data really showing how these people are improving. I'm sorry, I also have a really, really busy desktop. I'm that person. So, okay, can you see my desktop? It looks like the Sydney Opera House. Do you see it?
No, we're seeing like that Zoom.
Okay, you're
That
just seeing the Zoom
trying to
sign here.
remove.
Okay, hold on. She's, oh, I hate it when this happens here. Hold on. Okay, it's got the Zoom thing. Oh no.
You need to share exactly what you want to, like
Yeah,
you
it's
need.
not giving me a share option from that point. Oh no. Okay, hold on. Let me stop sharing here. Hold on. I have a lot of options here. When technology fights me, I have a million options here. So I'm gonna just hold up the screen. It's not real sexy here, but I have really some amazing videos. I'm gonna just start with my one crazy video, just because I just think it's shocking to see what the kids, and we're having lovely results with ADHD kids, which I'm really honored by. So here is one of my favorite videos of one of my girls that we're just going to accelerate her on that spinner. David's going to lift her, and holy smokes, look at this kid spin. 5.5 turns per second. Axis, balance, proprioception, midline cross. That vestibular is screaming as she's doing this work. And she's got to focus. She has to talk. She has to follow directions. She really has to learn through the chaos. And of course, at the end, she's going to tell us she's not dizzy. Okay, coming down. And then, of course, the most amazing part to the whole story. Okay, how dizzy are you? I'm not dizzy. Not that dizzy. Not dizzy at all. Thanks. Have a good. And of course, even NASA called me and they're like, how'd you do that? And the answer was, I trained her, and it just took nice, consistent training. And this is where we really see the improvements. I'm going to jump to the exact opposite situation, and that is my concussion patients. As we talk about vestibular, here we go. Here we go. Watch this. So, concussion. Vestibular, balance, cognitive, spatial, and sleep. Okay, so hands up. Okay, so we've got a lot of new skills that he's able to do now. So we've got the midline cross using both sides of his brain and keeping that active. Okay, I'm short enough that he can slide right over my head. Okay, all right, hands down. And just right hand. Here we go. Bring that in. Look at these balance skills. Look at that midline cross using both sides of his brain at the same time. Okay, that hand down, other hand out. Okay, just try to bring it in. Love it. Look at these skills. He's flying on this gear too. The question I always get is, what speed is he at? He's at 30 out of 100. Great. The This used to be so hard. Okay, all right, ready? And then both hands cross. And then, okay, here comes the stop. Okay, so I'm gonna stop towards the camera. Ready, stopping. Feel your brain. Feel it all come together. Feel that alertness. And his sense of humor's come back too. That's the one thing that I think is the cutest. So welcome, come try and stay with me. So we talk about concussions, the group. And, when we really came to the general public, our goal was to really see how many people we could put on the gear. So in the last 5 years, even I'm shocked at how many people we have worked with. Everything from children with autism to ADHD children, the average kid, the good old average kid, the elite athletes through Olympian level. We have worked with NFL, NBA, NHL, pro rodeo, pro motocross, pro rugby, all of these top sports, especially gladiator sports have really been working with us. We're really honored by our work that we've done with the U.S. military. We've had a batch of Navy SEALs and a batch of Marines, Army, especially we worked with the Golden Knights, the guys that jump out of the airplanes 14 times a day. Fascinating group to see our work with the military and these improvements. We talk about the aging population. We also work with, I'm going to just quick drop in just a quick aging video here. And it's one of my favorite stories because my favorite aging video is my mom. And with that, my mom, she had the goal, and I'm going to be honest, my mom likes to sit and cross stitch, and so she's not active. She's not a big walker. She's not, she doesn't enjoy any of that. So she likes to sit and cross stitch, and so she's not very active. But she wanted to do one of those Viking riverboat cruises. So to fly from the United States to Europe, on the boat, off the boat, on the bus, off the bus, stairs, oh my gosh, uneven cobblestones of Europe, churches, like she really had goals of a 3-week trip. So she worked with me for once a week for 5 minutes on our gear for the 6 weeks prior to the trip, and then went and did this huge vacation. And I'm gonna say too, one of our other projects, and the other speakers have spoke about it too, is the famous modified cat SIB test, okay? Every PT loves to talk about these things. And really what the testing, and we use a company called Balance Tutor, is our favorite little company. Yep, there we go. The Balance Tutor. We love them. Balance Tracking Systems, phenomenal. And Balance Tracking Systems has this modified cat SIB that we can really see the results. And what they really are, we do a ton of pre and post testing, with the pre-testing being 20 seconds eyes open on a solid surface, 20 seconds eyes closed. Then we add some foamy instability underneath you. Same test, 20 seconds eyes open, 20 seconds eyes closed. Then, so we get a nice baseline for everyone. We spin for 5 minutes very gently, and we come back and retest. And we have phenomenal data that we can see from this company. And my favorite example is actually one of our employees who went from 16 inches with his eyes open down to 16 centimeters of movement, eyes open, to only 12 centimeters, eyes open, after having worked with us. So there's an improvement in balance after having worked on our gear. So he went from the 55th percentile to the 86th percentile. And so we have tons and tons of data of all these different examples. And we really do see these improvements in eyes open and eyes closed, and on that foamy surface, eyes open and eyes closed. But here's just a quick example. And I'm going to just kind of talk it through here a little bit. But you can see it's my mom, and she's going to just start out very slowly and very gently. And she's going to spin, and then she's going to and she loves that midline cross, and just keeps getting better and better at it every time. I can control the speed and the direction, and then I just step on the pedal because, it's really, really easy gear to run. But you'll notice Look at, we just start very gently and we just keep this very gentle rotation. So where the kids can go insane on the gear in crazy tilt-a-whirl fashion, the adults cannot. And we just gently come forward with this gear. And of course, with that pre and post testing, we can really show the improvements of that vestibular system from that gentle spinning. Nothing tips on you. I love the last presenter, phenomenal. Like I watched that gear and I'm like so inspired by it. But there's a vibration through the bottom of the spinner that you can feel slide up your head. So there's a nice vibration and there's a sense of zen to our product. I think people have the assumption that it's a sense of vertigo when you work with me, that spinning, it'll make you barfy, it'll be too much. And in reality, that's not the feeling that we create at all. So the goal is to get you stimulated, but not go to that point beyond. It's not a tilt-a-whirl. The goal is not to make you vomit. I can, but I wouldn't do that to you. So the goal is to just get it just gentle and stimulated. And those are where we see so many changes in that gel moving through that vestibular system. So we have a ton of questions all the time about, well, how can we do more? And we've added more projects to it. We've added more vision training that we can add while spinning, which has been very successful. We've seen a big improvement in people's, especially eyes closed on the foamy surface from adding the vision training while on our products. We also have we like to pre and post with lots of different companies. Our favorite is NeuroTracker. So it's a moving ball game called a NeuroTracker. It's phenomenal. They're a worldwide company, specific. Their specialty is pro soccer. They've changed the whole sport of pro soccer at NeuroTracker. So we pre-test with NeuroTracker. You track those balls. The game speeds up as you speed up. The game slows down as you slow down. And then you spin with us and you retest on NeuroTracker and your score goes up, which is part of the cognitive side. So we talk about that modified CAT-SIB. For sure, there's your balance answer. So the 4 biggest parts of vestibular, the first one is balance. So that's where we track it with balance tracking systems. And then the cognitive side, where we track with NeuroTracker. So we can really see that speed up. The third is spatial, where we see an improvement in spatial. And that's where we also, we get a lot of data from people's driving skills improving, especially going back to my aging population, that they really can still track what's moving as they're driving. We also talk about fighter pilots and driving skills. It's the same thing. Our 4th biggest part of vestibular is sleep. So I always want to come back to the importance of sleep as something that is easily lost in our society, that, oh no, you don't need sleep. I'll sleep when I'm dead. That's great. That's a nice slogan for productivity. But at some point, you're not productive anymore because your brain needs sleep. That also ties back to suicide. And the data coming out of the military is that really the war fighter goes 2 days without sleeping to the point they've hit a manic state. And that's really the rise in suicides in that group. That ultimately, I've heard people say it's unstoppable at that point. But my argument is it is stoppable if you got them to sleep. If you didn't hit that 2 days of no sleep, you wouldn't have hit that manic state. So there's a big connection there. When we talk about sleep, then I also want to rotate back to not just the military, but I want to talk about our children who are not getting enough sleep. And there's some wonderful new papers that I'm sure Todd Gilbertson, who just spoke earlier, could talk about, is the rise of lacking balance and anxiety. So as your balance is failing, so does your anxiety comes up because your brain knows it's in a struggle phase. But we're seeing that in children because the children are not moving enough. That vestibular system is not moving and flipping and rotating and playing outside and jumping out of trees and on a spinning device. We had those as kids, Although those big metal spinning thing, oh my gosh, they were so fun. I fell off it as a kid. It broke my wrist. It was the best day of my life. They took it out, and that's why they're not out there anymore. But our children are lacking movement. And of course, the children are spending way too much time on screens. And so because of that, there's a rise in the anxiety of the children. And I don't think we need research papers on that. We know this as parents. We know this as grandparents, that these kids are just not moving enough. So a call to action on that from all generations. Take a big breath here and talk about, we have our product worldwide. We have gear worldwide. We love to team up with other projects. We love to team up with other companies. We're doing a project in a major fitness company that'll be announcing in 30 days. I keep saying 30 days. I feel like I've been saying that a long time. But in 30 days, we're about to announce a major partnership. But the companies teaming up in the project are myself, NeuroTracker, Dynavision's Interaction, where it's more of like a tap board. Another company called Maverick, which is a 3D domed product with a whole bunch of light pods in it, and you have to move throughout the pods are above you, behind you, under you. It's an amazing workout. I really enjoy that project. And then of course, our favorite balance company, the Balance Tracking Company. Woohoo, we love these guys. So we'll be able to pre and post test on all of these products and add in the spinning through this major partnership. We are also partnering with a lot of other great companies that'll be joining us eventually in more and more neuro rooms. Moving forward with neuro rooms, I think are really key to our society in ways that we can help our children and we can help our aging population, and we can look at rehabilitation and human performance together. That not separating the two, but really looking at them together as one human being. So I want to welcome you all to quick do some questions. I have 1,000 videos on our website that I'll throw in right here. Our website is spinyourbrain.com. We also have a chief medical officer that is available for anyone that has high-end medical questions. We also have a PhD research coordinator based out of the University of Minnesota if people want to write papers with us. We have a head PT based out of Delaware for those in the PT world that would have PT questions. He's a brilliant PT. I'm honored to have him on our staff. In addition, I invite you to go to pubmed.gov. Okay, pubmed.gov, where and you search vestibular plus whatever your issue is. Vestibular plus balance, vestibular plus autism, vestibular plus sleep, vestibular plus anxiety, vestibular plus aging. You just search your mind out. It's a free website, pubmed.gov, and there are over 52,000 papers already published on vestibular. So where I talk about the word vestibular, you're going to see it everywhere, but it's your entire balance system. And so when it's not working, there's your entire balance system out of whack. And my favorite is, what is vertigo? It's a pooling of the gel on one side of the canal. The other sides go dry, and boy, you're crawling to the bathroom. You're really, it's terrifying when that vestibular system is out of function. So we really do work on it, and it is trainable in the minds of our company. We have lovely research, even including people that are amputees. Our work also with autism has been stunning, although we don't publish videos on it, mostly because we feel like it's too personal. So if you are an autism specialist, do please contact us. We don't publish a lot on it, but that work is really important to us. Can you send the contact information to the PT in Delaware? Absolutely. Can you email me, and then I will send you that contact directly to the Crippen person that just commented. So here is my email, sheila@spinthebrain.com. And you can email me directly, and I'd be happy to forward on my contact of my PT in Delaware. Once again, brilliant. It's an honor. So that's right in the comment section. Just go ahead and copy that and just message me directly.
That's awesome, Sheila. I'm from Delaware. Maybe I can connect with her too. I'm
Oh,
not sure. I
it's
don't know where's
brilliant.
Deja from. Maybe she's from East Coast as well. That's why she's interested.
Oh,
Oh,
they're from Delaware. Yay.
we're
So
all from
everyone's going
Delaware.
together.
Yeah, maybe we can
And
connect.
we would really love that. And really, the goal is that people just get on the gear. The assumption is it's a vertigo feeling, and it's not. What it really feels like when you're done is instant. Really, the first time you do it, you see me always be like, ooh, like you can feel your brain come back to center. It's an alertness. It's a spidey sense. It's a sharpness. It's a reset. It feels like you got your shit together. And that's where my athletes always talk about it, that they just feel sharp and alert and ready to go in a way that they didn't feel prior to. And that's my concussion group too. Really coming back from that concussion in an innovation and an intervention that not enough people are using.
Good point, good point. Thank you, guys. If you have any questions for Sheila, definitely just put it on the QA chat. And we have already Deja asking some information and resources. But Sheila, that's really interesting about that the one that you said, that the lack of sleep, which is very important because that measures already the capacity of us to work, you know. We are just like floating when we don't really have a good sleep. I have a friend, she said that you don't need to feed me, but I need to sleep, you know. If she will choose between eating and sleeping, definitely she just going to sleep. Yeah, and then you can really see, guys, the difference within the people working at night versus the morning workers. That's definitely really very and I just feel bad when research or evidence based that there's a less, you know, time or age is high, faster aging process is faster when night, and then also their time lifespan is, you know, it's just like difficult to say, but it's like evidence based how important is sleep for us, you know.
Absolutely. And I always talk about when my children were little, I cried all the time because I wasn't sleeping enough. I cried all the time. And I never cried out, but it's because I sleep. When you sleep at night, that's when the brain cleans itself. That's when your brain rests. And without that sleep, that's where we all kind of hit that manic state. And I feel like as a society, we really need to look at sleep protection, especially in these growing kids. I stood in one of the ice arenas and was interviewing just kids walking by me. I'm like, how much sleep did you get last night? And the answers were 4 hours, 5 hours, 5 hours, 6 hours, 3 hours. And I'm like, how are you functioning? And to be honest, the kids aren't functioning because they're not getting enough sleep. Simple
Yes,
as that.
yes. Yeah, especially some students, majority of students, I just on when I was in high school, I think college, we have a very big exam, and then I didn't understand about the sleeping, but they always advise before the day of exam, you need to sleep because whatever you're reviewing is really not coming into your brain. And I don't understand that, but I said, "Oh, I really need to review because the exam is tomorrow." And then I do that and I compared myself to these very smart kids that they just party or sleep good the night before the exam. And I really feel that it didn't sink in whatever I reviewed within the last 24 hours and during my exam because I don't have a sleep. There's like a bulb in my head while I'm doing the exam is still really bright light bulb here, but it's not sinking in. So it's really important because that's how they regenerates, right? Our neurons, everything. So
Absolutely. And
great point.
my chief medical officer, when he got on the gear, we spin him, he stops, He can feel his brain snap. And his answer was, let's go take tests. Like as a doctor, his attitude is, okay, I feel super sharp. Let's go take tests. And I'm like, let's go do sports. So it was really interesting to see how the two of us looked at that brain snap very differently, that taking tests, but it's all tied together. And that's where we can really see improvements. Like I was talking about, like the balance is just testing balance. That's
Yeah.
great. Like great. That's one window of data. Yet at the same time, it's the sleep, it's the cognitive, it's the awareness. And that's where people have to have some introspection, although we can, of course, test it with NeuroTracker and Dynavision, and other companies can team up with that. There's also another great company called Neck Care, which sounds like a weird company, but it's a nice little laser on your forehead that you have to move your whole head and follow the movement on the screen, with that. And you have to just kind of move your whole body for it. But even the president of NeuroTracker that does it, or excuse me, the president of Neck Care, that even after he does it every day, he spun with me and his score went up 17%. So we have lots and lots of data, but in the same sense, boy, those athletes, man, I've got over 1 million athletes growing up on this gear with outstanding results in sports. So we're not new. We're just coming to the public. And we're really honored to be here. So I'll let everyone go, and thank you again. I'm so grateful for your time and these opportunities. Please contact me, and once again, thank you to you. I'm so honored to be here. Thank you.
My pleasure, Sheila. So I will connect with, and we will going to check all this information you said. We have balance trackers, neuro trackers, neck cares. Thank you for all these resources. And guys, if you have any questions, Sheila already put her email and chat. Okay, thanks again, Sheila. All right, so let's check out. We have another, we are almost like left to two. We're now going to an AI. All right, let's see. With Hello Note, all right? So let's see what Hello Note. Hello Note is a practice. It is an all-in-one therapy practice management, EMR, and billing software. So who here has an outpatient or maybe doing Med B? So these are your EMR software that you can run your physical therapy, occupational therapy clinic. And we will learn more from Steven, what are the different benefits or the different things happening right now with Hello Note, all right? So Steven is an occupational therapist, so we are physical therapists here, occupational therapists, and I really like to meet people. We have Swati, which is a physical therapist who innovated Age Wiser. And Steven is an occupational therapist who combined his experience, and now he has a good sense of what is going on around during the EMR. So he developed a nice EMR that will help like us clinicians to be useful in doing this kinds of different setting. I think you can do it in home health or Med B, in outpatient majority. All right, so let's hear from Steven.
All right. Hello, everyone. This is Steve with Hello Note, and thank you all for joining in on our Hello Note 2025 innovations and roadmap. So thank you all for joining. First, hope you had a great Thanksgiving, everyone. And now we're approaching the holiday season again with all the holidays of Christmas, Hanukkah, everything that you celebrate. And we are extremely grateful for all of you. And not only because you may or may not be working with us, but also because we value your feedback. So Hello Note is a product of the community we serve. Okay, so the ones that have been with us from the beginning, you know that we always try to innovate and not be stale. So every one of our users, whether it's a therapist, administrator, biller, front desk, and even patients, have given us feedback throughout the years that we implemented Hello Note. So I do want to personally thank all of our internal team as well. So that includes the engineering team, support team, onboarding, web team, customer success team, sales and marketing, and our affiliate network. They're extremely important to us, and without them, HelloNote would not be possible at all. So also wanted to mention that we did mark a huge milestone. We did finally cross into fully 2.0. That means all of the users from 1.0 are now officially on 2.0. And just over a year ago, we actually had our HelloNote 2.0 launch party, and many of you were able to join us in New York City. So that was awesome. If you didn't join us, then we actually hope to have another event next year. So, and that was just the beginning. We are here today, a little bit over 1 year later, and there's so much that we have accomplished and so much more that we still want to accomplish. And we do want to share our roadmap with you all. So the goal of the webinar today, of course, is to share all of the innovations or the roadmap that we have to offer in the plan. And we did ask for a Q&A. So I will be going over some of those questions. Actually, probably all of the questions that we had, because I want to make sure we get to everyone. And there is a Q&A on the bottom of the webinar on the Zoom. So if you want to ask a question live, please click on the button and we will get to you as well. I do also have a special guest with us. So it's Kara from Next Level. She created the Business Builder program, and I'm grateful to have met Kara, and she's going to share a little bit about her program and how many therapists we have helped to actually start their journey on a business, including those that grow or want to grow their business to the next level. So I'm excited about that as well. All right, so let's see here. So I do have a small presentation, but I actually want to show HelloNote as well. So let's see where, maybe just make sure everything is set up. All right, so for 2025, I personally am excited for 2025, and I hope you are as well. So every year marks an opportunity for everyone. Okay, there's opportunities all around us to grow our business, and Kara will share a little bit about that later, because over 100 therapists have grown and started their business just with Kara's program. So that is awesome. And again, whether you're a new practitioner or seasoned, there's always room to grow. Okay, so I personally have had the pleasure, every day I speak to practice owners, and whether you're small, large, it doesn't matter. There's always that common vision where you want to grow your business. Okay, whether you have a full caseload and you're good, you always have something on the back burner where maybe you want to delegate and hire somebody else, or you have a practice with multiple locations that is also something that you can grow as well. So to me, there's no limit, because I speak to therapists every day that run a practice, and I watch them on their journey. And that's what's exciting about my job here at HelloNote, is because I get to watch every single practitioner grow, ask questions, feedback, and personally, I do learn a lot as well. So I definitely learn a lot from every single practitioner, and like the insurance rules and guidelines, it's always surprising to learn something. And with us, we are very community driven. So every single feedback that we get from you, positive, negative, it doesn't matter. It all goes to our team, and make sure that from our team, it goes to engineering, and then it goes to QA, and then we bring that to life. So we're very grateful for our internal team, because they make it happen. Okay, so it's not myself or one person that makes things happen. It's a whole team behind the HelloNote product. So I'm grateful for them. Also this year, on top of being a milestone of actually getting to 2.0, getting everyone over to 2.0, we actually hired a customer success manager, which is exciting. And the reason for that is because we want to make sure that we're meeting our commitment to ensure that everyone is getting the product that you pay for, right? So we don't want to have any clients that are unhappy with using HelloNote. And if you are unhappy, let us know for whatever reason. We're going to do our very best to make sure that we resolve your issues and we continue growing. And we're grateful that you chose HelloNote, and we'll do our best to ensure your success. So without you as our partners, we would not be where we are. So I do encourage everyone to reach out, especially now that we have a customer success manager. We can ensure that everyone's voice is heard, and we do our very best for you. All right, so let's see. Okay, I see some questions already coming in. So just want to give a heads up that I will get to those towards the end. Okay, so if you do have questions, no problem. Just put it in. Towards the end, I will answer them. All right, so, okay, so the first, so we have this slide up here. I'm going to shift over to the next slide. Make sure. All right, here we go. All right, so the phase one of the HelloNote 2025 roadmap is something that we want to immediately focus on. Okay, so that's core features. So first is time-saving features. So again, from the very beginning, we focused on making sure that HelloNote has as many time-saving features as possible, whether you're a therapist doing documentation, whether you're the administrator or biller, front desk, it doesn't really matter. We want to ensure that you're using HelloNote and it serves your purpose of saving you time. So we do always want to make sure that we're listening to you and how we can save you time. So feedback from our clients included templates, right? So we do have those autocomplete templates that I know therapists are using. Then we built out the note templates. And of course, that was a game changer because now you can preload all the data and preload it right into your note. So our next step is to leverage automation, custom reporting, and also we're going to be using AI to save therapists time on documentation. Okay, and then we're also going to be using that for billing purposes to track denial rates to ensure that when you're sending out claims, if there's a pattern, that you don't get the same rejections or denials. Also reimbursement. We're actually going to be tracking your average reimbursement per insurance per note type, because of course evaluation notes will pay sometimes higher. So we want to give you those metrics to ensure that you're billing properly and getting the most that you deserve. Also front desk. So front desk, we are always building out new features, reminders, tools that I'll go over in a bit on how front desk can use time-saving features. One of the biggest time-saving feature feedbacks that we have actually is using the instant messaging. So this way you can just communicate with your internal team, which is really, really nice. So next is patient engagement tools. So we have tools for improving communication and collecting patient feedback. So back in 2020, when the COVID pandemic happened, we actually had to rush to release our patient portal. And now, we're some time away and things have changed, right? So things have changed. The automation has changed, AI. So we do have plans to bring more patient engagement tools, including a kiosk, where a kiosk mode, I should say, that you can put onto your office on your front desk to automate that check-in process along with intake and consent forms. So that is really exciting, and I'll share a little bit more about that later. So of course, documentation. So best practices, creating fast, compliant, and comprehensive notes. And the keyword here is compliant, right? Because fast notes do not always equal to compliant notes. So we are also building out a tool where therapists will be informed of how similar their note is to prior notes. So this, I personally think this will be a huge game changer for not only the therapist, because therapists, I'm a therapist myself, we want to treat, right? We want to help our patients get better, but more from the billing side and running your practice side, you want to ensure that if there's an audit, that you don't get money taken away, right? So at the end of the day, it does all come down to insurance and reimbursement. If you're insurance-based, if you're self-pay, then you're in a good position where you don't have to submit claims to the insurers. So yes, compliance is extremely important. One of the major things we focus on is Medicare compliance, because a lot of insurances do follow Medicare compliance and guidelines. And in our software, you can trigger that on or off, and you can actually turn on Medicare compliance for other insurances, such as Medicare Advantage, right? So that always helps a lot if you want to just have an extra safety measure to ensure that you are compliant. And then real life success stories. So I'm gonna leave this to Kara towards the end, where she's gonna share about the Business Builder program, and she's gonna share some testimonials and case studies from current members of the program. So very excited about that, because it is just as amazing as it is to hear therapists grow in their career. It's also amazing to hear where a therapist was able to start their business and grow. And there were many practitioners that grew to multidisciplinary practices in more than one location. So that is always a huge achievement and accomplishment. So I'd love to hear that. All right, next is our phase 2. So billing automation. So one of the things we really want to focus on for next year's roadmap is to automate billing. So I mentioned that a little bit, where we're going to use AI to track your revenue and average reimbursement. But what does that really mean, right? So we can't, of course, therapists have to do their billing, right, within the note. So therapists will be doing their notes just as usual, but we are going to be building out more metric systems for the front desk billers or administrators to run and notice any patterns or anomalies. So with that, you're going to be able to see a graph based on how your therapists are performing, which CPT codes they're billing, which one is higher than your average, which one's lower. Also adjusting your fee schedule, because you also don't want to bill too high, you don't want to bill too low, of course. So there's going to be a lot of metrics coming with that. So hybrid billing solution is the next bullet here. So a lot of feedback that we get is, we're very fortunate to have majority of our clients do in-house billing, because it just shows us that the system is capable of that. And again, we take your feedback, we improve. We work with billing companies that give us feedback as well, and we're extremely grateful for that. And we like to have good relationships, of course, with any billers. So we are working with billers directly to ensure that billing is optimized, right? Because at the end of the day, billing is the financial component of survival for every business. So metrics, the flow of how notes turn into revenue is extremely important. So that's your RCM cycle. And with the hybrid billing solution, so I mentioned we have in-house billing. Of course, we have a lot of users with that, and billers that use our software. But there's nothing in between, right? So a lot of our clients are coming to us and say, well, I have a biller who's doing XYZ for me, but they're not doing ABC. Or you have your in-house biller doing XYZ and they're not doing ABC. So one of the features that I shouldn't say features, it's a service that we're going to be offering, is called the hybrid billing solution. This will allow HelloNote to take on some of that heavy lifting and split the responsibility with either your in-house billers or your billers. So for example, you don't want to deal with the actual submitting of claims and posting payments. So HelloNote will actually take over. So we will do the submission for you. We're going to do the posting payments, and we can leave it up to you to, to call rejections or do eligibility or authorizations. So that's why it's called a hybrid billing solution, is because A, we're not going to do everything for you because you might already have a great person or process in place. And B, the cost. right? So one of the big key points here is cost. So a lot of the clients that reached out to us for a service like that, they didn't want to spend a lot of money on it, but they said, you know what, it would be good if you guys offered a service at a reasonable price instead of me having to pay an extra, $500, $1,000 a month for somebody else to do that. So it is a service that we'll be offering. I will actually share a link in a little bit where you can fill out a form and we'll reach out to you to collect information. And every business is different. Okay, so we have clients that are low volume, we have clients that have a lot of volume, so that's why we want to have a conversation to see what you actually need, so we can ensure that we can provide the service that you actually want or need for your business. So next is host a webinar to showcase how to increase revenue and reduce denials. So once we build out all of these automations and everything, we actually want to have a dedicated billing team to do webinars and kind of webinars like this with Q&A, where we can show you tips, tricks, whatever it is that you need to ensure that your workflow is efficient. Because billing does get tedious, right? So there's a lot of things that go into billing, but at the end of the day, it's a lot of it is just the same work over and over again. So if we can automate that, along with reduced denials, I think that would be huge for everybody. And life moves quick, so we want to ensure that you don't spend majority of your day doing billing, and you enjoy your time off with for yourself, for your family, for any other ventures that you have. So that is important. So next on the right, I'll talk about the front desk assistance. So if you have been to APTA, what was it, in October, you would actually see our robot kind of driving around. So we brought this robot to APTA to showcase a new kiosk option that we'll be offering, which is really cool. So the kiosk option will allow you to put a tablet on your front desk, and it's going to automate that front desk kind of package where patients come in, they check in, they sign intake forms, pay bills, even run eligibility. So the goal for front desk assistance is to have something that sits on your front desk, right? And having the patient come in, check themselves in, they can reschedule themselves, they can pay for whatever visits they owe, sign consent forms and things like that. So I think it's going to be a huge opportunity for a lot of business owners as well to kind of delegate what can be automated, okay? Because there's a lot of things that are done right now by a person that can be automated, because then you can free up some time and delegate some more heavier tasks, which would be really nice. So we're going to launch and train staff on the new kiosk mode, of course. So I know this is a big item, and I know a lot of our clients have been asking about that, when it's going to be released. So next year we do plan to release it. The robot, by the way, is not something we'll be offering. It's something that we just got for the conference. If you want to buy your own robot, it's fine, but it's something we just got to showcase how this can work. So we actually have a clinic that has a remote front desk. So they actually use a tablet for when someone comes into the office. So you can actually use the front desk assistance for that as well, which is pretty cool. So templates and scripts for front desk optimization. So again, training will be provided. We're going to customize the front desk assistant for your clinic, because we do work with a lot of clinics that are cash-based only. We deal with a lot of clinics that are insurance reimbursements, and of course hybrid. So not everyone is going to need the same features. So we will work with you and your staff to make sure this is optimized, so patients can come in quickly, sign in, fill out consent forms if they already haven't. Okay, because we do have our online scheduling widget, which is really cool, and they can actually sign and fill out consent forms online before they come to your office. So we're excited to share. We're excited to share the front desk assistance for next year. So next, we're going into our phase 3. So upcoming features rollout. So key operational tools. So one of them is going to be the enhanced waitlist tool. So there's going to be automatic slot fill capability for no-shows. So again, I know a lot of you run busy clinics and you don't have time, or even your schedulers that you hire and work with you don't have time to follow up on every patient that is a no-show or cancellation, and there might be repeat offenders, right? So what we're doing is we're going to build out an automatic slot fill feature. So based on your wait list, if there's a patient that is a no-show, they can fill that, the system, HelloNote, will fill in that slot for them. So the patient will get a notification that a slot opened up without actually having to call that patient. So that's really cool. Next is custom referrals. So train staff on DME and equipment referral management. So right now, as you know, we have a feature called referral request. So we're going to be building on the referral request where you'll be able to add DMEs and equipment. So it's going to change the caption from a referral request to maybe DME request or equipment request, things like that. So that is that's also going to be rolled out. Average reimbursement tracking. So provide dashboards to monitor financial performance. So you may already notice that on our dashboard we do have a KPI tracking. So this was only the kind of the first phase of launching it, where it's more static. So we took feedback from clients, like what KPIs are important, and we put that into the static widget. But for phase 3, for next year, we are going to be able to give you the power to customize it, because not everyone wants the same KPI, right? And I get it, because we run KPIs based on different needs, different business models. So we will be giving you KPIs and average reimbursement tracking based on your needs. Custom case types and notes. So if you are a current client of HelloNote, you know that we use case types a lot. So based on a case type, you can control whether something is Medicare B, Medicare A, self-pay, HMO, Medicaid, PPO, whatever it is. So it works great. There's no issue with it, except for scaling, right? So as you grow, we need the opportunity to grow as well to give you more case types, right? Because there might be case types that you want, custom ones that we just don't have because not everyone needs it. So we will be rolling out a custom case type feature. You'll be able to create your own case type and preload any billing and note rules for those case types. Also custom notes. Custom notes is also something that we've been looking forward to for a long time, where right now we have great note templates out of the box. They work for majority of clinics, but sometimes you want to customize something, right? Sometimes you want a specific note, like whether you're doing lymphedema, hand therapy, home modification. So, there's always something. You might want that extra field or box or date field somewhere in our notes. We used to have actually a customization option for that. The problem with that is it's pricey. Not only for us, it's also pricey, of course, to tell someone, hey, you need to pay for a feature. And it's not something we want to do. Our goal is not to get clients to pay for more features. So what we like to do is do more of a community approach where we build something out and everybody benefits from it. And that's how we've been doing it since the inception. That's our model. So we will be working on custom note templates, and with custom note templates, we will allow kind of a cross-office sharing. So you'll be able to share it with another office, whether it's your office, and if you're okay with it, then you can actually share it to other offices. So we are going to be building a kind of a community of custom notes. So if you built out a nice template for yourself and you're okay to share it with others, then I'm sure every therapist would appreciate that. So and same goes for those other therapists; they can share with you. So we are excited to build out custom note templates. So next is patient-centric enhancements. So again, a lot of features that we want to work on is to enhance more on the patient side, so you don't have to do that, or your staff doesn't have to do that. So appointment reminder confirmations. So this is something that has been requested. Now, I think this year we actually had a lot of requests for that. I don't know why this year we got this request as opposed to starting from last year. But essentially, this will allow patients to click a link within the appointment reminders to confirm or cancel their appointment, which is a great feature. Actually, I have my accountant actually uses this feature, and it's very seamless, right? I get a notification and I click yes to confirm, and then my accountant knows I'm coming. So same thing here. Your patients will get an appointment notification reminder as they normally do, and you can turn on a feature, and this will be optional, by the way. So you can turn on a feature where the patient can click yes to confirm or no to cancel or request a new appointment. Okay, so that is going to be really nice feature. Next is custom intake and consent forms. So this has been a wild ride for us because we really wanted to bring this out already for quite a while, but we're finally nearing the finish line for this. So we do have intake and consent forms that are customizable. However, we do that customization, meaning you send us the forms, we customize it for you, and we load it into the system. Now, if you want to make a change or something like that, it has to go through us currently. So with custom intake and consent forms, you will now be able to design and create your own intake consent forms. And on top of that, we are going to make the fields dynamic, where you can actually select where they preload. So for example, if you're doing an intake forms with patient demographics, and then you're getting to the section that says, let's say, insurance ID number, you can actually map it back into the patient's chart automatically. So right now, when patients fill out intake consent forms, as you know, it uploads a copy of it into the Documents tab, which again works. A lot of clients use it, they're fine with it, but we do want to take it to the next step, which is dynamic, right? Making all the fields mappable so you can select where in the chart this will go. Okay, so I think that will that's going to make a lot of people happy on this, and patients will be happy that they don't have to refill out paperwork because it's going to generate automatically into the chart. Also with credit card capture. So one of the other big components we're going to be adding to this is a credit card field. So you can collect patient credit cards right on the intake form, and once they fill it out, it actually gets preloaded. Just make sure it's in your consent form that you'll be capturing credit cards, of course. But otherwise, it's going to capture all of that and send it right off into the chart. The map feature. The map feature is location-based planning and task management. So if you notice currently, if you're doing the calendar on Hello Node, there's a button that says Show Map. So what it does is it takes the view that you currently have and opens up another window, and it loads a Google map of where your patients are, right? So it plots them out, and it also color codes it for the discipline. So I know a lot of mobile-based practices are very thankful for this feature. And I've been hearing that non-mobile practices are also thankful for it because they could see where their patients are located geographically, and they can make business decisions like opening up another practice, doing more marketing in other areas or within that area. So that is a cool feature. And then front desk assistance. So I mentioned that on the prior one. So it's going to be more seamless for patients to check in and schedule their next appointment. The next is security and AI tools. So note locking. So this feature actually came from HelloNote 1.0. This ensures that your therapists are doing notes on time, and you're going to be able to control a kind of a threshold on how many hours until they cannot do the note anymore. Because, again, as a therapist myself, notes are not always on my, priority list. And I know most therapists agree with that, where they don't do notes on time. But, for billing purposes and running your practice, of course, that is crucial, right? Because if you don't have steady cash flow, then, your business cannot survive. So with note locking, we're going to be able to specify a time limit for when your therapists are allowed to do their notes. And if they exceed that time, then they have to go and more at the administrative level, which I know therapists don't want to do, so they're incentivized to do their notes on time. Next is EVV with GPS tracking. So electronic visit verification is getting a lot more popular. So as much as we don't want that, unfortunately, that is where kind of the industry seems to be heading, especially with Medicaid. I know they launched that. So we do have a lot of practices that do Medicaid, and they need EVV to be compliant with Medicaid. So as you know, if you're a client, we do have the patient signature module for every single case. So you can collect patient signature, but we don't have a GPS component, meaning it doesn't track your geographical location. So we will be launching a feature with GPS tracking to give you full EVV kind of compliance if you need it. So that is something coming as well. Next is AI note tools, intelligent assistance for faster error-free documentation. So again, with AI, there's so much, I also think over the next few years, things will get AI will get more, better, stronger because it just learns based on itself and the data that it's given. So we will be implementing more AI tools. And I did mention that we're going to be launching a feature that tells therapists how similar their note is to the last note, okay? Because it is crucial for notes to be different, right? Because you don't want to have the same exact note session to session. So it will give a therapist an alert on that. Next, financial systems, emailable statements with auto send. So this is actually really, really cool because we didn't have an option for emailable statements. So if you wanted to print a statement, it would have to be a PDF, and then you can do whatever you need with it, either print it, mail it, show it to the patient, whatever you need to do. So with HIPAA compliance, we always have to be careful. We want to ensure we're compliant so this way we can provide the maximum security and compliance for you. So we are building out an emailable statement option, which will allow patients to get an email with a secure link, and they're going to have to verify, of course, their identity, and it's going to show them the statement. So I'm excited about that. And on top of that, it's going to automate sending the patient receipt. Invoice and receipt. So for example, if they didn't pay their bill or something like that, you can set up a threshold where when does it send to the patient a reminder? So do you want it to send after 2 days, 3 days, 7 days? It's going to be your call. We're going to have a customization for that. Next is automatic ERA posting. So I know a lot of you have been asking about that, and I can finally let everyone know that we do have this up and running. So we had to build out a few key details, and we are doing more for this, but we do have it up and running. So if you want this, or if you already reached out about it, we'll reach out to you. So you don't have to reach out again. But if you have not reached out about it, please reach out. And the reason it's important is because we need you to know that we activated this for you, because we don't want double posting, right? So if we're going to enable this feature, that means you no longer will have to go into the clearinghouse, download the ERA, and import it back to HelloNote. It will automatically take the ERA from the clearinghouse, put it into HelloNote, and then it'll be up to you to post your payment, okay? So that's also huge news, because I know a lot of people were waiting for that, and we're finally excited to launch that. Next is prompt paid discount, to incentivize timely payments. So we are building out more tools for these discounts, including super bills. So when you print out a super bill, it's going to have an additional line items with what the patient pays. So this way they can be compliant with getting reimbursed from the insurance. All right, next slide. Let's see. So phase 4, advanced analytics and customization. So patient status board with dragging. So with this feature, we have a patient status filter that I know a lot of you are using. So you can run reports based on different patient statuses, right? So you can create your own statuses. You can see which patients are active, inactive, on home health, whatever it is, on Part A, whatever the case is. It's all customizable. And there is a report for that. So we actually have a new feature coming out that's going to allow you to visually see a board with a vertical view of where your patients' statuses are, and you can drag and drop as you need. So I'm actually very excited about that because I use something similar for kind of different components of tracking. I use other softwares for that. So bringing that into HelloNote for patient tracking, I think will be awesome for a lot of you, just to ensure that you know which status your patient is on, and you can easily move the statuses from one column to another. So that's really cool. Static event categories with default colors. So with this, we're always trying to improve our schedule. And if you know, you've been with us from 1.0 to 2.0, you know how much more of the schedule kind of features we rolled out. And again, this is thanks to all the feedback that we've been getting, because it's not easy catering to every single client's needs, right? And it's our job to listen to that feedback and build something that works for everybody. So extremely grateful on that feedback. And one of that is more like color coordination. So with static events, we already have the feature where you can predefine categories. So you're also going to be able to customize the colors, which is going to be really, really nice. You don't have to remember which colors go for which category. Next is adding and removing new users. So also something that's been on our roadmap for a long time. And I can finally say that we are almost done with this. So I actually think quarter one, we actually will be releasing this. Hopefully January, I should say, you will be able to add and remove your own users without having to reach out to HelloNote. So I'm excited about that. I know our support team is excited for that. And I know you are excited about that because you don't want to reach out every time you want to add a new user or remove a user. So you will be able to add your own users, remove them as you need. Next is customizable dashboard. So we spoke about this before. So we are working to give you the power to create a dashboard that works for you. Okay, so I know everyone wants something different, and we have a ton of reports in the system already. So we are going to be working on little widgets that you can create from the report into a widget. So if you want to see how many cancellation notes there were in the last 7 days, you can drag a widget for that. If you want to see what's your top insurance payer in the last month, you'll be able to drag a widget. So we're working on full customization of the dashboard. To me, this is one of the most powerful things because running reports takes time, right? As many reports as we do have and as important report running as it is, we do want to take it to the next step by giving you the power to see all your reports that you want in one area as opposed to running them individually. Now, again, this doesn't mean you're not going to run your reports. It just means you're going to have a shortcut to kind of have a bird's eye view of what's important. KPI dashboard. So that ties in with a customizable dashboard. So you'll be able to place on top of reports. You'll be able to place any KPIs that you want as well. And we're always listening to feedback because KPIs vary so much from different offices. So I do want to make sure that we give you the opportunity to create your own KPI dashboard. So if you have any feedback on KPIs of what you want to see, just let us know so we make sure that that is available. All right, and then for phase 5, ongoing support and feedback. So that's always going to be something on our priority and making sure that we look.
All right. So guys, that is you call this, that's Steve from HelloNote. And if you have any question for Steve, definitely please connect with him, and then we can going to provide his email and the link later, okay? All right. Thank you so much, Steve. Let me see. We have now Dr. Mike, and then he's on the attendees, and I will going to put him first. All right, so let me introduce Doc Mike and then let me share here first. All right, I hope you see my screen. So Dr. Michael Chua, he's a physical therapist and doctor of physical therapy, certified dementia practitioner, and also instructor. And then he has lots of certification, but majority of his niche is dementia. So if you have any questions, any books, he's an author as well. And if you have anything that you want to learn more, definitely connect with him. He's based in Tennessee, all right? So Dr. Michael Chua is a doctor of physical therapy and owns a Jerry Hab Physical Therapy and Wellness. It is a multi-site clinic specializing in geriatric care. As an APTA certified clinical instructor and an ANASM senior fitness specialist, he is also a dementia practitioner. That's a national level and certified dementia practitioner. He brings extensive expertise to his practice. He is a moderator for Alternative Careers for Rehab Professional. It has more than 18,000 plus members. Dr. Chua helps rehab specialists explore innovative career paths. He also leads an Alzheimer's and dementia support group, providing resources and strategies for caregivers. He is an accomplished author. Dr. Chua has written several books, including Misunderstanding Dementia and 365 Daily Tips for Dementia Caregivers, and his work focuses on cutting-edge therapy, mentorship, and caregiver support. That's what I've said. Connect with him. If you have any questions, you want to learn more about your niche and how to proceed, all right? And this is Dr. Mike Chua's information and email and website. All right. So welcome, Doc Mike. And Doc will be our closing for our Innovator Summit. So now we are closing with an amazing host and speaker.
All right. Well, if you are watching live, comment, watching on the replay, comment replay. And for those people who are still here, go in the chat box, type in there that you are still awake and alive because we want you to be alive. So, well, anyway, I can't follow Steve, right? Steve is amazing. You know what? Well, you know why I played that? Apata, apata. Is that how you?
You didn't get that.
My daughter. You're wearing that, Dad. Okay, let's do it again.
Not APT.
Well, anyway, again, thank you very much for letting me join your amazing event, Jenny. Give her a round of applause, ladies and gentlemen. Type in, I learned a lot. Me too. I've been listening behind the scenes. So we're just gonna be closing this because we want you to take action, ladies and gentlemen. How do you become an innovator? Jenny and the team and the rest of the people who presented here, like I know Helena, I know of course Steve, the rest, Ian, Mike, Ed, they're innovators. And how does one become an innovator? Okay, how do you become an innovator? By the root word itself, you innovate. If you're a therapist, if you're typing your discipline there, if you're a PT or OT or a spit. I'm running out of English. Yeah, it's Saturday, Jenny. Stop doing it in a Saturday. We run out of English. Speech therapist, speech therapist. Type in there what is your discipline. If you're a student, a PT, an OT, or a student, type in there. Hello, everyone. Hey, Risa. Hey, Anak. So type in there. What is your discipline there? Because this is how you're gonna be able to innovate. All right. Now I have to share the screen. So we're not gonna be talking about all this stuff here, all the crazy stuff, but we're just gonna summarize in essence what we were supposed to do. I'm not gonna share that video again. Let me go this one here. All right, share the screen. How do I share this, Jen? Let me log out. Click share. I was able to share the thing, right? Okay, there you go. All right, see that? All right, how to be an innovator. How do you become an innovator? You become a mentor. You are mentor. All the speakers that spoke here, is that how you say it? Spoke? Are mentors. Before they become innovator, they become a mentor. And what kind of mentors can they be? Remember when you were in school, you get attracted to the teacher who was very, very good, who teaches you well and mentors you, right? So that's what we're gonna be today. We're gonna be doing today. So you could implement all of this stuff. So how do I put this down, Jen? There you go. I'm gonna keep going. So you want to be a mentor. So this is me. This letters behind my name is not to impress you, ladies and gentlemen, but to impress upon you that if I can do it, you guys can do it too. All right. I see those messages now. People from OT from Long Island, PT in California. Shout out OT from New Jersey. Oh, Philippines in Saudi. PT from Philippines. There you go. You want to be a mentor. Let me go back to our slide here. These letters behind my name is not to impress you, but to impress upon you that if I can do it, a little Filipino guy can do it, you guys can do it too. All right. It doesn't have to be complicated. All you need to do is do the first step. You don't need to get all of the program that Jenny was offering here. Just get one there, and then you'll be fine. Okay. So you got to do the mentor method, mentor. You start with the letter M. Okay. So, well, a little bit about me. We run a staffing agency where we staff different agencies. We also run an outpatient clinic. We have several outpatient clinic locations. I used to be a medical rep. I always make a joke. I sold drugs for a living, right? So who sold drugs here, right? So I sold drugs, blood pressure pill and everything. And we run a podcast. And of course, I'm a father to my kids, and of course to my beautiful wife, a husband to my beautiful wife, right? So we run all this group, the alternative careers, the Alzheimer's group, but like what I said, you have to find that specific niche, just one of the many stuff that they were talking about. Okay. So let's go. Why do we do this? We do this for our family, right? I don't go out and speak just for free, right? I don't go out and start a business just for free. We do it for our family. Second, we do it to leave a legacy. Me and my wife, we were talking about yesterday. We were talking about last night. Where were we last night? I think. Oh, no, me and my wife, we went out and eat Vietnamese pho, and then I said, you know what? I really wish my dad and my mom kept their businesses back home. They could have left a legacy, and this is why we do this too. We do this so we could leave a legacy, not just for our family, not just for our kids. Yes, we raise our kids well. We mentor them, we take care of them, we give them the nice, good moral and conduct. We teach them the right way how to go live life. But you also want to leave a legacy, not just for your family, but also for your community. When you start being an innovator, like what Jenny's doing, like Steven's doing, Helena is doing, you actually leave a legacy. All right. And how do you leave a legacy? You become a mentor. You don't have to mentor thousands of people. You start with one person. Start with one, you know, start with yourself first. How can you teach other people if you can even mentor yourself? Start with yourself. Okay. So we do this for our dogs because they eat a lot of dog food, right? And of course, my kids, they eat a lot. So this next slide here, I was just gonna show this to you. And I always show this when I present all my lectures. This is back home in the Philippines. Everybody looks the same, right? We all look the same. We wear the same uniform. We have the same black hair, but you got to be different. Anybody here who can find where I'm at? Anybody here who can find me where I'm at? Type in there, in the chat box. No, you're all asleep and everything. Shout out, Leonora. I bet you can't find me there, right? But if you go closely, I'm running out of English. If you go deep on this picture, you'll find me on the upper left-hand corner. I don't know if you see my mouse, but upper left-hand corner, that's me over there. I'm wearing a wig. I'm wearing a shades. One of my best friend here, Jason, we're wearing a shades, sunglasses, because we knew deep inside that our future is bright. Sounds cheesy, right? But yeah, you got to be different. You can't just be a wandering generality. You need to be a meaningful specific. Jenny said the one with the wig. Yeah, thank you, Jenny, for pointing that out. You can't just be a regular therapist. You can't just be a regular student. You can't just be a regular therapist. You have to differentiate yourself. And this is what the rest of the speakers are doing. They're differentiating themselves. Helena, she did vertigo. Dr. Mike, the guy, he's talking about cognition, neuroplasticity. Ian, he talked about low frequency vibration, and so on and so forth. They had that specific niche deep inside themselves. And that way they could differentiate themselves. You got to find that. You got to find that. So in the chat box, type in what is that specific niche that you're wanting to serve? What is it? Type in the chat box, I want to serve geriatrics. Or what kind of, geriatric you want to serve? You want to serve Parkinson's disease, stroke, dementia. Me, I do geriatric because our clinic is called geriatric rehab, right? But we mainly specifically market ourselves Alzheimer's and dementia. But do we just treat Alzheimer's and dementia? No, we treat most of the geriatrics. Well, guess what? We also have pediatric cases. We have a division called Kids Hab, where we serve early intervention. So you have to find that specific niche first, then you go from there. Okay. So Jenny, how many minutes do I have? 5 minutes. All right. So
Good.
this is what I want you to be. I'm sorry, Jen, you say something?
Yeah, 10, 15, that's okay. Yeah.
10, 15. Okay. So this is what we're going to be doing. I want you to go the mentor method, the MENTOR. Letter M is meet a need in your community. All right. Meet a niche. So what kind of niche are you wanting to serve? Steve, did the EMR. Jenny's doing this. I'm doing geriatric. So type in the chat box, what do you want to be? What kind of business, what kind of practice you want to start, what kind of specialty you want to serve. Because you just can't be a simple, Lisa said dementia. You can't just be what you call this, a generalist. Even in the medical world, I mean, there's nothing wrong being a general practitioner, but in the medical world, if you have a heart problem, do you go to a general practitioner? Yeah, initially, but you go to a cardiologist, right? If you have a money problem, you don't go to you go to your wife, right? But if you have a urinary problem, yeah, you go to a urologist. And same thing in therapy. If you have a back problem, go to that therapist who really knows about back issues. And same thing with Alzheimer's and dementia. Risa is focusing on that. So make sure you have that specific niche. Okay. Next letter is letter E. Once you identified that niche, you educate them. Educate the people. Go out in your community. That's what I did. Oh, I'm seeing geriatric people. Hey, I'm going to educate. I started speaking. I started going. I started creating class. I started adding value. How do you add value? Create a podcast. Interview people. Interview your own clients. That's what I did. That's what I do. I still interview people. We have what you call senior moments where I interview our patients, of course, get the proper consent form and everything, but go ahead, interview them. Whether you have one person or 1 million person in front of you, you just show up, keep podcasting or YouTubing or whatever you call. And here we are. We got 1,000 people in YouTube or Facebook or TikTok. They don't even have the experience or education that we have, and they're eating us alive. And here we are. We're like, oh, I don't think I can do it. No, we can do it. You guys can do it. Start educating them. Okay. Adding value. Next is letter N. Start networking. Why do you think Jenny's doing this? Right? Why do you think she's doing this? Just because she wants, influence? Yeah, to be in an influence? No, this is for networking. You know what Jenny did to me? She sent me a message. Hey, Dr. Mike, I think that, whatever you call that, Jen, that proprioception device is good for your geriatric clinic. I said, yeah, why not? Send them to me. Stuff like that. It's a networking opportunity. Right over here, type in where you're at, your discipline, and where you live. That's the reason why I ask you all the time, when I'm on video, that way you guys can connect, talking to each other. Oh, I see somebody from Maryland. I'm going to connect with them too. Instead of competing, you collaborate. You collaborate. Shalu said that would like to set up OT cash-based practice for scar management. Oh gosh, that's a needed service. You do that, sister. All right, you do that. ANS regulation. I don't know if you know about what you call this, the parasympathetic. I'm sure you know it. We use the direct current device for our scar management. No, network. Next is letter T is team of winners. You got to find that team of people that will bring out the best in you because you are the average of the 5 people you hang out with. Whoever you hang out with, that's going to be you. Do you think our clinics will run without an amazing team? All right. Do you think I'll still have to answer the phone call? Do you think I still have to do the billing? Do you think I still have to treat after I did the evaluation? You know what? I don't even see patients in our other clinics. I only go to our main big clinic to help and support there. We got to find those team of winners that will believe in you, that will support you, you know, that will bring out the best in you. Even your own family, when you're looking for your better half, your spouse or your partner in life, you got to find someone who will believe in you, not the one that will pull you down. It's very important that you have that. And you got to find that team of people. Next is one-on-one coaching, letter O. You got to find that one-on-one coach that will bring out the best in you because you cannot teach other people of your specific niche that you're wanting to serve if you yourself is uncoachable. This is where being coachable is important. Mike Jordan, LeBron James, Stephen Curry, yes, they are superstars like you, but the only way for them to be able to reach their next level and championship level and reach that level of being the world champions or whatever you want to call that is they're coachable. Are their coach better than them? Heck no. I mean, Stephen Curry shoots the ball amazingly, but his coaches are definitely not better than him, but they're coachable. All right. So be coachable in order for you to be able to share this innovation that you want to share. All right. And last but not least is repeat or recurring revenue. You can find a niche, you can educate people, you can create a podcast, a YouTube channel, a TikTok video and dance. You can network with 100 people or 1,000 people. You can find a team of winners. You can even have a coach and blame that coach for not being successful. But if you don't know how to repeat this process and find the recurring revenue, you're going to have a hard time succeeding this. That's why a lot of people, gets upset from getting a coach because they can't find this recurring revenue. You got to find this recurring revenue, whether you call it passive income or somebody treating for you. You got to find that recurring revenue. All right. So again, that is my short spiel and education for you today. I know it's a very quick one. Shannon said I have a cash-based model. There you go. Boom. See, she left her acute job after April 18th. So congratulations, Shana. Let me go back here. So you got to make sure to be a mentor, all right, in order for you to start innovating in this crazy field that we have. It's changing. The only thing that is permanent in this world is change. And in order for us to be able to be successful and innovate in this life, is you got to innovate and be a mentor and learn how to be mentored. Okay. But before I let you go, before Jenny closes this too, I want you to remember the word fast, FAST, letter F. Find people that will bring out the best in you. I already told you this earlier because you are the average of the 5 people you hang out with. Because whoever you're hang out with, that's going to be you. Hang out with those people that will bring out the best in you. Next letter is letter A, take action. All this stuff that we're doing, Jenny's doing, Steve, Helena's doing, it's not going to do us good. It's not even going to do you good or us good if you don't take action. Take action, go to their website, talk to them. I think I want to be the balanced person. I want to be the vestibular expert. I want to learn more about Hello Note. I want to learn more about Jenny. I want to learn more about Eliza. I want to learn more about somebody here. Take action. Reach out to them. It doesn't have to be perfect, all right? Imperfect action beats perfect in action. Reach out to them. Next letter is learning how to shoot for the moon. Why? If you keep shooting for the moon, you're going to miss it. But when you miss it, you're going to be landing with the stars. Today, I kept shooting for the moon. I landed with a star named Dr. Jenny Youssef. Keep shooting for the moon, ladies and gentlemen. You're going to fail. I'm going to tell you now, you're going to fail. People will reject you. People will make fun of your accent. People make fun of how tall you are. People will make fun of your dreams. But when you share your dreams, make sure you plant it in a good soil. All right, plant it in a good soil. Don't just share your dreams to random people. Right? Share it to the people who will believe in you. Share it to the people that you know that you're planting it, that it's going to water it. Don't even share it to your family member who will just shoot it down, because family members, they will shoot down your dream. They will tell you, "Oh, don't start your business. Don't do this. It's not stable. It's not good, blah blah." No, you know, we got to make sure you plant it in a good seed. So shooting for the moon, you're going to fail, but there's this I don't know, the Japanese proverb or whatever, fall 7 times, stand up 8. Keep standing. Keep falling, but keep standing. And last but not least, in the word fastest letter T is teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, that's how you become an innovator. That's how you become an amazing person. You keep teaching it, and that's what Helene is doing. That's what Steve is doing. That was Ian is doing. That was Jenny's doing. They keep on teaching it, and they become this amazing innovator. All right. Again, thank you very much. We appreciate you. Be awesome. Be great. Be excellent. And we'll see you in the next Innovator Summit 2025. Jenny, take over.
Thank you so much, Doc Mike. That's really amazing. Thank you for closing. So, guys, I really appreciate all your time and staying. This is an amazing one-day event. And definitely, if you find value in our event today, I would love you to connect and join us in you can donate in the Future Foundation. It is a nonprofit organization, and you can have a certificate of attendance. All right, so this is the one you can definitely donate. Let me show something. All right, thank you. All right, here. Okay, so I am a treasurer, that's why. Let me see. What can I do here? All right, so here is, yeah, so this is the Future Foundation Global. It is a nonprofit organization which have the expertise and dedication of Filipino PTs globally to uplift the profession and health outcomes. So our mission is that it fosters and focuses the resources of the global Filipino diaspora to better improve the health of the Filipino people, to serve both locally and globally. And our vision is that it is that will foster, someone was saying, we have a mistake on that. But definitely we have a goal that we help physical therapists. We even have a project that we're able to sponsor one student at a time for a doctor of physical therapy. So if you find value in this event, definitely please donate, and it will go straight to them. It is a nonprofit organization. And if you're based here in US, definitely that can be tax refund. Just connect with me. If you donate something, definitely we will give you a certificate of attendance. Any amount will do, at least $10. That way it will go a long way. So if you find value in this event, definitely this is this will really help them. Okay, so you can join us and then also connect with us with that. I appreciate you guys. So if ever you have any questions, definitely we have all the chat. I put my email. You're welcome, Rachel. I put my email there. And then join us in the Balance and Fall support group in Aging Adults. And yes. All right. So let me check. David has a question. Did you raise your hand, David? Yes, yes. So on my email, definitely just connect, and then we will going to provide you. So certificate of attendance is by request, and then it's $10. You can donate it exactly straight to Future Foundation. And then if you donate something, just email me, and then, hi, Dr. Jenny, I donated something. I would love to have a certificate of attendance. And definitely we can email it in you, all right? Hi, David, go ahead. I think you have question. Yeah, because I'm a board of trustees and a treasurer. So I am doing some of these events so that we can do something. All right. Yes. where we will find the recording. Yes, recording will be emailed. Once we all process all of this recording, we will definitely email you. And we already have your email because you already registered, right? And that's how I able to follow you guys. Yes, we will email it to you, most probably anytime this coming week. Okay, and we will put all the resources of the amazing speakers, and then you can connect with them with all your questions because I will put on the side their information. And we also have, I asked them also I asked them also to put their different resources like contact information, the PowerPoint as well. They will going to give us some PowerPoint, right? Because it's really nice to just watch and listen. You don't need to take notes, but they will provide their PowerPoint. Guys, I really appreciate you on the email that we will provide. Definitely, we can put the Future Foundation email or the QR code that we just showed. If you watch the replay, just go all the way back and take a picture and you will see the QR code. All right. Thanks so much, Joan. Thank you so much, Leonora. And email me for that. That way I know that you already donated or you're planning to donate. That way we can make your certificate of attendance. Appreciate you guys. And definitely maybe I can connect with you again and wait for my emails. We have different courses coming up, sometimes resources. I'm on financial education as well because some physical therapists are looking forward with that. What are the different long-term care that we can offer for our patients, and just like a tax more on savings and tips, okay? And maybe that's a good help because we are a group of nurses and therapists nowadays that learning more about financial tips and learning. And good luck, guys. I appreciate you. Thank you and good night. All right.